Welcome, everyone, to the 44th Annual Howard Rosen Memorial Tri-State Trauma Symposium. I'm here today with my co-host, Dr. Meelan Patel. We both welcome you to what is sure to be a riveting trauma symposium. We're going to be going through the full gamut of upper extremity and lower extremity topics. And I'm sure you guys will hopefully pick up a lot. We have a couple of housekeeping items before we get started. The first thing is, if you are logged into the NYU CME app, we do recommend that you use that. It's going to be the easiest way to interact with us. You can make sure to claim your CME credits through the app. Question and answers will be done through the Slido webpage, which can be accessed through the NYU CME app. Audience members will not be able to ask questions out loud, so if you have questions, you will need to submit them through the Slido app. The moderators will be able to voice your questions or comments. So please, again, we would like this to be interactive, and especially for all the residents out there, your OITs are coming up. It'll be a great way to pick the brains of a lot of your attendings. So what I'm going to do now is we're going to turn it over to Dr. Kenneth Egol. Dr. Egol is going to give a brief intro on the namesake of the symposium, Dr. Howard Rosen.
So welcome, everybody. And as Dr. Konda mentioned, this is the 44th year that our department is hosting this educational event. And it's really the work of, from the work of Dr. Howard Rosen. And just a brief word about who Howard Rosen was, because we're getting to the point where I think many of the people in our department, the residents, the young faculty, and many of the people practicing in our community don't really know who Howard was. So Howard Rosen was a New York City son, born and bred. He was born in 1925. He actually graduated high school in 1941 at the age of 16. He then went on to the NYU College of Arts and Sciences, where he graduated in 3 years, and then finished medical school in 1947. So he was about 23 years old when he finished and went into residency. He came to the Hospital for Joint Diseases in 1948 as an intern, did a surgical residency there, and then did his orthopedic training, and went into practice in 1953. And from 1953 until 2001, he had an uninterrupted 53-year association with the Hospital for Joint Diseases. And really, he was a private practice orthopedic surgeon in Manhattan. And the thing that changed his life was in 1960. He had an uncle, as the story goes, who sustained a humerus fracture and went on to non-union and was being treated in various casts and brace. And there was talk about doing some type of onlay bone graft. And they didn't really know what to do with him. He was very symptomatic, and all the guy wanted to do was play golf. And Howard met a young orthopedic surgeon from Switzerland named Maurice Mueller that year at the Seacoat conference at the Plaza Hotel. And Mueller had a presentation about his magic plate and screws that could heal bones. And Howard discussed the case with him, and Mueller said, well, if your uncle comes to Switzerland, I can fix him and he'll be back to playing golf in a couple of weeks. So as the story goes, his uncle went, got fixed by Mueller, the non-union healed, and the rest was history. Howard was sold on the techniques, and he was really the first American surgeon to travel over to Europe to learn the techniques of the AO regarding fracture fixation, plates and screws, and so forth. In fact, Howard brought back the first set of AO instrumentation, the first sets of plates and screws, drills, and such in his luggage. And, he became very well known around New York as the guy who could fix problem fractures. He was the chief of the quote unquote problem trauma service at the Hospital for Joint Diseases. He was an AO faculty member and was there at the inception of all the AO courses, and was well known as a gifted educator. He was also a humanitarian and volunteered his services around the world in teaching underserved countries the techniques of the AO. He was a gifted surgeon, not a very fast surgeon. He was known for his handlebar mustache. He started this course 44 years ago as an all-day Saturday trauma event. It was actually called the Trauma Day course, and it was funded by a grant from the AO. And again, think about this was way before the advent of all of these courses and meetings and such. So he was this actually predated the Orthopedic Trauma Association. So he was very much into education. He was a very funny guy. And here's some video of Howard as a table instructor at an AO course in his older age. And in fact, he was such a tremendous educator that after his death, the AO named the award for the best table instructor at the meeting the Howard Rosen Table Instructor Educator Award. He was a very, very, very lovely guy, but he could talk. And when you were a resident, we used to, back in the day before computers, we had all the x-rays up on the boards, up in radiology, and you'd be putting the x-rays up there and in the middle of the night to get things ready for the next day. And he'd come by about 10 o'clock at night. And if he ever saw you in the x-ray room, you couldn't get out of there. He'd spend about 2 hours with you, teaching you, talking to you about all the different x-rays and what it meant. And he had a tremendous heart, and he was respected and loved by many. Unfortunately, he passed away at age 75 in 2001 after a long battle with cancer. And he is remembered today as a leader, an educator, a master surgeon, and a great colleague. It is a pleasure to keep his memory alive in this manner. We have several things that we do yearly that help us remember his legacy. And everything that we do at the NYU Langone Orthopedic Hospital and our trauma service throughout New York really could not be done without Howard having come first. So with that, I'm going to turn it back to Dr. Konda, and hope everybody enjoys the meeting.
Thank you, Dr. Egol. Wonderful presentation. It's great for everyone to get a better understanding of Howard Rosen. So now we're going to move on with our symposia. I'm going to pass it along to our first moderator, Dr. Toni McLaurin. Toni, you want to take it away?
Good morning, everyone. I want to welcome you all to our Howard Rosen Symposium here. And the first part of this is going to be upper extremity, and we'll start with Dr. Ganta on clavicle fractures, dual versus single plating.
So we're going to talk about dual versus single plating. So over the last couple of years, dual plating with mini fragment or low profile plates has really taken a bit of a popularity. And I wanted to kind of go over not only the pros and cons of it, but also some of the technical tricks and tips associated with it. Let's see, perfect. Just a brief overview, clavicle fractures, and when we see this for essentially all trauma fractures, so you have high energy and low energy fractures. It can be from a low energy fall in osteoporotic patients or high energy in motor vehicle accidents, pedestrian stroke. But the one thing that's striking about clavicle fractures is that you have so much muscle attachment to it, and the resulting deforming forces can make displacement, and as a result, difficulty with healing and non-union an issue. You have to be wary in these fractures as well. A lot of the patients have associated rib fractures, shoulder girdle injuries, clavicle fractures that are completely gapped apart. You have to worry about a floating shoulder. People have pneumothoraces and scapular fractures. And, while these associated injuries are not necessarily absolute indications for fixation of clavicle fractures, they can kind of weigh into the surgical decision-making on whether or not, clavicle fracture needs surgery. So we kind of, going over the non-operative risk and the operative management of these is a little out of the scope of this lecture, but, we do have a lot of studies, especially high-quality randomized control trials, talking about the rate of non-union in patients, the benefit of clavicle plating and clavicle fixation in patients with concomitant chest injuries, such as pneumothoraces and rib fractures, There's a benefit in fixing these in polytrauma patients to allow them to mobilize a little bit quicker. Ultimately, when it comes down to it too, in very skinny patients, we talk about the deformity of the healing. So if a patient heals in a non-operative management, it can be left with a large callus, which can be to them a cosmetic issue. Alternatively, when you fix it, you are left with a scar. So there's a pros and cons when you talk to the patient about whether or not they need their clavicle fixed. But this patient, for instance, was someone that just came in a couple of weeks ago. This is actually to me is real skin tenting. He had blanching of the skin. And so for me, this was a no-brainer that this patient had to go to the OR to get his clavicle repaired. So when we have surgical treatment options, it's very variable. You have intramedullary fixation, superior plating, anterior inferior plating, and now more recently popular is dual plating. So let's talk about superior versus anterior inferior plating. Anterior inferior plating, relative to superior clavicle plating, there's a lot of randomized control trials. Ultimately, both options actually do very well. They have a high rate of healing, but there are issues with clavicle and hardware prominence and superior plating. There are studies that show that anterior inferior plating can sometimes decrease the rate of not only hardware prominence, but also subsequent removal of the hardware, which can happen if the plate is not only irritating, but also very prominent and makes clothing wear difficult. So if you just look at this is a meta-analysis that I kind of pulled up, and it takes a ton of papers that have been published from 2011 to 2015, 2016. And you can see anywhere from the red is superior plating and the blue is anterior inferior plating. And you can see that the rates of hardware, this is just prominence itself. Okay, so prominence does not necessarily necessitate hardware removal, but it can be an issue to the patient. That there is a higher risk of this with just pure superior plating with a pre-contoured plate. And if you look at inferior plating, anterior inferior plating, it's slightly less. But if you're looking at the numbers, it's anywhere from 15 to 20%. Okay, which to me seems relatively high. Now we take a step further, okay, and then we talk about the rate of implant removal. So a portion of these patients need their hardware to be removed, and that can range anywhere from the same percentage, so 10 to 15%, and to sometimes even higher depending on the paper you're studying. And if you look at the financial implication of hardware removal, so this paper talks about not only non-operative management, but also operative management. But it shows that non-operative management is the cheapest option, even if you include subsequent requiring revision or subsequent non-union repair. But the average cost of operative management is, let's say, $14,700. And then if you add on a subsequent hardware removal, it adds even more cost. So there is a financial implication of having prominent hardware or hardware irritation at the side of clavicle fixation. So I just want to briefly touch over the dual plating with using mini fragment plates. So this is a patient that's 20 years old, was a bicyclist that was struck, and she sustained a kind of a mid-shaft to distal third clavicle fracture with a Z-type deformity. I talked to the patient about operative versus non-operative management, discussed the rate of non-union, et cetera, and we decided to move forward with operative repair. So the way I position my patient can be done anyway, but I prefer to use kind of a diving board or a radiolucent table, and I kind of give a little bit of 30 degrees of head up or trendelenburg. You can do it on a Jackson flat table. You can do it on a beach chair. So whatever is is up to your comfort. And once you make your approach, you want to. There's a lot of different ways to use it, but the way that I use it is I use a 2-7 recon plate. So this plate is very malleable and it's very thin. And then the challenging part of this is to match the plate contour to the anatomy of the clavicle, which is dependent on every single person. So even with pre-contoured plates, you may have to do a little bit of fine adjusting as well. But for this, you have to spend a little bit of extra time once you get your fracture reduced to contour the plate to make sure that it matches the basically the shape of the clavicle. Once you get that plate secured, you want to make sure that you check on fluoroscopy to make sure that even if you're looking at it directly, it can sometimes be a little bit tricky. So you want to make sure that the plate is contoured appropriately on fluoroscopy. And while you're doing live screw fixation for these, you want to make sure you're keeping as much soft tissue attachment as possible. You can get to a point where you start removing more and more soft tissue, then you're left with a non-viable fragment of bone. So once you have that plate secured, then I use a 2-4 DC plate And this is the same thing, is plays basically contours the anterior surface of the clavicle. And again, just like the last one, you want to spend a little bit extra time to making sure the contour is close to as perfect as possible. Takes a little bit of futzing around. And then following that, I add anywhere between 2 to 3 points of fixation on each side of the fracture with this. And then you're kind of left with this construct. Okay, so I got, more of an axial view, pure view on boss with the clavicle. And you can see that, you try to do your best to minimize as much soft tissue disruption at the fracture site as possible. So let's talk about what is a benefit of dual plate mini fragment fixation. Because, as this gains popularity, yes, it looks pretty cool, but we have to really decide whether or not this is really beneficial to the patient. Let's talk about, first of all, the rigidity and the stiffness of the fracture construct. So, using small plates, it is a diaphyseal bone. You want to make sure that you have, appropriate amount of fixation on both sides, and that, as the clavicle sees more and more force during the patient's postoperative therapy, that you're not really applying too much of a bending moment on this. And then the plates can fail. But if you look at the biomechanical studies, it shows that between axial stiffness, torsional stiffness, the dual plating is about just as good as anterior and superior plating with pre-contoured plates. So from a biomechanical standpoint, it tends to be relatively equivalent. And this study done out of Stanford showed that the rate of hardware irritation is relatively low, as well as implant removal. It looks kind of similar to the other studies. 10% seems really high, but this is a study out of 30-something patients, so about 2 or 3 only required implant removal. And if you look at this study done out of Houston, which showed kind of similar results, they showed that patients with dual plate mini fragment fixation required way less hardware removal. It was around 3% in their cohort, and they used kind of a relative similar construct as mine. And if you look at that compared to the other studies that they kind of compared it to, it shows that the implant removal rate was potentially even higher. So in conclusion, the benefit of this to me is, especially in a very skinny patient, there's decreased rate of not only symptomatic hardware irritation, but also decreased rate of symptomatic hardware removal. You are using 2 plates, and it is not, these plates are not cheap. There is definitely an unclear cost benefit. There's no studies that have really shown if there's a cost benefit in using this. And I will say that from my experience, it's been challenging to use in comminuted fractures where you don't have a good length and no cortical keys to really determine what the true length of the clavicle is. I think patients with these type of injuries to me is a little bit easier to use a pre-contoured plate. And yes, you are adding more hardware. And so there's a potential increase in the procedure length, especially when you have to spend extra time making sure the plate is contoured perfectly to the superior and the anterior aspect of the clavicle. All right, thank you.
All right, thank you for that, Dr. Ganta. And I'm happy to see there's some questions coming in through the Slido. So we'll have a question and answer once we finish up with this section. So let's move on to our next speaker. Will be, sorry about that, Dr. Sanjit Konda. Yes. Slides coming up. And he will be
speaking. Slides coming up right now.
Okay. No, proximal humerus fractures. Nail versus plate.
You can see the slides?
Yes.
All right, great. All right, everyone, thank you. And Abhi, great talk. So I'll be moving down the upper extremity, talking about the proximal humerus. My topic today is going to be, should we be nailing or plating these? Now, first thing we want to make sure that everyone understands is the vast majority of proximal humerus fractures, probably up to 90-95% of proximal humerus fractures, can be treated non-operatively. Well, really what we're talking about are those proximal humerus fractures that we do think meet indications for surgical fixation. And what is the best option? Historically, in the United States, at least, we have been trained and to fix proximal humerus fractures with plates. But if you look at the rest of the world, and I mean by the rest of the world, particularly Europe and Asia, and in Asia, Japan and China, over there, probably more than 50% of proximal humerus fractures, when they are fixed with intramendibular nail devices. So a lot of the literature with modern locking nails are coming from that area of the world. But I don't think here in the United States we're as familiar with them. So what I think is the best way to go about tackling this question, should we be nailing or plating this, is to really go into the literature and see what it says. When we go into the literature, one of the things that we're looking at is, intraoperative parameters we need to compare. We need to compare functional outcomes between nails and plates, hardware failure rates, and reoperation rates. I think that those are probably the key things that we would want to know as to which implant may be better. Actually, the way I wanted to break this up was, let's look at two-part fractures first, and then as we go into the literature, we see that people are looking at then a combined 3- and 4-part fractures in which they're nailing as well. So actually, one of the probably earliest literature on nail versus plate actually came out of this institution in 2012. Very small retrospective cohort series led by Dr. Egol, looking at 12 patients who had IM nails for 2-part fractures compared to 12 patients who had locking plates fixation for 2-part fractures, and all patients in the study had greater than 12-month follow-up. And what the authors found was mean time to union was similar, 3 months in both cohorts. Both cohorts had no significant difference in the mean neck shaft angle, at 124 degrees in the intermedullary nail group and 120 degrees in the plate group. Remember, mean neck shaft angle for proximal humerus fractures is around 135. Mean forward elevation at follow-up was, again, similar, about 134 degrees in the IM nail group and 140 degrees in the plate group. With regards to complications, the authors did find that there were more complications, although it did not reach significance, but it's probably due to the numbers, more complications in the IM nail group. Here, they found that there was subacromial calcification in 2 patients, deltoid calcification in 1 patient, painful hardware in 1 patient. And it's a different type of complication they were seeing as compared to the patients in the plate group. In the plate group, the types of complications being seen were along the lines of screw penetration, in which they had 3, and AVN, in which they had 1. Now, again, this is a very small retrospective study, so we can kind of go forward. This is now 2017, published in the Journal of Orthopedic Trauma. Again, this is a group out of China, and they're again looking at intermedullary nail fixation versus locking compression plate fixation of 2-part proximal humerus fractures. And what the authors found is that in Group A, if you look at the table on the left, with patient demographics, Group A is the intermedullary nail group, Group B is the proximal humerus plating group, that there is intermedullary nail was associated with shorter OR time, almost by about 30 minutes, and less EVL, almost by about 100 cc's. For people who do nailing, it does make sense. I mean, this is a little bit more of a minimally invasive procedure. And so access to the actual fracture site can occur much quicker with your surgical dissection. And because the surgical incisions are smaller, the closure time is shorter. And also because less of the fracture site is exposed, and especially for 2-part fractures where a lot of the reduction techniques are percutaneous, there's going to be less blood loss on the operative field. And the most important part of this study was that they had 2-year follow-up. And at 2-year follow-up, there was no difference in functional outcome. But interestingly, at 3 months, 6 months, and 1 year follow-up, using both VAS, ASCS, and USLA shoulder scores, again, the authors found no difference in functional outcome. The idea being that regardless of a nail versus plate for a 2-part fracture, at each time point as you progress throughout your recovery, your functional outcome was similar. And probably the best quality study for this was published in 2011 in Journal of Bone and Joint Surgery. This is a prospective randomized trial with a minimum of 3 years follow-up. And this study, again, looked at intermedullary nail versus plate fixation. Outcome scores they measured were VAS, ASCS scores, and constant scores. There are 25 patients in the intermedullary nail group and 26 patients in the plating group. And they found no difference in union time with nail versus plate, again, 3 months union time. What they did find, interestingly, was there was a significant difference in complication rate. Unlike the study I presented before by Dr. Egol, this study found a significantly lower rate of complications with intermedullary nails. Here we have 4% complication rate versus a 31% rate of complications. And again, at 1 year follow-up and then again at 3 year follow-up, mean functional outcome scores were very, very similar. No significant difference. Now let's move ahead now and talk about 2 and 3-part fractures. Unfortunately, I'm not able to isolate out 3-part fractures in the literature because no one is looking at just comparing 3-part fractures, plating versus nail. They are combining some of these. When we look at this, here's a study published in 2016. This is out of Brazil. these people had 32 intramedullary nail patients versus 33 plating patients. Of this cohort, 50% were 3-part fractures. The other 50% were 2-part fractures. Primary outcome measure was their 12-month constant score, and their secondary outcome measure was their DASH score, VAS, range of motion, neck shaft angle, and complication rates. Again, the take-home message here was that there were really no difference in functional outcomes at 3 months, 6 months, or 12 months. There were differences in hardware problems. Intramedullary nails had a higher hardware problem rate, 19% versus 6%, and they did have a higher reoperation rate, 19% versus 3%. The reoperation rate in this group was primarily for screw loosening. The conclusion of this study is that fixation with locking plates or intramedullary nails produces similar clinical and radiographic results. However, there are more hardware problems and reoperation rates in groups treated with intramedullary nails. Now here's another study, again, looking at a combined 2, 3, and actually 4-part fractures. The 4-part fractures here were only about 10% of the cohort. This is 34 IM nails versus 48 plating fractures of a different combination of fracture patterns. The conclusion here is that more complications in the plating group. Here we have about, say, 34% in the plating group versus 26% in the IM nail group. The IM nail group was associated with shorter oral times and less blood loss. There's another study here. This one was published in 2019. 27 IM nails versus 28 plates. Mean age of the patients was 75. So this is an elderly cohort, of which 50% were 3-part fractures. In this study, intramedullary nailing had fewer incidents of secondary loss of production and screw cutout. And at 1 year, between nails and plates, similar functional outcomes. The take-home message here so far, in my mind, is that functional outcomes up to 1 year and beyond between nailing and plating, 2 and 3-part fractures. And studies appear to have variable rates of hardware complications. Some studies saying that plates have higher hardware complications, and some studies saying that intramedullary nails have higher complications. Now, it's much less common, especially in the United States, to see 4-part fractures treated with intramedullary nail. However, in Europe and again in Asia, these are treated much more heavily with, again, intramedullary nails. And so this was by the Softcott group. This was published in 2016. This was a multi-center retrospective study, 54 intramedullary nail patients treated versus 53 plating patients. These were collected from the years 2009 to 2011. There was a mean of 42-month follow-up with a poor outcome defined as a constant score less than 70%. The mean constant score for this group was no different, 77% in the intramedullary nail group versus 81% in the plating group. Again, no significant difference in the outcome, which was poor outcome, and no difference in the rate of tuberosity healing in the anatomical position. But the interesting point about this study was that if a medial hinge was present, so you had a fracture along the medial calcar of the proximal humerus, or if you didn't, the constant score was significantly higher in the plating group. So if you had a medial hinge, there was no fracture there, the plating group did significantly better. And that was regards to constant score and the rate of outcome. Again, complications rates were no significantly different. Their AVN rate was about 17% in the intramedullary nail group, 15% in the plating group. And then the similar rates of screw penetration and similar rates of surgical in both cohorts. The conclusion in this study is that if you have a medial hinge and it's preserved, the group recommended locking plate fixation. In other cases, either technique could be used. And to give you an example of what that medial hinge looks like, X-ray here on the left, there is an intact medial calcar. The proximal humerus head has just been tipped into the focus. If you look at the X-ray on the right, here, there's a very large medial cortical fragment. This is where the calcar has been disrupted. And in this setting, this is where an intramedullary nail will probably provide you as much stability and functional outcome and beyond. And then finally, I think one of the last studies I wanted to leave you with was a much larger retrospective study. This is probably the largest and most up-to-date sort of systematic review and meta-analysis out there. There were 38 retrospective studies reviewed, which included a total of about 2,700 patients. They looked at what they considered the control group, looking at patients who had locking plate technology versus the experimental group, which were intramedullary nails. They did control for near classification. And based on this very large pooled cohort of patients, what they found was that intramedullary nail was superior to plates in terms of intraoperative blood loss, operative time, fracture healing, postoperative complications, postoperative infection. But ultimately, there was no difference between plates or nails with regards to functional outcome, essentially radiographic appearance of the neck shaft angle on x-rays, no need for additional surgery, and no really difference in complication rate. So what is the conclusion, nail versus plate for proximal humerus fractures? I think studies essentially are conflicted on the best implant for 1 year outcome. I think that actually when I say conflicted, they're saying that they're equal. Outcome is equal between nailing or plating for proximal fractures. Probably what this means is that your outcome and with regards to provision rates and other types of complications is likely surgeon dependent. Both seem to be acceptable outcomes. Ultimately, what needs to happen is that we need to respect the principle of proximal humerus, the principles of proximal humerus fixation, which include reduction of tuberosities, correction of the varus alignment, and then stabilization of the calcar. Thank you.
All right, thank you so much for that. And our final talk on this session will be by Dr. Philipp Leucht, who will be speaking to us on tips and tricks for one of our more complex fractures that we deal with, a distal humerus.
Thank you, and good morning, everyone. I'm going to go over some treatment goals, imaging approaches, reduction techniques, and complications. And I picked 3 cases, and I'm just going to go through those cases and discuss how I tackle these sometimes complex injuries and how we can prevent some of the complications that can occur during fixation of these fractures in the long-term outcome. So for treatment goals, these are articular fractures. So our principles hold true here. We want to restore articular congruity, and that has to be done through anatomic reduction. Little different compared to other articular fractures, for example, the distal femur or the tibial plateau, where you anatomically reduce the joint and then just add the shaft in a proper alignment, rotation, and length. For the distal humerus, we oftentimes strive for anatomic reduction of the connection of the articular block to the shaft. Because if you're just bridging a comminuted zone in the distal humerus, that often leads to non-unions and other complications. So most of the goals in reduction are really anatomic in the distal humerus. The goal really is to get a stable joint so you can start early range of motion, because we all know any fractures around the elbow are prone to getting stiff afterwards. So we need a stable construct that allows early range of motion within a few days after surgery. And then we want to avoid the complications that are most common, and those are nerve-related complications, so ulnar neuropathy, stiffness, HO, and non-union. And I'm going to show you some examples of these complications. So just a brief refresher. This is the anatomy of the distal humerus. The distal humerus is made up of 2 columns, a medial and a lateral column, and those 2 columns are connected at the joint through the trochlea. We usually plate those columns on the medial side with a direct medial plate, and on the lateral side you can go lateral or posterolateral. But now with more mini-frag options, you can see or put plates on almost every surface if you find room to put a place, and it helps you in your reduction and maintenance of reduction. For imaging, this is usually what it looks like when you see an AP and a lateral of the distal humerus. It's hard to identify fracture lines because everything is distorted. So oftentimes the best view is a traction view. This is not the best example of a traction view, but sometimes the traction view really shows every single fragment and suddenly you understand the fracture. But even in this pattern, you can see here that the medial column is split into 2 fragments and the lateral column is impacted and definitely not well aligned. CT imaging is not very helpful. Usually it does help with capitellar shear fractures, or identify capitellar shear fractures that you have to address during your operative fixation. It also shows you some trochlear marginal impaction if that's something that you suspect. But you can see on these images up top, that's the same fracture that I showed you before. I think the traction view is a lot clearer than the axial cuts or even the sagittal cut or coronal cut of this injury. For pre-op planning, think about how you want to position your patient, what OR table you need, that you need a C-arm, where's the C-arm, from which direction is the C-arm coming in. You have to think about your approach, what tools you need for reduction purposes, and then your fixation strategy. So first positioning, this is how I position my distal humerus fractures in lateral position over an arm board. The arm board can either be connected to the top of the head or is shown on this slide here on the side of the bed. Just keep it far away, almost at the level of the hip, so that it doesn't interfere with the C-arm when it comes through to a lateral. The C-arm comes in from the head parallel to the bed. That allows you to give an AP X-ray, and then you come to a lateral, and you can get a lateral of the elbow. I don't just keep the C-arm in the AP position and move the arm back and forth to get an AP and lateral, because oftentimes your reduction with pointed reduction forceps and K-wires is a little, it's not as good to allow for this movement, and then you lose your reduction. So it's easier to just have the C-arm come through. And if you axial tilt the boom of the C-arm a little bit, you can actually get really close to the patient, and you'll get the whole distal humerus on your image. And then I put the hand into a Mayo stent cover to keep it sterile. And in case any fragments fall out of the wound, you'll also catch them in the sterile bag. For approach, usually I start out with the paratricipital approach. So it's a straight midline incision, and then identify the ulnar nerve, tag it with a vessel loop, and then elevate the triceps off the posterior humerus. That gives you two windows, an ulnar and a radial window. And I just look at the articular block from those two windows and decide pretty quickly within a few minutes whether I have enough visualization or the fracture pattern is simple enough for me to reduce it. If it's not, I'm not going to continue to struggle. The next step is an olecranon osteotomy. So in most of the cases, if there's any comminution, if there's any struggle with a reduction, I go straight to an olecranon osteotomy. And this is how I do it. I place a K-wire into the olecranon and just get a fluoroshop. It can be as ugly as this one, but I just want to make sure that I'm in the bare spot of the olecranon. And then I use a microsagittal saw and perform the chevron osteotomy, which I then finish with osteotomes. And you want to finish with osteotomes for two reasons. You don't want to gap out a piece of articular surface with your saw, which would happen. And secondly, if you use an osteotome, you get a nice fracture line that has keys for reduction at the end of your procedure. Oftentimes, I contour my plate first before I do the osteotomy, and drill two holes, one for a screw in the proximal fragment and one in the distal fragment, just so that when I'm reducing the fracture at the end, I can just put the plate on and put the screws in, because after you've struggled with the distal humerus for a few minutes, you don't want to then struggle with the olecranon osteotomy at the end. And it makes it much easier to already have the plate and screws ready for fixation for this. And here's a picture of the olecranon osteotomy. You can see that the tip is pointing distal, and you can see the entire articular surface. Especially if you flex the arm, you can also look all the way anteriorly into the joint. There are many options for fixation for your osteotomy. I use a mini frag plate as shown here in this X-ray with screws, but you can also use a screw and a washer alone, or you can use a tension band. All of these work, and there are reported non-unions in these situations, but I think if you use good technique, make sure that you compress the osteotomy side. That should not be an issue. So first I'm going to show here a lateral column fracture, the same goal as in the type C fractures. You want anatomic reduction of the joint, you want articular reduction and compression, and then early range of motion. So you can see here the lateral column is fractured and displaced. So in this case, I did not go through a midline approach. I did a lateral column approach. You can see here the freer is anteriorly over the capitellum. The fracture is visible, is reduced anatomically. You can see this in front of the army navy here, held with a K-wire, and then a lag screw is placed independent of the plate, and then a small a mini frag plate is contoured as a buttress plate to support this fragment. And this is what it looks like. You can see the articular compression with a lag screw is the most distal screw, and then a buttress plate placed above. And you just have to make sure that you keep your fixation out of the fossa, because that really limits extension. And that's why you see only 2 screws in this plate, one proximal and one distal to the fossa. And then you can see the 1-year post-op x-rays sealed nicely. There's no step off at the joint. And in my opinion, or in my experience, these plates always have to be removed. I have not done one where the patients didn't come back later on and said, oh, the plate bothers them and they want them out. They're just very prominent. And this patient also had his plate removed. I don't have the x-rays after the removal. For type C fractures, I mentioned this before, we are striving for anatomic articular reduction, compression, and then the order of reduction really depends on your keys of the fracture. If you want to first fix one of the columns to the shaft and convert the fracture into a type B, that may be a good strategy, or you can fix the entire block together first and make it into a type A fracture. And I have an example here of the latter, where I first reduced the articular block with K-wires and small pointed reduction forceps. There's a small fragment, which you can see in the second from the left image, held with the pointed reduction forceps that's then fixed with a mini frag screw, which you can see in the floor shots. You can see also that there's a lag screw going all the way across the articulation to compress the joint surface. And then this block was attached, as you can see here, to the medial column. This was an open fracture that was IND'd at an outside hospital, and they took a big lateral column fragment out. So this patient ended up with a bone void on the lateral side, which I was planning to go back after 6 weeks for bone graft procedure. This patient was also on ECMO. Not the most stable. So the goal was just here to restore the articular block and then reduce the fracture and come back later for fixation. You can see here the floor shots with lag screws, independent lag screws to hold together those fragments, and then a medial plate and a posterolateral plate. And you can still, on the right shot, you can still see the olecranon osteotomy is not fixed yet. And here's the final product. This is 4 weeks out from surgery. I told you this patient was on ECMO. He's a polytrauma patient, so he developed severe HO. So maybe I don't have to go back for a bone graft procedure, because he may develop HO in this bone void as well, and this may just heal fine. But you can imagine this HO is also encapsulating his ulnar nerve. So now he's complaining of ulnar neuropathy. So I envision that I have to go back in a few weeks and release this HO and release his ulnar nerve to help him with his ulnar nerve symptoms. The good thing here is that the HO formed only in the distal humerus and not so much around the elbow joint. So his range of motion is still very good, and most likely this will not lead to stiffness because it is so proximal. So here's some data on ulnar nerve symptoms after distal humerus fractures. This is a randomized controlled trial from Canada. 58 patients with distal humerus fractures who underwent plate fixation were randomized either to in situ placement of the ulnar nerve or anterior transposition. 31 were randomized to in situ, 27 to anterior transposition. There was no difference in all measured outcomes or in 2-point discrimination. Nerve conduction studies revealed no difference between the two groups, but what you can see here that there was a high incidence of ulnar nerve pathologic findings in the ulnar nerve conduction studies in both groups. And that's just something that you have to counsel your patients about, that it is very common to have some ulnar nerve symptoms after surgery, but the majority of those improve by 1 year and patients will be okay. And then the other complication that you saw in my patient is the HO formation. This is an older paper, 89 distal humerus fractures, follow-up 15 years. And you can see the incidence of HO was 42%, and it was present usually at the 3 months follow-up. The most common location was the anterior humerus and the medial collateral ligament. The anterior humerus is exactly where my patient developed it. And you can see that the majority is limited mature HO that probably doesn't lead to any stiffness. And only about 5% in this cohort developed complete ankylosis. So I think the 27% with extensive HO plus the 5.5 probably need a secondary procedure to allow for more range of motion. Thank you.
All right. Well, thank you to our three speakers. And there have been some good questions coming up in the chat. Some of them I'll have to get to more independently because we're a little short on time, but I just want to ask some questions of each of the speakers. So for Dr. Ganta, one question was, if the superior plate's more prominent, why not use the 2.7 anterior and the 2.4 plate superiorly? Is there any reason for the selection of those plates?
Yeah, so the 2.7 plate is actually a recon plate, so it's actually very, very thin. The DC plates are the ones that tend to be thicker, and it's every time I've tried putting a 2.7 DC plate on the anterior part of the clavicle, because of how thick the clavicle is, it tends to be actually more prominent that way and a little bit more challenging to apply. And so that's why I use a 2.7 recon, because it's a really thin plate. It's the same thinness as like a 1/3 tubular plate. So that's the plate that goes on the superior margin of the clavicle.
And I thank you. I just want to say anecdotally that I've been doing anterior inferior plating just with a single plate forever. And I literally have never had a single patient ask for harder removal. So I was actually kind of surprised about the numbers that you were quoting there. But again, that's just anecdotally. But thank you. Dr. Leucht, one question that came up was, how do you choose your total? Who's going to get a total elbow and who's not?
Good question. I mean, it has to be a very old patient that I really think has an unreconstructable distal humerus. It is very rare that I would indicate someone for a total elbow. I think you can. There's still the bag of bones technique in an elderly patient where you don't want to take a patient to the OR and you just treat them without surgery. But then the same age group with a lot of articular comminution that's still highly functioning, I think that would be a good patient for a total elbow. But again, the total elbow, the limitations afterwards, especially with weight bearing or weightlifting, are really a big concern for me. So they have to be patients who are not really using their arms much anymore.
Okay, thank you. And this is a good question for Dr. Konda. And one thing I want to say, first of all, is that I always say to the residents that the literature is like the Bible. You can find something in it to support whatever it is that you believe. So I think that, your selection, you had a little bit of a selection bias in your literature selection there. That being said, the question is actually about what about using a fibular strut allograft with your plate to reconstitute the medial calcar? Any thoughts on that?
Yes, it's a great question. I think that, based on the large retrospective review of Europe, I mean, the authors there would suggest that if you are lacking that medial hinge or that medial calcar, that plate fixation is not ideal. However, I think that's what we found here in the United States, and we've popularized using that fibular strut to kind of reconstitute that medial calcar. I think it's reasonable to use. The fibular strut is an option. Calcium phosphate cement is an option. There are various options that people can use to reconstitute that medial calcar strut. I don't know of any studies that have compared, in particular, intramedullary nailing versus, plate fixation with a fibular strut, however, for that specific practice.
Okay, thank you. So I think with that, we will close out on this session, and I'll hand it back over to Drs. Ganta and Patel.
All right, thanks, Toni. So for our next session, we're going to be doing upper extremities part 2. Our moderator for this is going to be Dr. Patel. Dr. Patel, I'll have you take it away from here.
All right. Good start to our upper extremity section. We'll keep moving down. And Dr. Egol is going to start off talking about proximal ulna fractures.
Okay. These are my disclosures. Nothing to do with this talk. So I'm going to start off. There are basically three sections that I'm going to talk about. I'm going to talk about fracture of the olecranon process, simple ones and a little bit more complex. I'm going to talk about Montasia fractures, and I'm going to talk very little about anteromedial coronoid facet fractures, these all being proximal ulnar fractures. So the anatomy of the proximal ulna includes the olecranon, the coronoid process, and the greater sigmoid notch. And overall, olecranon fractures make up about 10% of elbow fractures. And as with all fractures, there's a bimodal distribution. We tend to see them in young patients, usually due to high energy, and more commonly in our practice in New York City, lower energy in older, poor quality bone. Now, there are several classifications, but really the important thing to understand about olecranon fractures is the mechanism of injury. Most commonly, they are secondary to indirect or tensile failures due to eccentric contracture of the triceps. So it's a very high force contraction of the triceps muscle against a flexed elbow. These tend to be transverse fractures, but they can have a little bit of comminution, especially if the patient then falls on the elbow. Most patients will tell you that they fell on their elbow because the act of the eccentric contraction usually occurs during the fall. The other mechanism is a bending mechanism, and those are usually more high energy. Those are the ones seen with the Montasia fractures. And more commonly, we see a lot of comminution and impaction with these. And of course, you can have a combination of the two injuries. As I mentioned, you have the tensile fracture and displacement of the olecranon tip, and then you get some impaction as the elbow hits the ground. Now, my first tip is I am a fan also of the dorsal approach for most distal humeral and proximal ulnar fractures. I tend to do this in a lateral position with the elbow over a post, similar to the way that Philipp presented it. I actually do like to drape in the C-arm as well. The head comes in, the receiver is up at the head. I place the C-arm in the lateral position, and I drape it in, because all I'm really interested in is the articular reduction at the joint. And I don't necessarily need a lot of AP imaging. I'm looking directly at it. And once I get some provisional fixation, then I just rotate the arm to get the AP. I like this approach. Gives me nice access. I can get to both sides if I need to. I can be extensile or I can be minimally invasive. Now, my next tip is you got to understand the difference in the fracture patterns. So at the end of this, I want you to take away that not all proximal ulnar fractures or olecranon fractures are the same, right? On the left here, if you guys can see that arrow, that is a simple tensile fracture, right? There's often very little comminution of the articular surface. In the middle, right, that is a fracture that's associated with significant comminution and articular impaction, right? This is not a simple tensile fracture. And then all the way to the right, this is the Montasia fracture. This is a bending fracture with posterior dislocation of the radial head. So yes, these are all proximal ulnar fractures, but they're all very different. And the way you treat them and the implants that we choose to treat them are very different. Regardless of how you choose to treat these injuries, the objectives remain the same. We want to restore the articular surface, although I do not believe that this is the major goal of fixing proximal ulnar fractures. We don't walk on our arms. I think articular incongruence is well tolerated in the elbow, and radiographic arthritis doesn't correlate with functional outcome. Most importantly, I believe we want to restore and preserve the elbow extensor mechanism, much like we do for patella fractures. And of course, we want to restore elbow motion. We want to give them a functional range of motion, although 95% of people will lose some range of motion. And you got to tell them that when you start, you're not going to have full extension. You're going to lose 5 to 10 degrees, and you're going to lose 5 to 10 degrees of terminal flexion. And if you do that and they have it in their mind, they understand it's a consequence of the injury and nothing that you've done. And then, of course, we want to prevent complications. Almost impossible. What we really want to do is minimize complications. And how you do that is really how you're trained and what you feel comfortable with. So the how to do it, right? These are the tricks. So I think for simple tensile fracture patterns, you must have a tension band to counteract the tensile force. So on top, we have that simple olecranon fracture tensile, and it's fixed with a K-wire and looped wire tension band construct. And it works very well, allows for early range of motion. And this is a dynamic tension band in that range of motion, right? And active firing of the triceps actually causes compression on the compression side, the articular surface side of the fracture. So you have to have an anatomic reduction. On the bottom, thanks to Dr. Tejwani, is an example of a tension band plate. It's still a tension band. It's on the tensile side of the fracture. It's still counteracting the tensile forces, but it's a different implant. It's a plate and screws. And this works well as well. We've published on this extensively. There are no differences in outcomes, radiographic appearance, and the ultimate need for hardware removal. Anytime you put any implant on a subcutaneous part of the body, such as the olecranon, patients are going to feel it, and a portion of them are going to become symptomatic from a bursitis. Now, I think in more complex tensile fracture patterns, in addition to the implant, you got to remember you got to perform an articular reduction. That's another tip, and it's a trick. So just like all articular fractures, you may have to use a little bit of an osteotome and elevate an impacted fracture, right? And then hold it there. And sometimes you have to pack some bone behind it or some calcium phosphate cement or whatever it is. And then you can use, again, I think as long as you have an anatomic reduction, you can use either a plate and screws or a wire tension band construct as shown in the slides below. Now, if you have bone missing or there's a gap, then I would advise against the wire tension band because you don't want to have dynamic compression. You want to have more static tension band construct in place. But either will work very well, and you can see that healing is usually the rule with these. Very low incidence of non-union. Again, understanding the mechanism leads you to the treatment solution. Next, we'll talk about the Monteja fracture. So the Monteja fracture is, again, a fracture of the proximal ulna, usually involving more distal area, the metadiaphyseal junction, usually involving the area around the coronoid, usually from distal to the sigmoid notch and the coronoid tip. And there is an associated either radial head dislocation or a fracture of the radial neck and or head. Okay, now this is a little bit more rare, about 2% of all the fractures about the elbow, but it's one that's associated potentially with poor outcomes. And again, this is the Beto classification, right? Type 1's common in kids. Type 2 is the most common fracture we see in adults. Type 3 rare, again, seen more in kids. And the type 4 is the most rare of all, and that is a both diaphyseal radial shaft and ulna fracture. Of the type 2s that's been subclassified by Jesse Jupiter, again, based on its location, as you go more distal and get more comminuted, these become more complex and the outcomes are not as reliable. Now, almost all of the complications we see in adults are associated with the type 2s. Now, is that because they're the most common? They make up about 70%. That's probably true. But again, I think because of mechanism, because these are bending fractures and they want to go posterior, I see a lot of patients not treated with posterior plating, which counteracts that force, and this can lead to problems. The treatment objectives here are, again, restore ulnar length. By restoring ulnar length, almost all the time, you will be able to reduce the radial head. Dorsal plating. Although it is a subcutaneous area and the patients become symptomatic, you have to provide a biomechanical counter to the bending moment that wants to displace this fracture. And when I see failures of plating, early failures, it's because people try to put the plates laterally and avoid having them be subcutaneous. Try to stay away from that. I think most radial head fractures, and we see them more in the elderly, do better with radial head arthroplasty rather than attempts at fixation. We know that if you have more than 3 pieces or 3 pieces or more, and the shaft is included, right? So basically, if you have anything more than a partial articular fracture, you should replace the radial head. That's another tip. So here's a case. This is a pretty bad one, high energy. You can see there's a sagittal split in the coronoid, and you have to be able to address that. Don't forget that. Don't leave it out of your fixation strategy. But, there's a significant soft tissue injury associated with this. You can see because of the dislocation of the radial head here. Again, CT scanning, I think, is very helpful in these cases to assess all the fracture fragments and help you in preoperative planning. So patient gets dorsally plated. When length is restored, you can see the radial head and the radiocapitellar joint is well reduced. You can see I have screws going from the plate into that displaced medial coronoid fragment, and it's very important. And here's the patient at 6 months with a very good result. There's some heterotopic bone seen here, but it did not inhibit this patient's ultimate outcome. Sometimes, as I mentioned, it's better to replace the radial head. Again, I think certainly in older people, and anything more than just a simple partial articular, I don't think twice about replacing the radial head. I tend to do it through the same approach. I'll flip the proximal ulna fragment up and I'll replace the radial head through the fracture itself. However, if the fracture is distal in the ulna, you'll have to make a separate Coker approach, and you can do that through the posterior skin incision, and just slide over and make a separate window. And this is what it looks like when you do that. And again, I think that this is really the way to go, certainly in the older patient population. Finally, I'm going to touch on the anteromedial coronoid fracture, and I have to give props to David Ring for really bringing this to our attention. It's usually a large type 3 fragment. It's associated with anteromedial instability. The type 1s tend to be associated with posterolateral rotatory instability and or the terrible triad fractures. Those usually can be fixed with a suture technique. What I'm talking about are the large fragments that involve the anteromedial facet. Now, as opposed to positioning these people on their side and going from the back, I position them supine on a hand table, and I go medially, usually through an over-the-top approach. Here is a case of a young guy who sustained this type of an injury with a large anteromedial facet fragment. CT scanning, again, helps to better visualize fracture fragments and help you with your preoperative planning. This is an isolated fragment. And in order to restore elbow stability, I believe this is best treated with fixation. Here's the approach. Again, find the ulnar nerve. That's what's in the vessel loop down here. Just know where it is, but you're going to be well anterior to that. This is the over-the-top, splitting the flexor pronator mass, and you're right down on the anteromedial portion of the coronoid, and you can reduce it. Sometimes I'll fix it with an independent lag screw, or sometimes the lag screw can go right through the plate. They make specially pre-contoured plates for this. Sometimes I'll just take a mini fragment plate and contour it myself. And this is what it looks like. So in summary, my tips and tricks, I think setup is important for the elbow. I like the lateral position for most dorsal approaches. If I'm going anterior or lateral, I'll go supine and use a hand table. Understand mechanism of injury for these fractures. That is the key to fixation. If you have a simple olecranon, it needs a tension band to counteract tensile force. If it's a Montasia fracture, you need a dorsal plate. Understand which fracture patterns are the bad actors so you can generally counsel your patients and understand what to do when things don't go your way. Understand anteromedial instability and how it's associated with these large coronoid fragments. And if you do, you'll be able to provide better care for your patients. So with that, I will thank you. And I would like to say that while great being here on Zoom with all of you, I'm looking forward to next year when we can do this in person. Thanks very much.
Thanks, Dr. Egol. That was great. Next, we have Dr. Paksima, who's going to talk about forearm compartment syndrome.
Great. Okay. So I want to thank Dr. Aylan for lending me some slides, and my disclosures don't pertain to this talk. We're going to talk about some of the anatomy, some of the causes, diagnosis, and management of compartment syndrome. So compartment syndrome's definition is a condition of increased tissue fluid pressure within a confined osteofascial space reduces capillary blood perfusion below level necessary for tissue viability. So the bottom line is it leads to muscle death. And from a historical perspective, 1881, Richard van Wolkman described this condition of myonecrosis and contracture from prolonged muscle ischemia. Initially, there was debate of whether this was a nerve problem or vascular problem. This was settled by Jepson in 1926. And in 1940, Griffiths gave us the 5 Ps of arterial insufficiency, which overlap with compartment syndrome. In the 1950s, Seddon proposed a resection of infarcted muscle, and Eaton and Green finally established fasciotomy and episiotomy as the definitive treatment in 1975. So not so long ago. From a historical perspective, Donadow established that pressure in has to be greater than pressure out. And blood flow stops when you have interstitial pressure that equals diastolic blood pressure. This is the pathophysiological cascade that Madsen described, and I draw your attention down here to tissue perfusion. Decreased tissue perfusion then leads to increased capillary permeability, which then sets up a vicious cycle, which leads to more decreased tissue perfusion and ultimately progressive muscle death. On a cellular level, the lack of oxygen leads to a decreased production of ATP, which then leads to a failure of the sodium and potassium channel pumps, which leads to individual cell death. So, the formula here is local blood flow, and it's a function of arterial pressure in, venous pressure out, and resistance. So resistance is modulated by things like a tight splint or cast, and the arterial pressure, such as arterial occlusion or from hypotension. The bottom line is that time is muscle. So within 4 hours, only 5% of muscle cells are damaged. But by 8 hours, 100% of muscle cells are dead. So that's where the 6-hour thing comes from. And the sooner, the better. How much pressure is too much? Absolute pressures of more than 30 or 45 millimeters of mercury, or relative to diastolic pressure. So if you're within 30 millimeters of mercury of your diastolic pressure, you're in the danger zone. Compartments are made up of different tissues: fascia, bone, muscle, nerve, and of these, the muscle is the earliest to be damaged, followed closely by nerve. Let's look at the forearm specifically. So in the forearm, we have the volar compartment, which has 2 compartments, the deep and superficial. And the deep is further subdivided by the pronator quadratus having its own separate compartment. On the dorsal side, we also have a superficial and deep component, as well as the mobile wad. But the important thing to remember about these is that whenever you have compartment syndrome, you want to release every single muscle. So that picture on the bottom right talks about, or that's a clinical picture of an individual ECU compartment syndrome. So every single compartment can be compressed and needs to be released. And that's the thing to remember about dorsal and volar. The causes, they can be from tight casts and splints, circumferential burns, prolonged positioning in the OR or outside, specifically in the upper extremity, supracondylar humerus fractures, both forearm fractures, especially in kids, pit viper inflammation, snake bites, and forearm exertional compartment syndrome seen after ice fishing and boring holes in ice. The diagnosis is based on the 5 Ps, of which the most important is pain. That's the only and earliest reliable indicator of compartment syndrome. But always the question is, what's pain out of proportion? So one thing we try to look for is pain with passive stretch. So you can stabilize the PIP joint and just move the DIP joint to really get the FDP moving to see if there's deep pain. Remember that when you're thinking about nerves, initially paresthesias can set up as early as 1 hour. That's one of our earliest findings. Paralysis can take 4 to 8 hours, and pulselessness is the last sign. So if you wait for pulselessness, you're always going to miss the boat. When do we measure compartment pressures? Well, whenever there's a suspicion, you can measure compartment pressures. But the most important thing to remember is this is a clinical diagnosis. So compartment pressures, if they're positive, they're going to lead you to fasciotomy. But even if they're negative, as you see down here in the bottom right, you still have to monitor closely and make the decision based on clinical findings. There's different ways to monitor. You can make your own setup with like the white side technique. We can use the Stryker monitor if it's available, or we can use continuous monitoring. Question always is, where do you stick the needle? And this needle should be stuck right at the site which has the highest pressure, which is closest to the fracture. If you look at the differential diagnosis, there's a lot of overlap between arterial injury, nerve injury, and compartment syndrome. So again, the clinical diagnosis is super important, and this is especially true in obtunded patients and pediatric patients. This is a favorite board question. This is the sentinel sign. The sentinel sign is an area of necrosis on the dorsal and radial aspect of the hand. And if you see this, that's a pathognomonic of pediatric compartment syndrome, neonatal compartment syndrome. Non-surgical treatment is really limited to impending compartment syndrome. You can take off the cast, you can split the web roll, avoid elevation, and closely monitor. But the mainstay of treatment is surgical. And so you can have these dorsal incisions and the volar incisions. And to quote Dr. Egol, this is a tip and a trick. This is the preferred incision on the volar side. You really want to make it on the volar ulnar aspect of the forearm, not that wavy thing that's going through the middle, because you have to leave these open. And when you leave these open, you want to leave the median nerve covered. Decompression of one compartment takes the pressure off of every other one, but it's really important to release every single compartment. What do you do when you release? You look for muscle viability. Any non-viable muscle based on the 3 C's is resected. And then the wound should be left open. Don't close the skin because you're going to recreate the compartment syndrome. If this is missed, this leads to replacement of muscle with fibrous tissue, contractures, and nerve dysfunction. And that's what we call Volkmann's ischemic contracture. This is classified either by the system of Holden, which looked at arterial injury versus direct injury. More commonly, the Sugi classification of mild, moderate, and severe, of which moderate is the most common. And the classic or moderate findings are involvement of the deep volar compartment, the flexor tendons, little involvement of the extensor tendons, variable involvement of the median and ulnar nerves, and no joint contractures that are fixed. When we get to more severe compartment syndrome, now we're talking about all of the flexor tendons, some involvement of the extensor side, severe median and ulnar nerve symptoms, and fixed joint contractures. To differentiate hand compartment syndrome from forearm, hand compartment syndrome leaves you with an intrinsic plus deformity, as seen here. Forearm compartment gives you intrinsic negative. Non-operative treatment for established Volkmann's is centered around maintaining joint mobility. And for early or milder stages, the treatment may only involve scar fibrosis, excision, and Z lengthenings. In more severe cases, the nerve has to be addressed either with neurolysis or even with resection of the nerve and nerve cable grafting. And you can even do muscle slides. Here's an example of what it looks like. You take the flexor pronator mass, detach it from the proximal origin off the humerus and off the ulna and skeletonize the ulna. The problem with this is that it may lead to increased weakness. For end-stage Volkmann's contracture, you may consider resection of all fibrous tissue and free muscle transfer, such as a gracilis transfer seen here. I wanted to conclude with showing a quick case. This is a case of a 16-year-old. He had a forearm fracture, was treated with open reduction and tunnel fixation, had cast complaints which were not addressed for 6 weeks. So these are the x-rays. And when he came out of the cast, he had these findings with a moderate compartment syndrome, a moderate Volkmann's contracture. So he falls into the category of moderate over here. The surgical plan was to take him to surgery, debride the tissues, and perform, even at this latest stage, fasciotomies. So here are, you can see the sort of pink whitish looking dead muscles that had to be excised. This is the ribbons around the vascular leashes around the median nerve. And further dissection showed the ulnar nerve to be severely compromised. The ulnar artery was completely collapsed and the radial artery was still intact. So the nerves were neuralized and wrapped. The tendons were lengthened, and he underwent an extensive program of physiotherapy afterwards. Here he is at 6 weeks getting some early gains. And here's another view of the 6-week mark looking at the fingers. And here's a 9-month follow-up with restoration of finger flexion and extension and reestablishment of ulnar nerve motor function as well as median nerve motor function. You can see his opposition over here. And this is a video of his function with a good restoration of movement. So in summary, a high index of suspicion is a clinical diagnosis. Timing is important. Remember, more time equals increased muscle death, early and thorough release, and then the late sequelae require planning and execution. Thank you very much.
Thanks, Dr. Paksima. That was great. It's always upsetting to see a missed compartment syndrome, especially in our neck of the world. So thank you for that. Next is Dr. Tolla, who's going to talk about some of our nastier distal radius fractures.
Good morning. I'm going to be talking about dusted distal radius fractures and going over some tips and tricks. I have no disclosures. So I'm going to be covering what goes into my preoperative evaluation and how I think beyond just volar plating when dealing with difficult fracture patterns. And then I'll move on to discuss some technical tips and go over a couple cases. So the first thing I take into consideration is the age and functional status of the patient. If the patient's a polytrauma patient, I want to know if there are other injuries that may require load bearing through the injured wrist, or if they're in the ICU. In these situations, I might consider using a dorsal spanning bridge plate for fixation. When reviewing preoperative imaging, it's important to review the injury films to understand the behavior of the fracture in addition to the post-reduction films. Sometimes traction films can also be helpful for this. CT scans are not always necessary, but can help to better characterize the fracture pattern. I find them to be most useful for small volar lunate facet fragments that I may not have appreciated on plain film, and for localizing die punch fracture fragments, and this sometimes helps me plan my approach. X-rays of the contralateral wrist are helpful for understanding the patient's native anatomy, and in fractures with shortening and metaphyseal comminution, they can help avoid over-distraction when you're using an X-fix or spanning bridge plate. And as we know, over-distraction can lead to severe postoperative pain and stiffness. There are numerous fracture classifications for distal radius fractures, none of which really help guide management or predict outcomes. The better known classifications, including the Frickman, Malone, Mayo, and AO classifications, have been shown by Anderson et al. In '96 to have pretty insubstantial inter-observer reliability. Burkiel and Regazzoni published an article the same year describing the column theory of distal radius fractures. This is not really a classification, but the authors described the distal radius as a 3-column biomechanical construct and advocated for dual fixation of the radial and intermediate columns at 50 to 70 degree angles to improve stability and allow early range of motion. The radial column is composed of the styloid and the scaphoid facet. The intermediate column is composed of the lunate facet and sigmoid notch. And the medial column consists of the distal ulna, TFCC, and the DRUJ. This theory was later adapted by Rhee and colleagues to describe an algorithm for management of multifragmentary distal radius fractures. Without a reliable classification system to help guide management, it's important to recognize fracture patterns that can get you into trouble. These consist of fractures like volar lunate facet fragments that have small pieces, as well as radial carpal fracture dislocations. On the top left, this is a type 2 radial carpal fracture dislocation, which involves the radial styloid. And in this type of fracture, the severity of the injury is often underappreciated, especially if it's well reduced. Overall, it's important to recognize that not all distal radius fractures are created equal, and not all are amenable to volar locked plating. There's a lot of literature to support the use of volar locked plating for comminuted distal radius fractures. This retrospective study reported a nearly 90% union rate without loss of reduction in a cohort of AO type C3 fractures. However, it's important to note that the authors excluded 22 fractures that had quote unquote other methods of fixation, 19 of which were C3 fractures. So roughly 17% of the C3 fractures in this study required alternative modes of fixations and may have represented higher energy fractures. Folk and colleagues also concluded that a majority of intra-articular fractures could be managed successfully with just a volar locked plate. These investigators similarly excluded a large variety of fracture patterns, including dorsal shear fractures, radial carpal fracture dislocations, die punch fractures, and what they called highly comminuted intra-articular fractures, which they defined as fractures with more than 5 fragments. All in all, these are the situations when I consider using, or at least consider using, supplemental or alternative fixation. There are a large variety of fixation methods besides volar lock plates. There are now new lower profile dorsal locking plates that you can use to buttress dorsal shear fragments. There's fragment specific plating systems that can be used to address multifragmentary intra-articular fractures. And there are several systems that offer plates with volar hook extensions to improve fixation for small volar ulnar corner fragments. External fixation is still a good tool and can be combined with any of the above methods, in addition to just using K-wires to treat highly comminuted fractures or fractures with significant soft tissue injury. And lastly, dorsal spanning bridge plates are an excellent option for highly comminuted fractures with metadiaphyseal extension, bone loss, and they can also just be used to neutralize other fixation, especially in radiocarpal dislocations and in situations when you have small articular shear fractures. It's important to be familiar with all of the approaches to the distal radius. The volar ulnar approach, which was described by some of my colleagues at NYU, is useful for accessing isolated volar ulnar corner fractures. But really, you shouldn't be afraid to make additional incisions over the radial column or even dorsally to address fractures of either of those columns. The sequence of reconstructing multifragmentary distal radius fractures that I generally follow is described by Ree and colleagues, and this is in a Yellow Journal article. You start initially by fixing the intermediate column, and this is followed by restoration of the radial column, and lastly by assessing and addressing any instability at the ulnar column or DRUJ. So these are some of my tips for room setup. I like to use a large C-arm for difficult fractures for a couple of reasons. The first is it provides, in my mind, a more accurate depiction of the articular reduction relative to a mini C-arm. The second is that I don't have to move the image intensifier in and out by myself. And the third is that it doesn't interfere with traction setup. So I like to use traction with 2-finger traps, cling, and usually 7 to 10 pounds of weight suspended off the end of the fracture table for many of the fractures that I take care of. And this just gives me an extra hand to work with while getting the reduction, provides ligamentotaxis. I also always have a dorsal spanning plate or an X-fix somewhere in the hospital just in case I run into trouble. And I always make sure to have whatever reducing instruments I might need in the room ready to go. These include, I like to use a 399 clamp sometimes to restore volar tilt. Some people will place the dorsal tine directly through the skin down onto bone. The above authors use a rubber test tube cap to protect the extensor tendons, which I thought was kind of a neat trick. A 399 clamp can also be used to address coronal translation and dial back in radial inclination, as you can see in the picture on the left. Coronal translation can also be addressed by manipulating the proximal fracture fragment instead of the distal fragment. And this can be achieved with a small blunted laminar spreader or even an Army-Navy placed proximally into the interosseous space. So I'll just go through 2 quick cases. This is a 27-year-old male who fell snowboarding. Oops, sorry about that. And he sustained a comminuted impacted distal radius fracture. Here, a CT scan showed significant articular comminution and bone loss. And in this fracture, I began by reducing the volar ulnar corner fragment to the pedestal. And then I buttressed the radial styloid and scaphoid facet with the radial column plate and filled the large bony defect with cancellous chips. To neutralize my fixation, because of the bone loss, I added a dorsal spanning plate. And this also buttressed the dorsal wall fragment and provided additional support for the articular surface. One good trick when using a dorsal spanning plate that I learned from a Mark Richards lecture is to approach the radial shaft proximally between the brachioradialis and the ECRL instead of using the interval between the ECRL and ECRB. This allows you to get a lobster claw around the dorsal and volar aspects of the radius and easily control the proximal position of the plate. And the second tip is to make a 3rd incision over the radial carpal joint to facilitate passage of the plate, and also to make sure you don't trap the EPL underneath the plate. And also you can, access the articular impaction, or if there's articular passion, through this 3rd incision. So this is a patient 4 months post-op right before I took the plate off, and then his florals intra-op with a healed fracture. The second case is a 29-year-old male involved in a motorcycle accident who sustained a volar Barton's fracture with intra-articular comminution and extension into the metadiaphysis. Here's a CT scan, and here it was very useful because there was actually a segmental fracture of the volar ulnar corner. And I wouldn't have been able to capture that with a regular or standard distal radius plate. The metadiaphyseal extension was first addressed with 2 interfragmentary screws. This was followed by reduction of the volar corner fragment with a separate hook plate, followed by placement of a metadiaphyseal distal radius plate. And this is his x-rays at 2 months. And that's it. Thank you.
Thanks, Dr. Tolla. That was great. Definitely important to know about all the options. Most distal radius fractures, you think you're going to get them reduced intraoperatively, and sometimes they just throw some surprises at you. So it's good to have all those options. So I think that rounds out upper extremity. I do have a couple of questions. One for Dr. Egol. Do you prefer to use a polished stem radial head or a press fit type implant?
It's usually, it's always press fit. Leave a little bit of toggle in there. We've gone through the gamut of these over the years, and things being pulled in and out of the market and such. But pretty much press fit. And I think currently it's a polished stem, but it's press fit. It's not an ingrowth stem. Allows for some rotation.
Yeah. Okay. And then one also for Dr. Paksima. Somebody was just asking about how important the relationship between yourself and the physical therapists and occupational therapists that are working with patients that have a, Volkmann's contracture. How involved are you with that?
Yeah, thank you for that question. It's super involved. I mean, basically, as with all things hand surgery, the therapists make us look good and save us all the time. And the feedback that you get from therapy is incredible. So, in that particular case, for example, the multiple variations of splints, kinesia tape, and things were needed to get that patient back. So that's a very important point. Thank you.
Awesome. All right, so we're gonna head on to some upper extremity complications. A couple cases. Dr. Konda is going to moderate that. Go ahead.
All right, thanks, Meelan. I'm going to share my screen. All right, everybody. So I think this is going to be an interesting style of presentation. What we'll be doing is we're going to be going over cases that have had complications in the upper extremity. Our panelists today are Dr. Egol and Dr. McLaurin. So we'll be directing, questions primarily to them, but certainly would love for any of the other panelists for any of the other sessions to chime in, comment, and or ask questions. I'm sure a lot of the attendees would have a lot of similar questions. And again, for the attendees, certainly please, again, log on to Slido and ask questions that you have as they come up. Now, for the first case we have here, I'm going to throw it to Dr. Ganta. Dr. Ganta is going to talk about this first case.
All right, so I just went on a whole thing about how awesome dual plating is, and then this is some time to air out my dirty laundry. This is a 20-year-old female who she fell while intoxicated, sustained a left clavicle fracture. Had a pretty long conversation about operative and non-operative management with this patient. So, for her, I told her she's a high risk of non-union. Then these are not films are not even standing; they're supine, so she's lying down on these, and it's a transverse fracture, and it's pretty gapped. And so I discussed operative and non-operative management. She was pretty adamant about not having surgery. She came in a week later, fell again. I think she was also intoxicated at this point as well. Felt like she re-injured her clavicle, and she wanted to have surgery done at this point. So took her to the OR a week later, did dual plating on her as well. Case went well, no issues. And then I saw her at about a week and a half, and then sent her to therapy. And she felt a pop. And I took a look at the films. I didn't really notice anything strange. Retrospectively looking, I can see that there's like a pretty significant angulation between the medial aspect of the clavicle and where the plate is, but She had a little bit of erythema around her suture. I thought it was maybe a suture abscess. She denied any fall. So put on antibiotics, saw her back, wound healed, same thing. So I got bilateral clavicle films just because that angulation looked a little weird, but she really wasn't too tender around this area as well. And just continued to monitor it. She was actually feeling better, had less pain. And I saw her basically at 3 months. And looks like she apparently fractured on the medial aspect of her clavicle. Because you could see when we were looking at her, there was a pretty, you could see a deformity there. And you can see a lot of callus formation at 3 months. And she really wasn't painful at this time. And I had a pretty lengthy discussion. So I was like, we could take you back to operating room, span this whole area. It's really for a cosmetic purpose at this point. There's a little mild prominence there, and she was feeling pretty good. So we continue to just monitor it non-operatively. And I haven't seen her back since. She's supposed to come back in the next couple of weeks or so. So I'll see how she's doing. But a couple of things that I noticed from this. I think I ended the plates kind of at the same level, and I think that's potentially caused like a stress riser. She's young and she has good bone, but I kind of wouldn't expect this to happen. But she's asymptomatic, so I just kind of going to keep my eye on it and treat her non-operatively at this point.
Okay, great discussion, Abhi. So I'm going to ask, let me start off with Ken. So Ken, can you talk a little bit about fixation construct? What is your preferred fixation construct for these displaced clavicle fractures that you've indicated for surgery?
I use a superior applied 3-5 pre-contoured clavicle plate now. And my rate of hardware removal is exceedingly low. I think a lot of the old literature about clavicle hardware removal was centered around before we had pre-contoured plates. What you used to use was a 3-5 DC plate, really big plate. And since we've gotten rid of those, I've seen a lot less hardware problems, regardless of how it's applied. This is one that I might have considered, given that she's a young girl and it was a transverse pattern. Might have considered a nail for this one for surgery. I think this is the one pattern that I would consider doing a nailing of a clavicle fracture. Although the downside is there's potential that you're going to start and need to have hardware removal there, because those tend to be prominent at the insertion point.
And so going along that line with regards to nail, so is there use like a lock nail type device, use like a smooth pin?
And I wouldn't use the smooth pins anymore, or even the threaded pins anymore. They make clavicle plates that have deployable talons to allow for locking, and a jig placed locking screw proximally, and similar to the way they have the implant for the fibula. It's a similar implant. So that's what I would use if I was going to treat this one, I think.
Toni, what about you? I'm going to go back to the actual fracture pattern, and I know you discussed with us earlier that you're an anterior clavicle plater, but I do know through experience that you have, of all the surgeons here, you probably have nailed the most of these. Maybe a long time ago. I don't know are you still doing that at all for any of these?
Yeah, I agree with Ken. I absolutely, if I've decided to operate on this, I would 100% nail this. And I just use a flexible nail, like a pediatric flexible nail, put it in from the medial side towards laterally, and it's got that little curve on the end of it, and it goes into that flat area of the clavicle out distally by the AC joint. And then basically what you do is you put it in, you get it where you want it, back it out about a couple of centimeters and cut it, because you can't cut it flush to the bone. You just can't get that close on it, and then tamp it back in. So thank God no one has ever wanted one of them out that I'm aware of, because I don't know how you would ever access it because it's tamped in there so far. But I mean, it is rock solid fixation. The medullary canal of the clavicle is so small. I had one patient, I actually put in a 1/6 femoral nail, which is like a K-wire essentially. But that's what I would have done with this one. I would not even have considered anterior inferior plating. But I do, the one point I did notice, which Abhi did say when he was discussing it, is that I definitely, I would not, if I were using two plates, which I don't, but if I did, and same thing in the distal humerus, I always make sure they do not stop at the same place.
Right. So that's right. Dr. Paksima, so you've got a question.
I just wanted to say, was this a segmental fracture, or did it really just break because of because there was a stress riser there. I don't know. Am I seeing something, or is this a segmental fracture?
Looks to me like a transverse fracture. Abhi, you were there. Did you see anything medial to your plate?
I didn't see anything. I thought about that too. Maybe I missed a non-displaced fracture. I tried to keep the periosteum and everything intact in that area, so try to avoid aggressive dissection. But it's possible. But I didn't see another fracture line.
Toni, I'm intrigued on the nailing part of this, because I plate too, and I similar to Ken, I do 3-5 pre-contoured lock plate. But I guess from the non-lock type of nail, I guess my concern has always been migration. There are only case reports out there of migrations of non-lock nails migrating into the mediastinum. I mean, it obviously can't be that common, but I think it was talked about enough that I think it scared a lot of people away from it, and me in particular. What are your thoughts on that? I mean, is that something you're concerned about? You talk to the patient about it? Are you following them? Like, how are you following them any more closely, or not at all?
No, I don't follow them any differently. I follow them until they heal, and sometimes people come back. They want their yearly checkup, and they'll come back, and I'll of course re-X-ray them, and nothing has changed. But I think the difference is it's not just a smooth pin. It is actually because of that hook that's on the end of it, that sort of curved area, and it flattens out. And so I think that makes it a lot harder for it to move around once it's in there. I mean, and it is such a tight canal. And I think that's the other thing too. It sort of follows the curve of it more than just like a wire would, where you're just sort of crossing it. And also because I come in medially as opposed to approaching it laterally, where you're coming posteriorly, and it's more straight. So in the medial one, it actually has to kind of follow more of a curve to get to the fracture. So I think maybe even like the bend in it, I don't know if you get like some 3-point, bending or something in it, but it just, I have done it, not a lot. I don't think there's a lot of fractures where it's indicated. People have written about doing it for comminuted fractures. I never have. But when I've done it, I've not had any issues of any migration.
Okay. And then again, technical point, what size flexible wire? I think the 1/6 you said that you always use, or is there?
No, that was just and the other thing is too, it's described actually as doing it closed. There's no way you're ever going to get this thing reduced closed. So I make a small incision directly over the fracture. I get it reduced, and I actually now have started drilling into the ends of the both ends of the fracture, just to make it a little easier to pass across the fracture. And I just sort of, look, I mean, the canal is tiny, and I just look at it and I start to pass it from the medial side. And if I'm really struggling to get it across, then I'll just go with a smaller nail, but it's usually around a 2.4, actually, sometimes a 2.0. The 1/6 was just kind of ridiculous. Okay,
interesting. Now, Abhi, I wanted to go to the actual plating construct, and you talked about this in your talk. It looks like, so can you describe the plating construct that you have here? Like, what size plate is where? I know you went over this in your talk, but just to remind everybody.
7 recon on superior aspect and a 2.4 DC in the front anteriorly.
Okay. And then do you take into consideration, are you using locking screws as a young adult? Do you use locking screws? You don't use locking screws, just depending?
I don't really use locking screws unless I'm losing purchase on one of the screws. And it's usually on the lateral side that I would end up using it for. But for her, I didn't use any locking screws.
Okay. Yeah, it's interesting, obviously in retrospect, right? If we think about like stress riser effects, when I look at this now, what I'm seeing, you had a stress riser from your superior plate on the dorsal cortex. You have on the anterior cortex like almost two stress risers at the very end of the plate, but then also your screw, and then also on the inferior cortex, a screw kind of is penetrating. And certainly, if you miss, let's say you had to re-drill, that's another. Maybe you have a hole there. I don't know if you can even remember that, but there starts to be a lot of areas where this type of construct can fail. But I think we're going to see this a lot more common because we're seeing a lot more literature on this.
I try to make a point now after this case to really make sure that my plates aren't overlapping at all.
I just want to say that I'm fascinated by the fact that a lot of the younger trauma surgeons are now doing all of the using plates and doing their own contouring of them, because we lived through plates that we had to contour ourselves and we were all really excited to get pre-contoured plates. And I fail to see the appeal of having to contour your own plate. It's already done. Just use it.
I mean, is there? But yeah, it's a great question. Is there a sense of artistry, ownership of the fracture when you've added your own flair to it?
No, there's a sense of pain. It's just pain.
It's called reinventing the wheel.
Exactly. Yes.
All right.
See all the old people chiming in here.
I'm thinking about going back to fixing displaced femoral neck fractures in old people. Maybe it'll work now.
All right. We have a talk on that later, Ken. I'll get to that. Okay, interesting. I did want to ask a question here. And you had mentioned this during your presentation, but was there an inciting event? Did she fall and she felt this pop, or?
I mean, her story is a little like on and off, but she said that she was in PT just moving her arm and she felt a pop, which I find it really hard to believe. But it's possible that it could have just been during PT, or she could have fell at some point, after surgery.
Yeah, the one thing we should go ahead, Toni.
I was just going to say, I had a patient this happened to. I saw him at 6 weeks. Everything looked great. And then at 8 weeks, he called me and said, I heard and felt a pop, and now my shoulder looks funny. And so I was asking him, well, what were you doing? He'd been in physical therapy, and the therapist had been using the hand bike. So for 8 weeks, he's going like this and cycling his hardware essentially. And then it finally failed. So I always specifically tell them no hand bike. But so she probably wasn't using the hand bike, but that just put it out there.
Yeah, I remember you telling me that when I was a resident, and I make it a point now to make sure that it's just cyclical loading. It's like, it's cyclical loading constantly on something that hasn't really quite healed yet.
All right, great discussion. Move on to the next case. All right, this is my case. I'll talk about that. This is a 67-year-old right-hand dominant male. He's got a past medical history of a seizure disorder. He sustained a ground level fall, likely due to a seizure. He ambulates with his cane. At baseline, out in the community, this is his X-rays. Shows here a 2-part surgical neck fracture, displaced. First question I will throw out to everyone, and in hindsight, I probably shouldn't have operated on this.
Correct.
Because as I said before, and for everyone listening, 95% of all proximal humerus fractures are treated non-operatively, and there are studies out there that show that these do very, very well. That being said, I did decide to operate on this patient. I do like to do intervention nail as my bias, especially for 2-part fractures. So this is my intraoperative X-rays. Now, just to give you a little bit of background, I mean, the patient does have a history of seizure disorder. He had a seizure, it appears, when this happened. We did get him worked up for the seizure disorder and the seizures under control prior to taking him to the operating room. Part of my thought process was being a little bit paternalistic here, saying that, this guy is going to go back out into the community, and if he has another seizure in the next few weeks, am I going to be left with a much bigger problem in this shoulder that's going to be much more difficult to treat, as opposed to something I think here that could be done very, very quickly and easily in a relatively percutaneous manner. Bad choice by me. So here's the intraoperative films. We see here just a 2-part fracture. I do like to do percutaneous Simon pin and or Schanz pin fixation into the proximal humerus percutaneously to get control of the head. And then you see here a 4mm Schanz pin into the shaft. So now we have control of the proximal distal fracture fragments, and under fluoroscopic guidance, relatively easy for a 2-part fracture to get a relatively anatomic reduction. You can see here in the top X-ray, although we're still in a little bit of varus, as the nail goes in, it will, because it's a bent nail, and our starting point is relatively central, the nail will then kick that proximal segment into the remaining kind of few degrees needed in order to achieve a relatively anatomic reduction. And then this is my fixation construct on the right. And we can talk about this. I have really 2 points of fixation in the proximal segment, probably woefully inadequate, but only 2 points of fixation. There's a 3rd point of fixation, which is really kind of crossing the fracture side. I don't really think it's doing much at all. I think I put that screw there because I thought maybe it was doing something for the calcar region, but I don't think it's long enough. But I think that the reduction is pretty good. Anyone want to have any comments?
I think you sunk the nail too deep. I think if the nail had been a little bit, not a little bit closer to the top of the head, you would have been able to get, basically 4 screws into that bad bone of the humeral head. Now, I don't know what happened to the patient, but I think we want to try to keep the nail away from the top so we don't get impingement. But I think that one might be a little bit sunk too deep.
I would agree with you.
That was exactly my thought when I saw that. And you said it yourself, you only have 2 screws in there. And you're already concerned about this guy, and he's going to put some weird forces on his shoulder. And then you have really limited fixation. And especially I know they're out of plane with each other, but not nearly as much as if you could have gotten that 3rd screw in.
I agree, 100%. Yeah, I agree. I think that I think my focus on these cases with the short proximal humeral nail, unfortunately, at this point, has been trying to make sure it's not too prominent, because if your starting point is not truly center on an X-ray, it's hard to tell where the nail is, because I think the proximal humerus curves so rapidly that if you're off center on either on the AP view or the lateral view, it's hard to get an X-ray showing where exactly you are in relation to the articular surface, because even through a mini open or an open approach, when you're looking through the rotator cuff, you can't really see the top of the nail. And so I've always focused on trying to make sure the nail is not prominent. In this case, I agree that I sunk it too far, and I was only really left with 2 points of fixation in someone who's relatively old. And so setting myself up for disaster.
Sonny, are those, I see some extra, I don't know if those are pins or drill bits. Did you put those in as blocking?
So they're in there primarily for reduction aids. So I percutaneously placed in order to then get like rotational control. I like putting them in at like about 90-degree angle. And so you can get rotational control, but then also change your varus valgus angulation. I do try and put them in a position that is going to be slightly medial and or lateral to like a center starting point on the humeral head. So they're out of the way of the nail. Moving on, 6 weeks follow-up. So the patient shows up at the 2-week visit, is doing fine at the 2-week visit. Sutures are removed. At some point from the 2-week to the 6-week visit, the patient does not endorse any frank seizure activity. Overall, I actually think
nail's in better position now.
Say it again, sorry.
The nail's in better position now.
Right. He actually feels pretty good. Although it does say that his shoulder looks a little bit more swollen, but clinically he's not having any pain at this point. And is actually pretty happy with everything. Honestly, I see the X-ray and I'm very upset. I go talk to him. I say, hey, look, we got to do something about this. And he doesn't want to have anything to do with it. He says, my shoulder feels great. I don't really think I need anything done. Any comments? One thing I'd comment on is it's interesting that what we see here is sort of, proximal migration of the shaft with probably lateral migration of the shaft. Interestingly, the screws have stayed in place and the screws haven't migrated. I think in this nail in particular, there are some threads within the nail or some sort of bushing within the nail that allows the threads to sort of, quote unquote, be locked in place. They're technically not locked. I have seen screws back out before. But in this scenario, it's just like a true, kind of a pull out.
This is what the X-rays look like on all those Chinese studies with excellent results.
I think it screws in back out because they're not cycling, right? The head was never attached to the.
That's a good point.
Yeah, so I think this is, like you said, probably non-up. It looks better.
Yeah, it looked great on the original injury film.
Yeah, it looked better the first time.
It looked like less. It was less.
Yeah, it was in a lot less varus in the injury.
Yeah. If anything, now, right, as the humeral shaft migrates proximally with the screws locked in place, it's only going to tip this thing into more varus.
I don't think it really matters. I think this may have ended up like this without hardware.
It's
right.
healed.
So this is the thing. I think it would have ended up in this position.
It's healed now.
I agree with you, Nirmal, right? So probably this thing would have migrated proximally a little bit without surgery. What do you think about the amount of callus formation in 6 weeks? You guys think it's normal? Too robust? Anything that may have caused
a lot of irritation callus.
You see that, right, with fractures that with hardware that displaces, they do get a lot of robust kind of callus formation. Is anyone concerned about infection?
Right. That's the only thing I would tell you, that, think about infection when you get a lot of callus, because that could be bony reaction. So if you don't think it's infected, then I guess it's just your hardware.
Right. Yeah. So, it's a good point. I'm only thinking about infection now for the first time that we're talking about it. But I
Better
agree.
late than never.
Probably the first thing I should have thought about is, okay, why did this fail? With this amount of like periosteal, quote unquote, periosteal reaction or callus, not quite sure what, I should have been thinking, okay, is this guy infected? Clinically, never had any signs or symptoms of infection. Happy as a clam.
Don't look.
If you don't look, it's not there. Okay. And then here he is at 3 months follow-up. 3 months follow-up, still doesn't want anything done. At this point, I haven't even recommended. I mean, I agree with non-operative management. He does have limitation of forward elevation. He does have impingement. It's non-painful for him. His shoulder elevation is probably around 100, but he's happy. He can weight bear with his cane. He uses his cane in his left hand. 3 months is it. I think my conclusion from this is consider non-operative management.
Yeah.
More fractures.
The conclusion is, if it looks non-op, it is non-op.
Don't be paternalistic. Don't think you can figure out someone's whole life story and trajectory in a 5-minute encounter.
Yeah, don't operate based on what you're afraid might happen down the road.
True sometimes. All right, let's move on to our next case. Dr. Ganta.
All right. So it's a 75-year-old. He actually has a pretty bad heart disease. Fell about, I think, 10 to 15 steps, has 100% displaced 2-part proximal humerus fracture. And then the guy is actually independent, relatively very active, lives by himself, is his dominant hand. And, I have a scan on this, which, but it's 100% displaced. No, not really too much cortical contact. So to me,
100%.
It was on the CT scan. There wasn't any, it was very little cortical contact. So I was worried about healing for this guy, and it's his dominant hand. It's kind of what he uses to take care of himself. So I decided to fix it. And use plate and screw construct. If you look back, he doesn't really have much medial hinge along the inferior calcar that's attached to a fracture fragment. I thought the alignment was reasonable when I fixed it, and I was very happy. And then I saw him back at 6 weeks. I let him do immediate range of motion, and then he already collapsed, and his screw started penetrating anteriorly. I talked to the patient about this, that there is a screw in his joint, but it's pretty anterior. So really the only way that it was going to engage his glenoid or cause some glenoid erosion is if he had a lot of internal rotation. I wanted to make sure that we just kind of keep an eye on it, and I wanted to get more healing in before we did anything else, and let him know that there's a potential chance he needs to potentially go back to the operating room for either a revision, either a reverse total shoulder, a revision, or just exchange of the screws. And so kept a close eye on him, saw him back later, I think probably 8 weeks or 10 weeks, somewhere around there, or 3 months. And it looks like his screw penetrated a little bit more along the anterior cortex. And at this point, I got a CT scan. It did have a decent amount of healing posteriorly, not as much as I liked anteriorly. So I wanted to maintain the hardware. And it was really that anterior superior screw that was the big issue. But took him back to the operating room and exchanged a couple of the screws out, tried to make them a little bit shorter. And the guy's motion is actually really good. He doesn't really have much pain. You can forward elevate to 140. And then this is him at his most recent visit.
How far out is this guy now?
He's about 6 months now.
Yeah, this is AVN.
Yep.
So Ken, why do you say that? And can you tell us a little bit about what you're looking at on this X-ray? That's
when I see that amount of that collapse early on, and even if the articular surface maintains its shape like that, if you get an MRI in this, you're going to see AVN. That's what this is. Even with that, you did everything right. You put the cement in there, and the good news is that even with AVN, this has maintained its spherical shape. he's going to be okay, because very few people with AVN of the shoulder, if it's subsegmental, it's very small portions of the head, go on to need, shoulder replacement conversion down the road. I think he'll probably be okay, but that's what this is.
Yeah.
Ken, I'd like to ask you a few questions, and then Toni, I'm going to throw it to you. If we go back to just intraoperatively, I think this looks anatomic to me. It's a great reduction, Avi. Plate positioning looks great. Two things I would ask Ken to comment on. With regards to the plate position, what do you think about the calcar screw placement? Is this an ideal location for you? Do you like to go even a little bit more inferior? And the second question I'd have for you is calcium phosphate cement placement. Where are we supposed to be putting it? Are we supposed to be putting it in the center of the area where there's a lot of bone loss, or are we trying to aim it more into the medial calcar area where there is not a cortical strut?
I'll answer the second part first. My opinion is I scored it wherever it'll go. I put it where the hole is. I try not to aim for that medial calcar area because you'll just squirt it out and it'll be encasing the axillary nerve. But the thing that I've learned over the years is I don't think the screws need to be this long for this very reason, because this has happened to me many times. So I don't really care about getting these screws into that very near subchondral bone area. I just like the spread and get it kind of almost like a TP, just kind of like supporting the head. I don't think the screws need to be into the bone as far as they are, because you'll get this every once in a while and then it's a problem. So I tend not to put my screws in that far. Everything else I think looks fine. Yeah, I mean, the calcar screws could be a little bit lower, but I don't think this was I don't think this is a problem of the inferior calcar. I mean, it is a problem of the inferior calcar, so probably that's the involvement is what probably led to AVN, but
it's interesting because when you look at, all the X-rays up to this point, I agree. It's hard to see, it's hard to tell that there's not much bone stock there. You were there intraoperatively. You probably saw that there was missing bone. Let me go back to the injury film itself.
Yeah, there was not much bone stock there.
You don't have do you have a good X-ray, like a good AP X-ray? I see internal rotation on both here.
No, I pulled these X-rays, and so sorry I didn't include it. It was poor quality. Poor quality. That's why I didn't include it. But one thing I thought was, on this X-ray here, so this is your 3-month X-ray, you get a better sense, and I don't know if there's like fracture resorption here going on, but here you can really see that medial calcar appears as though not much there.
Yeah, there wasn't much calcar intra-op, that I could really use. Like, there wasn't really like a large medial hinge that you could really get like a nice cortical key on.
Yeah, but it wasn't, for me, it wasn't like this thing fell off into varus, which is what will happen if you don't really support that medial calcar. It just kind of it collapsed.
Yeah, it kind of settled backwards laterally. Because your neck shaft angle still looks pretty good, right? Maybe a little bit of varus.
Go back to the immediate post-op.
Media post-op is right here.
No, the one before that.
Right there.
Yeah. So look at the relationship between the articular surface and the greater tuberosity, and then go forward.
Yep, here, yeah.
And then go there. You can see that just, the tuberosity is still there. And the head, the anatomic neck just kind of dissolved a little bit and it settled down.
Yeah.
It's interesting.
All right. So the takeaway messages are, potentially consider shorter screw lengths, use of calcium phosphate or some sort of other augmentation for lack of medial calcar to help prevent settling. All good points. And then AVN, looking at radiographic signs of AVN. You may even start to see here at that super medial aspect of the humeral head, some irregular contouring now.
It may collapse over the next few months. Add a year, it'll look different, I bet you.
Anyone consider using a fibular strut for this, for medial calcar support? Or I didn't think it was necessary for this one, but I wonder retrospectively if that would have made a difference at all.
Yeah, I don't think looking at this one, I would have done that. I do that for the ones where you have like this little sliver of head and you just can't get it to stay where it needs to go. And you need something in there to prop it up. But with this one, I thought you had, adequate head to get your fixation in. And I think it's like Ken said, it's just AVN. I don't think it's anything that was done incorrect technically. My one comment is that this particular plate design, I think, does put your calcar screw. It doesn't put the calcar screw in the right spot. I think that's a function of this plate. But that being said, I don't think that was the issue.
All right, now we've run over into break time. I think we're having a good discussion. If you guys want to, we could do one more case, or we could move to break. Toni and Ken, what are your thoughts?
I'll do whatever you want.
Yeah, you're the moderator.
Let's do one more case. I'm going to jump to a case where I wish Jadie had been there with me in the operating room.
So why'd I bother preparing any cases for you, Sonny?
Did you? I was going to get to them, Toni. Well, we have a good.
Save them for next year.
We have a good bank now.
I'm good now.
We have a good bank. So here is. To go live.
Oof.
All right, so 70-year-old female, right hand dominant, open distal radius fracture, past medical history, hypertension, hyperlipidemia. She's a kidney donor, which is why she has one kidney. Very otherwise, functional patient out in the community. Has this fracture pattern, so comminuted intra-articular.
What's the one kidney thing have to do with anything? Her renal function is normal, so her bone health should be whatever it is for a 70-year-old, correct? She's not on dialysis, is she?
It's a very good point. That's why I brought it up. Her kidney function is normal, so this shouldn't scare you.
Oh.
Thank you, Ken, for making my point.
No, I'm not scared. Thank you.
Good. All right, this is our fracture pattern. Okay, these are my, so we took her back for urgent irrigation debridement and operative stabilization fixation. This is my final construct. I think I was a little bit concerned about the open nature of the fracture, of putting in a lot of hardware, but that being said, I still put in this dorsal bridge plate. And so, maybe my logic is flawed here. But looking back at this in hindsight, what ends up happening is this ends up failing. I had just K-wire stabilization of the styloid and the lunate facet fragment, which I'm hoping that my dorsal bridging plate is just acting as an X-fix. It's just going to keep things stabilized. So, I have treated some fracture patterns like this in an X-fix with K-wires. And I think my thought process was, what's the difference between that versus a dorsal bridge plate with K-wires? As we move on, okay, this is her 2-week post-operative visit. Now, usually I don't get x-rays at 2-week post-operative visit, but when I saw her, clinically, her wrist looked deformed. It looked different than when I had left the operating room. And she was in a lot of almost like, radial deviation. You can see here, AP and the oblique don't look so horrible, but on the lateral view, she's got frank displacement of her distal segment. And I believe, if I remember correctly, this was probably her, I can't remember if this was her lunate or her styloid segment. I think it was her styloid segment. Could have been the whole thing. So I took her back to the operating room, and then we revised this with this construct. So I did have buttress fixation of her radial styloid and a volar locking plate. I kept the dorsal bridge plate to neutralize the fixation construct. And in fact, I thought her DRUJ was a little bit unstable or wanted to increase the fixation. And so I put these radial ulnar joint pins in. Here she is at 6 months now, and she's doing relatively well. She's got no pain, but she's stiff. I think she's got a malunion. She's got loss of radial inclination, and she's got a neutral volar tilt. But I think that she's happy and functional. I'd like to get comments, critiques from the audience. Jadie, what are your thoughts? I mean, is this a construct we should ever be doing when I go back? I mean, now in my mind, I'm kind of like, no, this is for something that's comminuted as this.
Yeah, I feel like if you had an X-fix, it would have also displaced. I'm surprised that it translated, but I guess maybe, if there's a lot of volar comminution, you have to consider putting a volar plate on also.
Yeah, I'm wondering if it translated. Now that I'm thinking about it, I'm wondering if it translated because, these pins that I put in, quote unquote, the DRUJ here are not really, those pins are going into fracture comminution to the radius, yes, right? Yes. So I'm wondering if the ulna translated and then pulled everything with it. You guys agree?
you never, if you look at your construct, I don't think you ever fixed the articular segment back to the shaft. That was,
No, I didn't. I think I was just hoping to just like bridge it.
It was just floating
hoping,
there. You know what I mean? You don't have, and that's what the problem was. You don't have anything that was, I think if you'd have put those wires from the styloid into the proximal shaft, you might not have had this problem, but everything's in the distal segment if you look at that lateral. So you have that segment's free to just, there's nothing there. There's nothing holding it at all.
Would you have expected it this? I mean, I agree with you 100%. That especially that radial styloid, I've been looking at it now, that's in nothing. It's just floating. But would you still, with a dorsal bridge plate, you got such, you're so close to bone with this. I mean, would you still expect your volar surface to translate anteriorly?
Yes.
You're nodding. I guess the answer is yes, right?
Well, I'll tell you a funny story. On a case I did with Omri a while ago, it was a volar shear fracture, and we plated it volarly, and the lady was blocked, and she was put in a splint post-op. And we got x-rays of the hand for some other reason the next day. And while she was still blocked, no muscle function, and in a splint, she still displaced that volar fragment with hardware in.
Huh.
So with nothing acting on it, it's still displaced.
I think you can't do any spanning fixation or X-fix without putting supplemental KVAR fixation. I think just because you put a spanning plate doesn't mean somehow that your articular fragments are going to stay where they are, as you found out here. And I think, as Ken pointed out, and not only would I have put a styloid wire, I would have put a wire from the ulna dorsal aspect of the radius going into the shaft as well. So you have additional fixation for the articular surface, and you can come back and do what you want, but at least that would have held your joint, and that might be all you might have needed.
Right.
And then you can put the wrist spanning plate on the second metacarpal. That gives you a little more ulnar deviation and gets your radial height back.
Right.
And since you use a DC plate, there was a potential to put a screw right there from dorsal to volar into the fragment. And I know you probably didn't want to bone graft it because it was open and dirty. But even if you go back to the original film real quick, Sonny, when you can really see that teardrop segment right over here. I don't know if you guys can see my arrow.
No, unfortunately not. But you're talking about where here
on the lateral film.
Lateral film.
Lateral film. Yeah.
Right
see that triangle right there?
Yeah, right
here. A little further to the right.
Yeah.
That guy. That's the volar teardrop, right? So you can see that so whenever you have that teardrop that's so displaced, a combination of a dorsal and volar plate is nice. Or if you're just going to go dorsal, bone grafting the metaphysis and then dropping a screw from P to A to just kind of hold it in place may have helped as well.
Okay, thank you all for the advice. And I agree. I mean, I think that in hindsight, I think my problem here was multifactorial, but certainly I had zero control of the articular segment. My K-wire here just floating in space. So, point taken.
Wow. I like the idea of the dorsal spanning plate on this because it's dusted, it's difficult, it's very distal. So
I have found also. I mean, I know there are like company-specific plates that are more low profile. But I have found that if you are stuck in a situation where you don't have that specific company's plate available, that just a long 3.5 LCDC does work well. And now, because these are locking plates, you have the option to put locking screws in our geriatric population. So I think that's really useful.
Yeah, I just feel like the more I do distal radius fractures, and I don't know, I feel like I'm getting worse ones and they're more comminuted. And it's like the more I do them, the more I'm thinking that maybe I should not be doing them because I don't know. I find there's so much going on in the distal radius and that, that I'm missing something. Like Nader pointed out, you see that one thing and he could predict what was going to happen. I would not necessarily have made that same prediction. So I'm not 100% convinced that I'm the right person to be doing these. And I'm sure, the hand guys are clapping about that and saying, yeah, these trauma people need to stop doing distal radius fractures. But I don't know. I feel the older I get, the less competent I become at these.
You're not alone.
All right, guys.
I feel the same way.
All right, guys, great discussion. We went through our break time, so I hope everyone else had a chance to take a break. Maybe this is just for ourselves. But we are going to proceed to stay on track, moving to our next moderated session. And so our next moderator will be Nicole Stevens.
Everybody, we're going to start moving on to the lower extremities. So our first talk is damage control, pinning of displaced femoral neck fractures. When is it okay? By Dr. Konda.
Thank you, Nikki. All right, let me share my screen one more time. All right, everybody. So this talk is damage control, pinning of displaced femoral neck fractures. When is it okay? Dr. Egol had alluded to this earlier when he talked about, and facetiously talking about, maybe we should go back to fixing displaced femoral neck fractures. So this is what, so what is damage control orthopedics? It's a real question, right? So damage control orthopedics, we think about in the high energy polytrauma situations, the under resuscitated patient who has multiple injuries, who's potentially crashing on the table. And what we're trying to do is any of the peripheral extremity injuries, we just want to temporize those extremities. And how do we do that? We typically put them into external fixators of some sort, but you could also splint them. But we want to do something to stabilize the patient in the immediate injury period until they are more adequately resuscitated, at which point, in a much more controlled fashion, we can go ahead and proceed with any definitive surgery if it's indicated. So what we're asking is, can we take that concept of damage control and apply it to femoral neck fractures? And typically we know that the treatment algorithm for femoral neck fractures, displaced femoral neck fractures, is that displaced femoral neck fractures do better with arthroplasty. However, in this day and age of value-based care, there are other things that we are incumbent to take into consideration. And are we actually providing the best quality care for the patient? Particularly, we think about the high-risk patients. With the high-risk patients, if we have a patient who comes in who's in acute decompensation, so a patient who has an exacerbation of a medical condition, CHF, COPD, pneumonia, MI, for instance, this is a non-optimized patient, and this patient may take several days or weeks to optimize. And what is optimization? Does it mean optimizing them just to get them to the point where they can safely undergo the surgery? Or is it where they can safely undergo not only the surgery, but be successful in the postoperative period to the point that they are going to have a much better functional outcome? And so we are proposing potentially to stabilize and fixate the femoral neck fracture, a displaced femoral neck fracture, via safe and minimally invasive surgery, which is closed reduction percutaneous pinning, to allow for early mobilization and early pain control. Can we maybe do this type of procedure on our sicker patients, get them to the point where they're able to mobilize, get up, sit in a chair, even ambulate in the immediate postoperative period? And if it's successful, then great, let's leave it at that. But if they are not, then in a much more controlled setting, maybe 6 weeks, maybe 3 months down the line, come back and then do an arthroplastic procedure on them, at which time they've had many weeks to optimize whatever underlying conditions they have. So we know with CRPP for displaced femoral neck fractures, there's approximately 40 to 50% failure rate. Most of these who do fail usually fail in the first 6 weeks, but it is a minimally invasive and safe procedure. And in fact, we have shown that you can do this procedure under local anesthesia with just sedation very, very safely. Now, the traditional treatment for these high-risk patients is hemiarthroplasty. It's a much bigger surgery with a higher morbidity. However, functional outcome is much better. Why? Because we can much more reliably control for leg length, for offset, for hip abductor strength. All these types of things are much more reliably restored with the hemiarthroplasty procedure. However, remember, still with an arthroplasty procedure, there is a risk of dislocation, something that is not present in our CRPP group. So with regards to reduction criteria, Lowell et al. Published in Core, there's something called the S sign. The S sign is looking on the AP and the lateral view of the femoral neck and seeing an S-shaped curve on both the superior and inferior cortices and also the anterior and posterior cortices. In contrast to the S sign, you have the C sign. This is a sign that you've maybe malreduced this. The femoral neck fracture is in varus on the AP if the superior cortex does not make that S. And these femoral neck fractures typically go into an apex anterior angulation with dorsal comminution. And so if you see that C sign along the anterior cortex, again, that's a sign that you potentially have not reduced this. Why is it reduction so important? Because it's the quality of the reduction, really, when you're doing a pinning, that is the most important with regards to the ability of this fracture to heal with the minimal amount of displacement. We really want to achieve an optimal reduction for displaced femoral neck fracture. Now, there's studies out there now that show that, closed reduction techniques are probably as efficacious as doing an open reduction. So I would advocate to you that a closed reduction, especially in a geriatric fracture patient, especially these high-risk patients, is all we're asking for. We're not asking at all to do any type of open reduction to achieve this. We're looking at a closed reduction and a percutaneous pinning. This is a picture diagram that's courtesy of Dr. Ken Koval. This is the concept of the pencil in a cup. This is the idea that where your hardware is placed along the femoral neck, very, very important. You really want to be placing your screws abutting the cortices of the femoral neck. If they're within the intermedullary aspect of the canal, the fracture will continue to displace until it hits your hardware. Again, will continue to displace until it hits your hardware. So therefore, it's important when we're doing our inverted triangle configuration, which is what I like to do, is to put those screws along and abut the cortices to allow for the minimal amount of fracture displacement. So we've actually studied this concept of damage control orthopedics. Is published in the Journal of Orthopedic Trauma. It's been well received, actually, with some editorials and actually other centers asking to potentially participate in a larger study. What we did is we took 15 patients who underwent closed reduction and percutaneous pinning for a displaced femoral neck fracture, and we compared them to a 2-to-1 ratio to 30 similarly stigma-matched, which is a risk score, patients who underwent hemiarthroplasty. This was a retrospective review of a prospective IRB hip fracture database. CRPP was done on patients that were deemed too ill to safely undergo hemiarthroplasty. These were patients who wanted operative treatment but still declined non-operative treatment. The hemiarthroplasty patients were matched to the CRP patients via stigma score. And again, we evaluated differences between CRPP and the hemiarthroplasty patients with regards to hospital quality measures, complications, length of stay, readmission, and then 30-day mortality, as well as inpatient costs. When we look at the patient characteristics, so these are the 15 patients that underwent CRPP. These are all patients, for the most part, who are really high risk medically complex patients, but these are also patients who are really not inclined to potentially follow postoperative protocols with regards to arthroplasty procedures. If we look at the first 2 patients, for instance, a history of alcohol, or first 3 patients, history of alcoholism. And these patients are patients who, after talking to them, it was very clear that they were going to go back out into the community, continue to pursue their lifestyle, and be very high risk for having complications with arthroplasty, primarily dislocation. But as you scroll down the list, you're starting to see patients that we were doing this on who were much higher risk. Some patients who came in with non-ST elevation MIs, look at patient 10, patient 11, patient had acute CHF exacerbation, patient 13 has bone metastasis of a visceral organ cancer. So this is patients with stage 4 metastatic disease. They're pretty high risk patients. Now, if we look at the demographic characteristics, again, because we were stigma matched, we found no differences in the demographic or injury characteristics of the patients who underwent CRPP or hemiarthroplasty. The mean age of the patients was around 8, and mean CCI was somewhere between 2.5 to 3. So what we found that there was really no difference in length of stay between these patients. So the sick patients who underwent CRPP versus the sick patients who underwent hemiarthroplasty. No difference in length of stay. No significant difference in the inpatient ambulation. We were able to look at the physical therapy records and see how far were patients able to ambulate in the hospital setting, and there was really no difference. No difference in the major complication rate. We did see a difference in the minor complication rate, a significant difference. Of the 30 patients who underwent hemiarthroplasty, approximately 50% of patients had some sort of minor complication. Right? And what were minor complications were acute renal failure, surgical site infection, UTI, and anemia. So that's a very stark contrast. The patients who underwent CRPP had a much lower minor complication rate. We found no difference in readmission rate at 90 days. There was really no significant difference in inpatient mortality, 30-day mortality, or 1-year mortality. I will point out that because this is a retrospective study, our study may not have been powered, right, to detect some of these differences, but clinically, looking at the numbers that we have, clinically, the numbers don't seem to be a significant clinical difference. Next slide. Now, another important factor that we took into consideration, not really taken into consideration, but we wanted to retrospectively look at was the cost. Now, if we look at CRP patients on average for their inpatient cost was around $21,000 compared to hemiarthroplasty patients, inpatient cost was around $35,000. Now, what was this major difference? Where was this major difference coming from? We told you that there was really no significant difference in length of stay. Okay, so it's not necessarily the number of days that we're staying in the hospital, but we are seeing is that there is a difference, although not significant, in room and board. Why would there be a difference in room and board? Probably because the hemiarthroplasty patients, due to intraoperative parameters, increased blood loss, just general feeling that this was a bigger surgery. These patients probably required a higher level of care, so we probably had more of these patients in a step-down unit or an ICU unit postoperatively. We did see a difference in pharmacy costs and lab pathology costs. Procedural costs obviously is where the big difference was, right? The hemiarthroplasty component is going to cost a lot more than just 2 or 3 cannulated screws. And so those were the major differences. So what's our conclusion? So our conclusion from this study is that CRPP, okay, as damage control fixation for displaced femoral neck fractures is a viable treatment. We had a decreased minor complication rate, a decreased rate of acute post-op anemia, decreased red blood cell transfusion risk, decreased inpatient costs. There was some risk of reoperation, but less than reported in the literature for foreign using proper techniques, and ultimately no difference in an outcome, we could say, with regards to mortality, ambulation, and number of feet walked in at least a short-term period. So again, to answer the question that this talk was set out to answer, who should we be performing this in? I would argue that we should be considering this option in medically unstable patients who are non-optimized, and potentially as a palliative procedure for patients with poor prognosis. The family does want to have some quality of life prior to the patient path. Thank you.
Thanks, Dr. Konda. Next, we're going to move on to Dr. Patel, who's going to teach us about efficient nailing tricks for femur fractures.
All right, thanks, Nikki. Like Dr. Egol's proximal ulna talk, no literature, but I guess some opinions. We could go on for hours talking about nailing femur fractures. I just wanted to focus on a few things that I thought were maybe a little off the beaten path. We all nail femurs, so not getting control. Oh, here we go. So pretty much any femur fracture can be nailed, anything from your intertrochs down to your ipsilateral neck and shaft and everything in between, even including your far distal intercondylar fractures are all amenable to nailing. I'm going to focus a little bit more on diaphyseal and proximal femur fractures. I think we have Dr. Ganta talking about the distal ones later. So I just wanted to I don't want to spend too much time on this, but just a quick polling question. Just curious on what people are doing out there for femoral nailing, diaphyseal, proximal third, distal third, what type of nails people are using. So A would be a retrograde nail, B would be an antegrade or cephalomedullary nail with a piriformis entry point. C would be antegrade cephalomedullary nail with trochanteric entry point, and D would be I use a hip spica cast. I'm not going to necessarily wait for those because I think there's a delay. We'll come back to that. Let's see. Maybe we got it. So it looks like nobody's going retrograde. Nobody's going antegrade with a piriformis entry. 67% use a trochanteric entry point and 8% use a spica cast. Guess we have a joker out there. So with just choices with nailing, again, starting points come up quite frequently with your antegrade nailing. There's your trochanteric entry point versus your piriformis fossa entry point. We have our retrograde nails, and then one thing that can often come up is for fractures that you could kind of go either way, your mid shaft or your the proximal third, distal third. The little bit of literature I have says that similar union rates for mid-shaft fractures, despite antegrade versus retrograde. The choice is often made by surgeon comfort level. A lot of times the body habitus. A lot of people are more comfortable doing retrograde nails in larger patients. And whether the patient has concomitant injuries may be a factor. For example, bilateral femur fractures, you may want to go retrograde because the whole setup for an antegrade nail, takes a lot of time. And also if there's any ipsilateral or contralateral lower extremity fractures that may play a role in your decision-making. But one thing to remember that's very important is that the risk of malreduction and malunion increases when your fractures are further away from the driving end of the nail. So the more distal a fracture is, the more recommended it would be to use a retrograde nail, and vice versa. So positioning and setup, your considerations are going to be what type of table you use. The biggest one is some people use a fracture table. Some people like to use a Jackson flat or a diving board type of table. If you're going retrograde, you're going to be supine over either a triangle or some type of a bump. The lazy lateral and full lateral positions, which I think a lot of fellowship trained traumatologists prefer, have a lot of advantages, but the setup can be a little bit more daunting if you don't do it often, in terms of whether you're going to use traction and what type of assistant you're going to have. So fracture table, which is what most people are probably comfortable with for your intertrocks and maybe some subtrochanteric fractures, and I think even shaft fractures, especially out in the community in places where people aren't nailing a lot of femurs. The advantages of a fracture table obviously are that you have consistent traction, but something to keep in mind is that the traction's great, but you obviously length is much harder to assess because you have no gauge of the opposite extremity. It can be hard to get a perfect starting point on a fracture table, especially in patients with larger body habitus, because the torso just gets in your way. You have limited ability to manipulate the extremity for getting a good reduction. And one thing, just personally for me, most people use a shower curtain. I like to use block draping for these, just 4 bar drapes, or at our institution, they're called top sheets. And that way you can really get maximum exposure of the entire thigh. So that, if you have to use any tricks or use any additional reduction tools during the case, the shower curtain just gets in the way, and inevitably the eye band gets wrapped up on your instruments, and block draping really eliminates all those problems. Retrograde nailing, I won't spend too much time on this because I think pretty much everyone's comfortable with retrograde nails, but just a couple points. One thing that can be difficult is getting the starting point, and I see the residents struggle with this when we do retrograde nails. You need the knee to be flexed over a triangle or a bump, but sometimes even then the tibia is still in the way. So sometimes you actually have to position the triangle in a way that you almost want the fracture to sag a little bit, meaning you're extending the distal femur through the fracture, and that in effect allows you to flex the knee a little further. It makes it easier to get the starting point. Your starting point is at the roof of the notch, just anterior to Blumensatz's line. And you do not want to be perpendicular to the joint line. The more perpendicular you are to the joint line, the more varus your fracture is going to go into. And you do not want to accept an imperfect starting point, because that will screw you up. This is just a demonstration of on the left here. You can see that the tibia is going to be in the way of getting your ideal starting point. If you flex the knee further, which is the middle image, the tibia is out of the way. So that's where you can sort of reposition your bump to allow the fracture to sag more proximally, and that gives you better access for your starting point. And the image on the right is just showing that the red line is if you were to enter perpendicular to the joint line, which is tempting, you're going to end up in bare. So you really want the green line, which is heading right up the canal. So now with our antegrade nailing, I think this is what comes up more often. I have a lot of non-trauma trained colleagues who call me for help when when they're on trauma call and dealing with these cases, and I'm always trying to convince them to position their patients sloppy lateral or lazy lateral, and they always inevitably end up either doing a retrograde nail or using a fracture table, and then they tell me afterwards how they wish they had done what I recommended. So with the sloppy lateral position, you can use a traction setup like in this picture here, where you have a pipe bender with a sterile rope and then just some sterile towels to cover it. You can use a bean bag or a bump. You just want to make sure that you can get a perfect lateral view of the hip. The advantages of nailing femurs this way, I think the biggest advantage is that you can adduct and flex the hip all the way across the other leg if you need to, and it really helps to get a starting point because you're getting the torso kind of out of the way. The further you adduct, the more out of the way the upper body is from kind of blocking the trajectory you need to get a good starting point. You have better ability to manipulate the leg for reduction. And another benefit is that you can either feel the other leg through the drapes, or you can even prep and drape the other leg so that you have the opposite side right in front of you to help assess for length and rotation. So this is just some photos of the setup. So basically you want a nice tight rolled bump under the hip. The torso is sort of, the upper part of the body is sort of flexed away from the opposite side. I used to use a bean bag, but I found that the bean bag just kind of takes up too much space under the hip and the proximal thigh, and it just gets in the way of getting your starting point. So I've gone to using a bump, but it needs to be a nice tightly rolled bump, not some sloppily folded up blanket that you just kind of shove under there because you don't want it to move and shift position as you're working. There's just an image of the lateral view on the C-arm with the hip bumped up, usually approximately 20 degrees or so, gives you a good shot. I don't do full lateral positioning, but it's definitely talked about. Kind of a similar concept that you're not sort of bound by the restraints of a fracture table, and again, just makes it much easier to get a starting point as you can sort of flex and adduct the hip, and thereby kind of getting a better trajectory. It also makes, if you have to open, which hopefully you don't, if you have to do an open reduction, it's just always easier to work on the femoral shaft when the patient's in the lateral position. In terms of antegrade starting points, the piriformis entry point is sort of the classic starting point. It's in line with the femoral canal, and the original nail designs were all straight nails, so it sort of made sense. But it became evident after a while that after some anatomic studies that the piriformis entry point is very close to the medial femoral circumflex artery and even the superior gluteal nerve, and can cause some serious complications. So newer nails have a proximal trochanteric bend, which has greatly improved our ability to nail these fractures without placing those structures at risk. There's been multiple clinical and cadaveric studies that have shown increased risk to the medial circumflex artery, the abductors, and the superior gluteal nerve with the piriformis start. So really, I think the piriformis entry is essentially fallen out of favor. So again, here's your piriformis entry point. Some people say that it helps to reduce your risk of varus angulation at the fracture, but again, with the newer designs, I think, and our better understanding of the trochanteric starting point, that's becoming less of an issue. And here's just another diagram showing, your piriformis start, which is going to be kind of right in here, puts the medial circumflex at risk. So for your trochanteric starting point, I think this is, for some people, this is something that really is hard to understand. The starting point is not at the tip of the trochanter. Some of the technique guides for the nails, when they describe the starting point, they're basically telling you to put it right at the tip. And I think it's pretty clear that that's not the best point for your starting point. You want to be just medial to the tip. If you put your starting point too lateral, the nail is going to kind of carry a medially directed trajectory, and that's going to risk perforation of the medial cortex. It's going to increase the risk that you're going to blow out the lateral wall, and it'll increase your risk of varus. This was a study that Ostrom did back in 2005, where he basically looked at different trochanteric entry points, and they had cadaveric simulations of subtrochanteric fractures, and they basically looked at starting points right at the tip, medial to the tip, and lateral to the tip. And they actually did this with, I think, 5 different nails. And unfortunately, I couldn't find all of the imaging with the medial and lateral to the tip entry points, but this is what they found with an entry point right at the tip, which, as you can see, for most of the nails, produced some degree of varus angulation and translational deformity of the fracture. In terms of reduction techniques, you want to kind of start with what's least invasive and go, progressively more invasive. I think the biggest point is that a perfect starting point, which you want to maintain throughout your procedure and during reaming and during nail insertion, is the most critical thing. You may start with a round hole, but if you don't take care to make sure that the hole stays round, it's going to progressively become more and more of an oval, and your entry point is going to migrate. Traction obviously is your simplest method of reduction. Strategically placed bumps or triangles. Some people use a crutch on the fracture table. I like to use a well leg holder, like you would use for the opposite side. And then one thing, this is getting into stuff, just some techniques that I've found that work really well over the years. One is fine tuning of your entry portal. So sometimes you're able to get your wire to sit right where you want it to go, but you can't quite get the right trajectory. So in that situation, you can kind of put the wire in, by a more medial trajectory, and then put your curved cannulated awl over the wire and use that to sort of redirect the trajectory, then drop your ball tip, and sometimes even use a reduction finger. And your preparation of your canal, you want to follow a trajectory down the lateral cortex, right down the canal, not heading towards the medial side. So again, just kind of fine tuning and maintaining your starting point. If your body habitus is getting in your way, you can let your wire kind of head a little more medial, and then use an awl to curve it in the direction that you want it to go. And then again, the reduction finger really can help. I'll sometimes put the reduction finger all the way down, even past the fracture site. And that can help a lot. And also, when you put the reduction finger all the way down, it can kind of give you a little bit of a preview of what your fracture reduction is going to look like with the nail in, because it's a larger diameter and it's stiffer than your ball tip or your flexible reaming rod. So, with the reduction finger all the way down, if you're seeing any deformity, then you may want to start planning, blocking screws or whatever your other maneuvers are going to be. Because that's going to that'll give you a sense of what's going to happen when you put the nail down. One thing that I've started using a couple of years ago is the Trefine opening reamer. It's kind of a different type of opening reamer that I think allows you to have a much more controlled entry point. It's great for intertrochanteric fractures or any fracture with osteoporotic bone. It has these really sharp cutting teeth that kind of cut a hole for you instead of the big opening reamers that come on these trays that can almost kind of push your fracture into a wedge type deformity. And you can make really fine corrections with it before you actually ream your entry portal. So this is just an example of kind of letting your wire head more medial than you would want your nail to go, kind of fixing it with your cannulated awl. And then here's the Trefine reamer, and you can see that even though the wire is kind of a little more lateral, you can push the reamer over more medially and create a much more medial hole than where the wire is. And then, of course, maintain the starting point. Use your soft tissue sleeve. Don't ream on entry and exit from the canal, because that'll just increase the risk that you're going to let the starting point migrate more laterally. And then just moving on with reduction techniques, blocking screws.
Patel, I think we're running pretty
We're running very low. Okay.
Yeah.
So just, just went through some of the instruments that you can use, blocking screws. I was just going to get into assessment of the length and rotation, but we can skip that. So just take home points, your nail type is determined by your fracture pattern, and surgeon comfort level, position, and setup, super important, as we've talked about with other fractures. And it's important to just have all your different reduction tools and techniques available when you're nailing femurs. Thanks.
Okay, next we're going to have Dr. Ganta, who's going to very quickly and timely, effectively talk to us about nail plate combos.
All right, so we're going to go over nailing, plating, and both for distal femur fractures. There we go. Kind of remember this whole thing again, the whole bimoral distribution, young patients, high energy MVCs, older patients, geriatric, osteoporotic fractures. But, the important thing on these geriatric patients too is there's a group of fractures such as peri-implant and interprosthetic fractures that you're going to see more and more often, which makes treatment of these injuries a little bit more challenging. I always talk about the complex distal femur anatomy. Unlike the tibia, the anatomic and the mechanical axes of the femur don't really match up. So they're off by a couple of degrees. So when you're trying to align a femur, you have to keep in mind that the two axes are not the same, and you want to restore the mechanical axis as well as the anatomic axis. By doing so, it's a little bit more challenging. And because of the complex shape of the distal femur anatomy, you have a trapezoidal distal femur, and, you have to be very cognizant and particular about the way you place implants in this area. Another challenging part is metaphyseal comminution. So, the distal femur itself is to me, it's a kind of a watershed area. You have an area of really good articular block, and then in the metaphyseal segment you get a lot of comminution, and some of the blood supply to the area of the comminution is very tenuous. And in mind, when you're trying to get relative stability within this area majority of the time. And when you're talking about your options for fixation, you have a lever arm that you have to work with. So when you're plating on the lateral side of the femur, and you have a longer lever arm to the mechanical axis of the femur, relative to an intramedullary nail construct, where the lever arm is a little bit shorter and a little bit closer to the mechanical axis of the femur. Because of this combination that you get unsupported medial cortex, and you get situations where the distal femur will fail into varus, and that's typically what you're going to see. And this is a patient that was actually fixed and it looked really good, and then eventually just over time started falling to more and more varus. So the goals of the procedure are to get an anatomic reduction, restoration of the mechanical axis, and you want what we say is appropriate mobility to the fracture site. So if you want to go for secondary healing at the fracture site, you want there to be enough mobility for callus formation and healing, but not too much mobility in which the construct will fail. And you want something not too rigid in which you're not going to get enough healing. All right, good. So some of the plating nuances that we talked about, because of the shape of the distal femur, the plate has to be applied pretty much perfectly along the lateral aspect of femoral condyle. And it's an anterolateral plate, so your screws are going to be aiming from more anterolateral to posteromedial, all right? This is somewhat parallel to, or perpendicular to the joint. And the same goes proximally as well, okay? So proximally, you want to make sure the plate is applied along the same axis in the same manner, because, you know, putting screws in the outer plane axis can either derotate your femur or push your femur into a different position. So, you know, plating is, while it's a good option, it's not something you can just slap a plate on. Same with the starting point for nailing. You know, Dr. Patel touched on this quite a bit. So we talked about start point must be perfect. There must be, you know, you have to make sure you're not eccentrically reaming, because when you have metaphyseal comminution, what ends up happening is the guide wire is going to drift towards the area where there's a path of least resistance. So even if you have it perfectly reduced, the guide wire will continue to drift. So you want to avoid eccentrically reaming and leading to malreduction, and you want to get your reduction prior to reaming. So because this is a capacious canal, your reaming is not going to reduce your fracture like it is in a diaphyseal fragment. And so we haven't talked about nails, talked about plates. So what about nail plate? So nail plate has been kind of described as to help not only improve the longevity of the implants, but also diminish the stress on each of the particular implants and allow for immediate weight bearing. So it's been published pretty extensively by Dr. Yoon and Liparaji, and they talk about the use of nail plate in more geriatric patient populations. So patients with periprosthetic fractures, osteoporotic distal femur fractures, and interprosthetic fractures. And the benefit is to allow the patients to immediately weight bear. All right, so, you know, when you have nail plate, you have a variety of options. You can do an antegrade nail with plate fixation, retrograde nail with plate fixation, and antegrade or retrograde, and use a provisional plate to basically get your reduction and hold your reduction. All right, which basically comes down to this flow chart for me in my head, which is very, very extensive, and it confuses me as well. So basically what we're looking at is any sort of, you know, intra-articular fracture. It depends on bone stock, the quality of the bone. And so to me, that's what dictates whether you're going to use a nail plate. And I typically tend not to use nail plate constructs as much in a more younger patient population. So when is nail plate not always possible or challenging? So when you have fractures where there's a stemmed implant, you have an unknown prosthesis, so you're not really sure exactly what the prosthesis is. You're not going to have any bailout options if the prosthesis is loose. And if you have a closed box total knee replacement. So, you know, while that's not like an absolute indication, you know, you can burr down the actual box to get your start point, but sometimes it's a little bit challenging to do so. So let's just go over a case real quick. 43-year-old male, motorcycle accident, open distal femur. Let's just go see if anyone would, what their treatment option is for this. I'll just keep going in the meanwhile while we do that, okay? So for this guy, I actually use a provisional plate laterally, reduces articular surface, held the joint in place, and then placed the nail. It's kind of like created basically a type, I guess a type C into a type B into just a kind of a sawbones, and then was able to pass a plate on, pass the nail through, and then reduces articular fragment and held it with, you know, separate screws. And this is him at about 3 months post-operatively, doing pretty well. So same thing, intra-articular distal femur fracture, same fixation options, nail plate or a nail plate. So this person was around, I think, 60 years old. He had a simple intra-articular split. So for something like this, you can hold the split reduced with provisional fixation, pass the nail through, all right? And then, you know, and then add additional fixation if necessary to hold the joint. But for this, because we had medial lateral screws to the plate, we didn't feel like it was necessary, and we're just able to treat with a single implant. And this is another case. It's a very large obese patient. I think she was BMI of like 55 or 60, very complex common intra-articular fracture. For someone like this, I think it would be a little bit, you know, more challenging to do a sort of plating construct. There's a lot of metaphyseal comminution, and the challenge for this patient is to allow her to immediately start weight bearing right away. And so for someone like this, we decided to use a nail plate construct. And you want to make sure the plate is span proximal enough to get some provisional fixation to the femoral head. And so that way you're trying to avoid any sort of stress riser or iatrogenic femoral neck fracture. and this is her about 6 months postoperatively. So another one case, 7-year-old female, periprosthetic distal femur fracture. I'll just go ahead and activate the slides, pull for this one. So to me, this is a osteoporotic patient. He had a lot of issues with his total knee replacement prior to the fall. So this was someone that I decided that a distal a nail plate would be appropriate. It allowed him to immediately start weight and had fixation into the femoral neck. So for someone like this, if you have the ability to, you can do a lateral peripatellar arthrotomy. Let's say midline incision, you can exchange as poly, do a retrograde IM nail, and span the plate into the femoral neck. So that way you're basically spanning the entire femur. You're creating some flexibility at the fracture site, and you can allow the patient to immediately start weight bearing postoperatively. So in conclusion, to me, what drives the fracture fixation is the bone stock, the bone quality, and a patient age. Regardless of the implant, I think the most important thing is the reduction of the construct and the stiffness of the construct. You want to make sure that everything is appropriately done so you can get the correct type of bone healing that you're going for. So the benefit for a nail plate is that you can allow them to immediately weight bear. It shows, like a lot of fundamental analysis demonstrate, that energy is distributed pretty equally between the bone and the implant. So not, for like a plate itself, the plate sees all the stress. For a nail itself, the surrounding bone sees all the stress. With a nail plate, you're basically able to see, you'll be able to get stress that's evenly distributed around everything. It improves the longevity of the implants until fracture healing, and it's potentially could decrease your risk of peri-implant fracture.
Thanks so much, Dr. Ganta. So we're going to skip the question section in order to get ourselves back on time. If anyone has questions, I will answer them on the Slido on the chat. So just let me know if you have any questions. And next, I'm going to toss it to Dr. Mehta to do the second lower extremity component.
All right. We'll move on to lower extremity injuries, part 2. We'll start off with Dr. Egol, tibial plateau fractures, tips and tricks.
All right, since we're behind time, I'm only going to give you the tips and no tricks. All right. So the first tip is correct diagnosis. You got to understand the injury pattern and patterns that are associated with under injuries. And these allow for surgical planning. We pretty much use the Schatzker classification in most instances, and it's important to classify it because that directs treatment. However, there are some that don't fit. And for those who know me, know I love this. And this is the Moore classification. And understanding this lets you know that this patient has more than just a fracture. There also may be some knee instability and or another injury, like a neurovascular injury, that might be associated with them. Be aware of unusual patterns. This is the hyperextension type injury. Doesn't fit into any of the classifications. These are associated with very, very poor outcomes. You need tip number 2, you need appropriate imaging. Nowadays, we have the advent of CT scanning. We get a really good depiction of the imaging, but you have to understand these AP, lateral, the obliques, and the plateau view, because this is what you're going to use intraoperatively to, judge your reduction. So you're not going to have a CT scanner yet intraoperatively, so you need to be able to know what each of these things are showing, right? So each of the 2 obliques show you the 2 plateaus, right? And the plateau view will tell you if you have a congruent reduction. So here's an example of a young lady. She was 28-year-old at the time, and she fell while running. And you can see that, this is not only a plateau fracture, but there is knee instability as her femoral condyles are subluxed anterior. So, she's got a posterior knee dislocation here in addition to her fracture. And the CT scan demonstrates this unusual medial articular impaction, and the CT scan confirms that. So she needs to undergo ORIF based on this, which addresses that anteromedial instability. So the fracture is buttressed with a buttress plate, and she gets ligamentous reconstruction on the lateral side for the knee instability. Again, as I mentioned, the key is knee stability. That's what we're going for when we fix any of these injuries. When we're done in the OR, we want to make sure we've restored knee stability. And this is an intraoperative image showing what happens. This is what happened at the time of fracture. So when you're seeing someone in the ED, or you're looking at their x-rays or CT scan, it doesn't really tell you the story of what happened to them. But this type of imaging will tell you exactly what happened. You can see that not only is there an injury to the lateral tibial plateau, a Schatzker 2 split depression fracture, but also an injury to the MCL on the medial side. That usually doesn't require any surgical intervention. And again, this is supposed to be a video, not working. So if I could show you, this would show you that if you flex the knee to about 10, 15 degrees and you do a stress, you can see accentuated valgus instability. We don't like to see anything more than about 10 to 15 degrees of instability in the knee. Here's an example of someone with a medial plateau fracture, first-time skier. CT scan shows minimally displaced fracture on the medial side, but beware that this has the potential for instability. If you're going to treat this non-operatively, you got to follow it very, very carefully. This lady opted for non-operative treatment and had a pretty good result, although she did fall into a little bit of varus. How about the approach? Does it matter? Probably yes. It matters based on where the fracture pattern is, right? So we like to go anterolateral for the majority of the lateral fractures. I prefer this L-shape window into the proximal tibia. Others use an S-shape approach and some straight vertical. Anteromedial, this is along the anteromedial side. Again, for one of these anteromedial depression fractures, sometimes we need to use a combined approach. We do not like a single midline incision with stripping medially and laterally. If you have fractures on either side of the plateau, it's best to address each separately, leaving the soft tissue attached between the two fractures. Posterior approach, the so-called Lobenhofer approach, something that we're doing a lot more of now that we understand how difficult these posterior fractures can be and the inability to reduce them from the front. This is not as daunting as one thinks it is. Start posteromedially, and if you need to go posterolaterally, you can release the medial head of the gastroc and really get over there. Going posterolateral can be done. The problem is that you have the trifurcation in the area, and it can become a little bit difficult to put your hardware in because that trifurcation is about 1.5 centimeters below the articular surface. So although you can see the joint for reduction from the back, it's hard to get hardware in there. Try to stay away from this big midline knee approach where you strip all the way medial and laterally. You may end up with a lot of pus like this one. Understand energy patterns rather than fracture patterns. That's tip number 4. Beware of the soft tissue. An articular surface reduction gives you the best chance for a good outcome, but does not guarantee it, while a soft tissue complication almost always will guarantee a bad result. We have written extensively, and spanning external fixation, joint spanning external fixation is a mainstay in the treatment of high-energy tibial plateau fractures. When you see high-energy patterns, don't dive in right away. Span them, restore length, observe the soft tissue, and come back to fight another day. Acute ORAF in the high-energy proximal tibia fracture is associated with wound complications, stiffness, and poor function. Here's an example. This is a significant more type 2 medial fracture dislocation. You can see there's impacted lateral articular surface from the lateral femoral condyle. This is a high-energy injury. This is what it looks like after you've spanned the knee with an external fixator. Get them out to length. Let the soft tissue resolve. You can address compartment syndrome if need be, and then come back and fix them. We know from the literature, high-energy fractures are well treated with this. We do it for plateaus, just as we've done for pilons. If you're going to do this, I suggest you wait on getting your CT scan until you've spanned. Then you can assess what type of reduction you've been afforded by the frame. Wait, and then when the soft tissues allow, you have a lot of different options. Pre-op planning, tip number 5, always plan out your cases. Use your CT scan. See, this will help you with your approach. It'll help you with your fixation. You may notice a non-displaced medial fracture that may not require its own individual fixation, but you may want to direct screws from the lateral side into the medial side to make sure it doesn't displace later on. Failing to plan equals planning to fail. Tip number 6, soft tissues. Don't forget the meniscus. Back in the 60s, 70s, when they started fixing these, people used to go in, do an arthrotomy, and they would excise the meniscus, and then we'd get a good view of the joint, fix it, and these people will go on to poor results. We know the value and importance of the meniscus. It's usually stuffed down into the fracture site and significantly displaced fractures. And with every millimeter of depression, you increase your odds of having a meniscus tear. They're usually peripheral, red zone tears, and they're very amenable to being fixed. So always fix it at the end of the case. Don't leave a void. If you have a hole, fill it with something. For this, where we're not worried about healing, I like a bone void filler like calcium phosphate cement. It's been shown in biomechanical studies and clinical studies to be better than cancellous bone graft. It has stronger compressive strength. This is an example of a bad fracture, initially span, rim plate for the articular surface up top, fill the void, and then a locking plate to reconnect the articular segment to the shaft. Remember basic mechanical principles. If you have a fracture like this that is medially unstable, that wants to go off into varus to slide off, a buttress plate is what you need. This does not get fixed from the lateral side, even though the lateral joint might be involved. You need a buttress plate. And this is what this patient looks like at a year with a good result. Use your CT scan. Here you see this fracture is all in the back. Fixing this from the front is not going to afford you the ability to see and reduce the joint or provide stable fixation. The fragments that need buttressing are in the back. You need to go prone, go where the money is, and you can get this type of reduction, again, using that Lobenhofer approach I showed you. Again, using calcium phosphate cement to support elevated articular segments. So, in summary, lots of tips, no tricks. You need correct imaging. You need the correct diagnosis. You have to understand knee stability, preoperatively plan, address the meniscus and fill all voids, and above all else, adhere to basic biomechanical orthopedic principles. And if you do that, you'll have successful results. Thank you very much.
Thank you, Dr. Egol. The next talk is by Dr. Leucht. This is Meelan fractures, tips, and tricks.
Thank you very much. So I'm just going to continue right there. Stick to your principles. Oops, there you go. I'm going to, again, talk about treatment goals, imaging approaches, and reduction techniques, and spend most of the time on reduction techniques. So similar to my previous talk, treatment goals are to restore articular congruity. That has to be anatomic, ideally. But different here is that we really have to respect our soft tissues. The Meelan fractures are really injuries to the soft tissues first, and then fractures of the bone second. And then, again, complications here, we have to avoid wound complications. So again, it's all about the soft tissues. So here's usually what it looks like when you get a Meelan fracture. You have an AP and a lateral. You can see how short and displaced this is. This is what we want to get back to. So after splinting, we all know that you usually cannot maintain length rotational alignment in the splint in the Meelan fracture because you need to apply axial traction. And you can see here in this splint that clearly didn't work. So as Dr. Egol mentioned before, it's often better to get the CT scan after you placed the extremity in an external fixator and restore length rotational alignment. That was not done here. So this is on the left, the three images. You can see what it looks like when you get a CT scan. Before the X-fix, you can see here the tibial plafond and the tibial articulation, and you can see the tibial shaft in the back. Clearly, this is not very helpful. So the patient was then taken to the OR for a reduction X-fix, and now you can see that you can gather a lot more information from this CT scan, which is really essential for preoperative planning. The stage protocol, just as in the tibial plateau, has been published extensively on, and it really has shown to be beneficial to reduce wound complication. Here in 1999 in JOT, 2 papers showing that staging of Meelan fractures leads to fewer infections and wound complications. So this is the case that I showed before. When he was taken to the operating room, axial traction was applied, and the tibial shaft fragment, which was really tenting the skin here, was not really reducing. So we had to make we took this free air through the open wound that was medially, and evacuated the anterior compartment, which was completely interposed into this fracture. And after that, a large pointed reduction forceps helped to reduce this fracture just through a stab incision on the anterolateral surface. And then that really restored our alignment much better. And then the patient waited for 2 weeks in the external fixator for definite fixation. And as I mentioned before, the CT scan is really essential for pre-op planning. It really shows you how many fragments you have, where the comminution is, and it really tells you which approaches to use. And for pre-op planning, choose the right table so you get imaging. Again, you think about the approach based on your CT scan, and then have the appropriate reduction tools. And for me, really the key here is the femoral distractor. I can't do a Meelan fracture without a femoral distractor because it really helps you restore length, and then you can just puzzle the pieces back together. And the principles I don't have to talk about. Again, it's the same. We want to have anatomic reduction of the joint, and you can convert them again, like in the distal humerus, to a type B or type or an A-type fracture, depending on what you prefer. For approaches, there are multiple approaches: an anteromedial, anterolateral, lateral, posterolateral, posteromedial, and straight medial. I usually use the anterolateral approach, which you can see on the left side. Just beware of the nerve, the superficial perineal nerve that is crossing your incision every time. And then I use the posterolateral approach if there's a fibular fracture or if there's a posterior fragment that I need to address. So coming back to this case that I just showed you in the external fixator, I always take the external fixator off before I prep, and then prep the extremity, and then use the femoral distractor to get my length back. In this case here, we used a humeral guide wire to stabilize the fibula first because it was a simple transverse pattern that was fairly proximal. Then placed the femoral distractor, and the femoral distractor pin is placed into the talus. Depending on the location or the nature of the fracture, I choose to either put the pin into the center of the body, posterior or anterior, wherever I want most of the distraction. So in this case, I just needed length, and I didn't need any anterior or posterior length, so I put it smack center, as you can see here on the right. And that allowed me to get length. And then I used a small pointed reduction forceps through the anterolateral approach to key in that posterior fragment to the shaft, and then reduced the block to it, and then used this anterolateral plate to hold the reduction. This is another case. Now, this time you can see that there is definitely shortening, and I noticed on this sagittal CT cut that the talus was subluxed anteriorly. So in this case, I put the femoral distractor more anteriorly in the body, as you can see by the hole on the right. And that allows you to get more length in the front and reduce the talus under the tibial plafond. And then again, just using a large pointed reduction forceps, I reduced and compressed the articular block, put 2 independent lag screws just above the joint, and then stabilized it with a anterolateral plate. And you can see here, I'm going to talk about this a little more in detail. On the medial surface here, there's a little gap in comminution. So the question for me always is, do I have to do something about this comminution? Do I have to bridge it with a plate or a screw to avoid varus deformation later on? And so you see in this left example, I put a long screw up to support the medial column, and on the right, I didn't. And of course, this patient was non-compliant, walked on it within the first 6 weeks, and you can see that this collapsed into varus. So I also want to talk about this paper really quick. How do Meelan fractures heal, and where should we put our plates? You can see here 2 examples on the right. One, an initial X-ray showing valgus deformity of this fracture, and then on the right you see varus. And the question obviously is, should you put your plate to oppose this deforming force? And what this paper shows is that it really doesn't matter if you do a biomechanical match of the plate, meaning putting it onto the medial lateral side based on the initial displacement. What really was important here to show is that the screw density between 0.4 and 0.5 is protective of failure and reoperation. So in summary, stage P-lone fractures to reduce the wound complications. Choose your approach based on fracture characteristics, which you can gather from the CT scan. Use the fibula to restore length, and then the femoral distractor will help you distract and regain length of your tibial column. And then use bone void fillers if you have to support small articular fragments. Thank you.
All right, thank you so much. And then the last talk in this segment will be Dr. Tejwani. This is calcaneus fractures, which surgical approach and when?
Thanks, Suman. We're going to talk about calcaneus fracture. And I'm going to try and see if I can control this. Okay, there you go. All right. So calcaneus fractures, we know are a problem, right? I mean, these are old sayings from Cotton and Bankart, and essentially told us that calcaneus fractures is a problem. And really, the best option you can expect is a stiff foot, which, you can think about this almost 80 years ago. He said that, and I think that is still probably true, where a stiff joint is probably a good outcome. So what are the problems? The calc fracture. So, you have the joint disruption, there's heel widening, malalignment is a problem, peroneal impingement, decreased heel height, as well as horizontal talus, which leads to an ankle impingement. All of these problems will also create the fact that, surgically they become a problem as well, and therefore a lot of people have trouble figuring out what to do and how to do it. It is a difficult exposure. Visualization is limited. You're seeing the lateral side and trying to reduce the whole calcaneus without seeing the rest of the joint or the rest of the bone. The shape and the anatomy are complex. Fixation devices are usually not adequate, or they are flexible and flimsy and have to be low profile. The surgical technique can be difficult unless you're an experienced surgeon, and most of the bone is cancellous. And then finally, the big gorilla in the room here is the soft tissue. This is what some calcaneus fractures may look like, and you can imagine trying to make an incision through that is a bad idea. This is an old study which talked about waiting for a few days for soft tissues to settle down so you can fix fractures, and then they talked about going later than 6 days to do it. Most of you have seen this slide of the lateral calcaneal flap vascularity. Old study, almost 20 years old now, tells you why we do the approaches we do, because of the big supply of the lateral calcaneal artery into the lateral flap. What are the goals? Like any other surgery, goals are restoration of height, width, and length. You want to, of course, restore the articular surface. And by doing those two things, you want to restore the relationship of all three joints and the orientation of the tuberosity to get the best outcome. So what are the approaches that we have, what we think about when we look at calcaneus fractures? Well, we have the minimally invasive or the percutaneous approach. This is the old Bowler clamp, trying to reduce the width of the calcaneus with traction and compression. We kind of have gone away from this technique a little bit. We do something different. How about percutaneous? Well, if something is like this, an avulsion fracture, I think it's perfect for a percutaneous technique. This one, as you can imagine, while the x-rays look good, the soft tissue is not so good. So just keep that in mind. Soft tissues can be a problem, and this fracture is actually a surgical emergency. Other indications, we said tongue type fractures and Sanders type 2C, where the whole facet is displaced, where you can actually reduce the facet and put percutaneous screws to fix it without making big open incisions and risking soft tissue problems. How about the two common ones we talk about, the so-called extensile approach and the sinus tarsi approach? I think everybody's heard about the sinus tarsi approach. It seems to be the new kid on the block, as it were, and we've all slowly migrated towards the sinus tarsi approach for most things. But like everything else, I think it has its own advantages and disadvantages. So it's a lateral position, which is, to me, the setup is the same, whether you do a lateral extensile or a sinus tarsi. The incision is much smaller and much more anterior, so it's 4 to 5 centimeters from the malleolus, extending distally. The key in this approach is that you have to enter the peroneal sheath and dislocate the tendons, because I think if you don't do that, the visualization is limited, excuse me, as well as placement of the plate will be compromised. You still need a shank spin to correct the heel varus, and then you need to put a second or third percutaneous incision to put screws posteriorly. This is what the joint looks like. One of the things with the approach of this is that you may have difficulty visualizing the whole joint. So I think if you're trying to look at the anterior part, you want to make sure the tendons are retracted posteriorly. If you want to look at the posterior part, then you got to make sure the tendons are retracted anteriorly. Otherwise, it's difficult to look at the both joint from just one visualization. So what are the pros and cons overall? I think it's a faster approach, smaller incision, and has less soft tissue problems. It does have potentially limited exposure, and it's difficult to extend. Once you make it, you kind of bought it. So this is I know it's a very busy slide, but what I'm trying to show here, that with the sinus tarsi approach, both the operative time and the wound complications are lower. This is a meta-analysis of multiple studies, both randomized control and cohort studies. And this has been replicated in further analysis as well. So just to give you a quick comparison of the two approaches, there are two fractures. And I think if we had more time, we would poll the faculty to see what they would use for which fracture, but this is what they look like, kind of similar. And you can see the displacement is a little bit more on one side than the other with the heel varus. And you can see we were able to achieve a better reduction on the sinus tarsi, even though the fracture was more complex. And the wounds look like this. And the range of motion is pretty good at 2 weeks. I'm going to skip that video. All right, just to summarize, I think the sinus tarsi approach is a very useful approach for fixation of calcaneus fractures. I think the tuberosity fixation is easier. It definitely makes the anterior joint visualization much easier. The posterior joint will require some extension and excuse me, and dislocation of the tendons. And potentially, because your approach is minimally invasive or less invasive, you could argue that you could operate on these calcaneus fractures sooner rather than you would do with an extensile approach. Now, I would keep the extensile approach for fractures that you approach late. I think once they start healing between 2 and 3 weeks, you may want to think about doing an extensile approach. If there is posterior comminution with an intact lateral segment, again, you can't really see much of the sinus tarsi, so you may want to go with an extended lateral. So to conclude, there are many factors besides the approach. You just have to keep that in mind, and you kind of heard that with other talks as well. Remember patient's age, compliance, and activity level. You saw the failure earlier on with lack of compliance. Patients with diabetes or smoking, you want to probably stay away for calcaneus fractures because I think that can be a problem. Fracture patterns can also decide for you what approach to use. And then, of course, your own abilities in what approaches you're comfortable with. Thank you.
All right. Thank you, Dr. Tejwani. We have a few minutes for questions now. There are none on Slido, so feel free to ask anything if you'd like to. I'll start with Dr. Egol. Question for me. What are the instances that you maintain external fixation after you fix tibial plateau fractures? Is it based on your fixation quality, ligamentous exam, a combination of these things, or what specifically are you looking at?
Well, I can't honestly remember the last time I've maintained an external fixator after fixing the plateau. I think probably the only reason I would if there was some significant soft tissue issue, compartment syndrome that wasn't completely, closed or resolved, or some, flap that needed to be done or something like that. But I would never leave the OR without the bony fixation and stability that I need.
Okay, great.
I have a question, Simon. Sorry for Philip. So I always struggle to put on the femoral distractor for Meelan fractures, and so I've gone away from using it. But I guess, and you had mentioned some tips and tricks to use it, but I was wondering if you could educate me a little bit. Like, what is I always find that when I'm out to length, I feel like I'm locked in a rigid position, and then maybe I'm putting it on the wrong way and then I feel like I can't reduce certain fragments when I'm there. Is there anything you're doing intraoperatively if you run into that situation, or anything else you can talk about?
No.
Okay. Maybe my problem my problem before probably was I was in the calcaneus. Maybe I was going into the calcaneus and not the talus.
Yeah.
Only when you're in the talus, you get more control.
Absolutely. So that's definitely one thing. If you put it in the center, in the talar body, you can definitely dorsiflex and plantarflex as much as you want. You also have only one joint that you distract. So if you go in the calcaneus, you lose a lot of that distractive force. The advantage of going in the calcaneus is that if you get a lateral x-ray, you don't have the distractor over the joint so much. So that's sometimes a little tricky. So you can't really rely much on x-ray because the distractors may be in the way. But because you're distracting so much, and if you resect the anterior capsule, you can see the joint so nicely. You can get everything reduced, held in place. And then if you really have to see it by x-ray, you can take the distractor off.
They got it.
This is also for Dr. Leucht on Meelan fractures. Do you have any preferences on, preliminary or partial fixation at the time of external fixation? What sort of fracture patterns or what type of fibula fracture you're looking at if you do proceed with that?
Yeah, that's always discussed. And you saw the papers that I showed. In those papers, they plated or nailed the fibula first at the time of X-fix. I'm not very special about it. I think if you do it yourself, you can fix the fibula then. But I think in most cases, I would just X-fix it, and I'm okay to fix both fibula and Meelan at the same time.
Okay.
The last thing I want is that someone else fixes the fibula and doesn't get it right, and then I'm struggling with it.
Makes sense. And then I've got one last question for Dr. Tejwani. What would you estimate your breakdown is, for all calcaneus fractures between sinus tarsi approach and lateral extensile currently, and how has that evolved over the last several years for you?
So for me, my personal bias is still an extensile approach. I mean, just because that's how I, started with. But I think I'm drifting more and more towards doing the sinus tarsi. I would still think it's about maybe half and half, but I know some of you guys on this call or this conference do that almost 100% of the time. But for me, it's still not there.
And Nirmal, when you do the sinus tarsi, so are you doing sinus tarsi approach with some sort of sinus tarsi plate fixation, like a plate designed specifically for that approach? Or are you using the sinus tarsi approach primarily for articular surface reduction and then using like percutaneous screw fixation as your final construct? Because I've gone to doing the latter, which is using sinus tarsi when needed for the joint reduction, but then just use a combination of some sort of cannulated screw system, 4.0, 6.5, if the fracture pattern allows for it.
Correct. I think that's a good point. I think if the fracture pattern permits, and I think I showed that one clinical picture of just screw fixation of the articular surface. But the fractures that I end up fixing usually have more than that. So if I'm doing just the sinus tarsi approach, usually it's associated with the plate. It's rare for me just to put screws and then do an open approach.
And then this is another technical point. For one thing I've always struggled with a sinus tarsi approach using a plate, whether it's a sinus tarsi plate or some other plate that you want to use, is the kind of the screws that go into the posterior tuberosity. They kind of go a little bit distal and plantar. And so how are you getting that exposure? Is it percutaneous? Is it, what tips do you have for that?
So a couple of things, one of the commonest reasons why the plate gets taken out is because of the screws in the back or the prominence of the plate. So usually I'll bend it a little bit so it kind of contours better. And second, yes, you end up making just stab holes, just do like perfect circle technique on fluoroscopy and put maybe 2 screws in there. I don't extend the incision for that.
All right, thanks. Sorry, go ahead.
Sorry, I'm going to ask a few more questions. I think we're ahead of time right now. Am I correct, Simon? I think we're ahead of time. So
we've got 7 more minutes.
Wow, that's a lot. Good job, guys. Way to be fat. So, Ken, I have a question for you with regards to bicondylotibial plateau fractures. As I go, to OTA this year and going around to conferences, I see more and more, high energy level 1 trauma centers starting to fix bicondylotibial plateau fractures, less with just pure plate fixation constructs with like a big 2 incision approach, because the literature infection rates for closed bicondylotibial plateau fractures are anywhere between 15 to 20%. And now they're trying to fix most of these with tibial nails. So it's a tibial nail with some limited percutaneous screw fixation around the joint. I think with the idea of trying to minimize infection risk, the idea that articular surface congruency is not a huge factor. It's really alignment is the kind of the main goal. What are your thoughts on this? Are you doing any more? Are you leaning more towards this? Are you happy with the way that just plate fixation goes?
No, I'm not. I think nails have a place in the armamentarium for proximal fractures of the tibia with minimally displaced or simple splits that can be easily lagged. But certainly not for any of the cases that I demonstrated in my talk. I don't think would be amenable to nail fixation in my hands.
Suman, I think there was one question that came through on Slido. It was for Dr. Leucht. Do you always fix the fibula in Meelan fractures? And if so, do you fix it prior to your tibial fixation?
Yes, always, because that really helps me to get length back and really judge length. And I always do it first. Yes, if I stay supine, then I go lateral or posterolateral. If I start prone, then I do my posterolateral approach, fix the fibula first, then address the posterior fragment, plate that, and then flip the patient, and then do the rest from the front.
Along the lines, I'm going to ask another question. Sorry, I got a lot of questions about Meelan fracture. Hate these things. Along the lines of staged fixation, we typically think of staged fixation as an X-fix first, and then come back and do the definitive fixation. But what are your thoughts on, staged fixation within the definitive fixation realm? Like, do you go ahead and fix all Meelan fractures if you're doing front back all at once, or do you stage that? Maybe do the back first, come back a few days later or a week later, and then front. What are your thoughts? And
that's a good question, especially based on that recent paper that showed that if you stage those, you end up with more infections, which is really counterintuitive, because you would think that giving the extremity a little time to calm down again and then go to the front just makes more sense to me. I have done both. I have, if I thought it was too swollen after doing the first part and I just spent too much time already on the back, then I staged it. But most of the time, I would say 90% or so, I would do it in one session.
I'm done with my question.
I'll pose the same question to Dr. Leucht as well. For Meelan fractures, are you doing any extreme nailing, and what are your indications for that?
No, and no. If it's a Meelan fracture that needs articular reduction, then no. I have done a revision where the articular block had healed nicely and then it collapsed into varus. That I then nailed to stabilize that fracture or that non-union. But primarily, I never understand that concept of reducing something anatomically and then jamming a nail in it like a wedge or an axe. Same for proximal humerus fractures. That's always, it just doesn't work in this German brain, even though Germans nail a lot of proximal humerus fractures.
Fair enough. All right, we're ending 2 minutes early. We can move on to the complications section. Thanks, everyone.
All right, guys, so we have some good lower extremity complication cases. I think the first one is going to be presented by Dr. Ganta. So go ahead, Abhishek.
It's going.
I think we can hand over control to Dr. Ganta.
Okay, perfect. So this is a 19-year-old male MVC. He had bilateral open tibia fractures, right femur fracture. Left side was a type 1 open fracture, healed uneventfully. The right side was a bad contaminated type 3 open fracture. Let's see, slide's just not going. Perfect. So I took him to the OR that night, cleaned it out, put a provisional plate to kind of get my length, and put some antibiotic beads in there as well. and duke him out for a couple more debridements. He had a large bone defect. Nailed his fibula, tried to get, because his fibula was floating in left space. Went ahead and just placed an antibiotic cement spacer as well for like a masculate technique. And then, presented 3 weeks post-op, started having a lot of wound issues. I tried to do some local wound care on it. Ultimately, he ended up dehiscing and had exposed antibiotic cement. So his culture results go back Enterobacter and Pseudomonas. He ended up eventually requiring a flap, and then I did exchange the antibiotic cement at the time of the flap just to get it a little bit more longevity. So basically, in summary, he has a type 3 open tibia fracture, gram-negative infection, bone defect. His antibiotics were completed, and he had a 2-week holiday, normal ESR and CRP. Took him back just because of the bone defect. I took out the antibiotic cement with like a masculate technique, and then used RIA only on him. Is that so much bone graft from the RIA that I just used RIA. And then his flap dehisced, and I had to take him back to the OR again, wash it out, close him back up, let him be weight bearing as tolerated. His cultures grew out another gram-negative bacteria. So he had 6 more weeks of antibiotics, and I talked to the patient about potentially having to rebone graft him at about probably 5 months, 6 months or so from the time of this procedure if I didn't see like a lot of consolidation. At 3 months, he was starting to heal. He still had, it didn't basically bridge the entire defect, and he still didn't have complete consolidation. So I kind of got him in the thought process of having to get another bone grafting procedure potentially done in a couple of months. And then he decided to go on vacation, did a backflip into a pool, and had immediate pain and inability to ambulate. And he bent his nail. So at this point, his ESR and CRP were normal. I still got cultures intra-op. I took out his nail and did a posterolateral bone grafting. And I used the same nail company. I just reoriented the nail a little bit to get new interlocking screws. Let him be weight bearing as hard. I figured with the nail and a plate, even with the segmental defect, he'd have enough strength to be, and the construct to be allowed him to weight bear as tolerated. And at 6 weeks, he started breaking his interlocks. And at 10 weeks, he broke both of his interlocks. And at this point, I took him, talked to the patient, and told him that, I don't feel comfortable leaving this. We took him back to the OR, took that nail out, put in a new nail. And then at 3 months, finally post-op from that he's actually starting to get a lot of callus formation and consolidation at the fracture site, and he's starting to heal quite a bit. So that's where he's at right now.
Thanks, Abhi. So what would you do if he still doesn't heal? If he comes back infected again, what would be the next move?
Honestly, at this point, probably have to take out all the hardware and probably have to do a spatial frame on him, like bone transport, resect all the infected bone out, and probably do a transport on him. But he's developed so much callus from the last time to now. I think that he's probably going to heal at this point. So I got lucky.
Yeah.
Yeah, I mean, one thing I would say is that when you do these non-union, I would be tempted to do a fibular osteotomy when you nail them. Give yourself a little compression if you need to.
Right.
Because I think if the fibula is intact, it's going to keep distracting it for you, right? Even with the nail in place, especially are you going to the second or third time.
Has anyone ever had a fracture heal around your cement spacer?
Yes, and that's okay.
Yeah.
All right.
I want to make a comment on Dr. Ganta's case. So I wasn't sure why you kept the plate on there for the second bone graft. And right after you increased the nail diameter and you put the plate on there, you saw that your bone graft basically resorbed. I mean, there are two reasons why that may have happened. One is the infection with Fingolia magna, which I've never heard of before. And second could be stress shielding. I mean, that's a super stiff construct, and putting bone graft into that environment may not just be the right thing. I think you needed a little bit of micromotion to allow the bone graft to mature.
Yeah, so I only did one postural out bone grafting on him. The first bone grafting I did on him, I didn't add a plate, and I just packed bone graft around the area and prepared like the intact tibia. When he failed that hardware is when I did a posterolateral bone grafting, and I didn't want to go back in through his posterolateral incision again. That's really the only reason why I left that plate in place. But all the screws were broken on it, so I figured it wasn't really doing too much at that point. So I guess he kind of somewhat auto-dynamized. But for these segmental defects, I get uncomfortable with them putting weight on their. I guess the interlocks are doing all the work, but he's a really big kid, and I got worried about him putting all the stress on the nail. So that's the reason why I added a plate posteriorly.
I was muted before, but I wanted to respond because I disagree with Nirmal's comment about osteotomizing the fibula. If you're going to do a posterolateral bone graft, you're not only going back there to try and bone graft and get tibia to tibia healing. The idea is that you decorticate the fibula and you lay the bone graft on the interosseous membrane and you try to get a tib pro fib, one bone leg, get the tibia to heal to the fibula. And you need to have the fibula intact for that, because in case the tibia never heals, it basically acts as a bypass where the tibia heals to the fibula both above and below the non-union. And that works very, very well. So it's like a backup in case the healing of the tibia doesn't occur. So I don't osteotomize the fibula ever. That's Howard Rosenism, the man who is the president of the Save the Fibula Society.
I have a question for the people who do a lot of non-unions. It's a question of these diaphyseal segmental defects, and this goes to Philipp's point. Like, how rigid are we supposed to be making the construct? Are we obviously not too rigid, is what Philipp is saying, but is it the same amount of like relative stability that we would expect for like a normal comminuted fracture pattern that we're trying to bridge? I hear people talk about for non-unions, you need to account for rotational or torsional forces, which is a reason why fusion masses oftentimes don't heal. What are your thoughts? Philipp or Ken or anyone else who would like to chime in.
I mean, I think if you're using a nail as your implant, you're not going to have it's not going to be absolutely stable, right? So you're going to get there's not going to be a lot of motion there.
Is that what we want? I guess is what I'm asking for these segmental diaphyseals that you bone graft.
I think you want endochondral bone formation, and for endochondral bone formation to happen, for that initial first step, the soft callus formation, you need to have some motion. So if you make it too stiff, that's not going to happen. So then you're just going to be left with a few osteogenic cells that are in your bone graft, and those will make bone. But that's going to be such a small amount of bone that's not going to lead to fusion. So you want those cells to sense the mechanical environment, divide, and then make cartilage, make a huge ball of extracellular matrix that stabilizes it and then calcifies. That's how you get a nice regenerate. So a little bit of motion is good.
Yeah, if you have a 4 centimeter defect, you can put a nail and a plate in there, and you're still not going to have absolute stability by the nature of that gap.
Right.
I mean, is it possible that I put those screws too close to the defect size or the defect area? I don't know. I've never seen anyone break a nail plate construct before, which blow my mind.
Yet.
Yeah, to me, that's a sign of ongoing infection.
Yeah,
and that would be the concern would be ongoing infection. I think
all those cultures were negative, after the initial ones.
NGS.
That doesn't mean anything, right?
NGS.
You can still be infected. What do they say? Osteos for life.
Yeah, for life.
Next generation sequencing.
Mm-hmm.
When you sent your cultures, did you also send stuff for pathology? Because you also want to make sure, to see what types of cells are in there, not just, what grows.
No, that's probably something I probably should have.
Yeah, I mean, anytime you're doing anything where there's even a thought of infection, I mean, the diagnosis is both a microbiologic and a histologic diagnosis.
And so that's a good question, Toni. So, and a good point. So, I remember Tim Rapp used to always say, send all your samples, both to you, micro and tumor.
Culture what you biopsy and biopsy what you culture.
Right.
Have you ever seen a report where they comment on the cells? I've only seen the report say it's consistent with osteomyelitis.
in terms of what exactly do you mean? Like what comment would you expect to see?
Well, what are we looking for, Toni? I guess is the question. Like I see sometimes the pathology say just giant cells, which is a sign to me. I think of that. I think, okay, inflammation. Sometimes
Right.
they see necrotic debris, which I guess is good. That means I was excising dead bone. Am I looking? I mean, are they supposed to be commenting on number of PMNs on that?
Yeah, they're supposed to be looking at white cells and, looking more at the histology of what it is that you're sending. I mean, their impression may be that it's consistent with osteomyelitis, but, and I guess in and of itself is something, because also sometimes you get it and the pathology will just say what the cells are, and there's nothing, there's no bacteria seen. I mean, there's no, they're not seeing any cells that are consistent with it being osteomyelitis. So they'll sometimes will say no evidence of osteomyelitis, or just fibrous tissue or whatever. But I mean, the textbook answer is that you need to have both of those things to make the diagnosis.
I have a question for you guys. So when we do the masculate technique, we're looking for the induced membrane. I've had a few cases where I go back in, 6-8 weeks after the initial cement, and there's no membrane or very little membrane, nothing, that's robust enough to kind of close around your graft. And then your graft ends up kind of, there's no constraint, and it ends up kind of getting pushed beyond the margins that you want it to go. Do you guys have any techniques or any artificial membranes that you use to deal with that problem?
Trust the membrane, that even if it's very thin and you can't see it, the cells are there. So just pack the bone graft and close the soft tissues over it. It will work.
All right, I think let's go on to our next case. This one is from Dr. Egol.
Sorry. So this is a 74-year-old lady who came in with this intertrochanteric hip fracture that I thought was a fairly benign looking injury. And, community ambulator, nothing significant. She'd had a previous femoral neck fracture on the other side that was treated non-operatively and went on to heal, and she was very happy with that. And I told her that she couldn't do that with this one. She needed to have surgery. So we did. We did this, which I thought was okay at the time. Anybody have any issues with this? The head neck's a little bit valgused in the reduction.
Only thing I would ask is, did you lock the set screw? Did you let it slide? What's your practice pattern here?
I think we let it slide. I don't think I had my hands on the screwdriver at the time, but it's allowed for impaction.
Looks beautiful.
Right. Anybody? No, nothing. So this patient came back came to her first post-op visit. Stitches were taken out. She was weight bearing as tolerated, and then returned to the office at about 7 weeks. Waddling gait, increased pain. Like this. Anybody have any thoughts as to why this would happen at 7 weeks?
7 weeks. Wow.
Yeah, now in retrospect, I mean, if you look at your immediate or your fluoro shots, the gapping just across that interface of the lag screw and the nail, that put a lot of stress on that nail. I think that's the only reason why I could think it would fracture right there. I mean, it had no chance to compress because it was fixed with 3 points in the proximal fragment with the proximal body of the nail and with the lag screw. So it was just distracted, I guess. But it's easy to say retrospectively.
But I feel that I've left the operating room lots of times.
Yep.
With the fracture, I feel like stretched out into just a slight amount of increased valgus, which will distract that medial calcar a little bit. Thinking, sometimes I do intraoperative compression, sometimes I don't, just variable. But usually I think within the first few days of that patient ambulating, it will start to settle. I suppose if it's somehow locked if it's locked statically, it obviously will not. But it looks like I think we wanted to let this thing settle as
I think this pattern is different because it's a simple pattern that was distracted medially and laterally. So in the typical comminuted fracture, where you also have, greater troch comminution, where the proximal part of the proximal fragment can settle, that's okay. But I think in this, it had no chance. It was stuck on that construct.
All right. So here she is 7 weeks. She looks like she did when she first came in. How would you guys go about revising this? She need a total hip here? Would somebody
After crying.
Refix it?
I mean, it looks like right now the lines that you've drawn in the image, that looks exactly like a blade plate. So it almost seems like that's what it's asking for.
Do you have any pre-existing arthritis or pre-existing hip pain?
No, she was fine. Very, very stoic Russian woman. Very stoic. Anyway, I great minds think alike. So that's what I did. And I thought I'd done a good job until after the case. And when I looked and I saw her leg was internally rotated excessively. So I got a version study to look, and I was right. So now what? Just bring him back and derotate?
Yeah.
Yeah.
You're gonna have to go. I would, to change. I would think you'd want to change your plate. Now you're gonna have. You would keep the blade in your neck because your neck. That was you're already starting to lose a lot of bone stock. You have to rotate the femur. And now you got multiple screw holes all along where your plate is. It's gonna break. You got to go a longer plate if you decide to do that.
Yep. All went through my mind. About leaving screw holes, and when I derotate this and whatnot. And right, the reason I went with the blade was because it was a different angle than the original screw, so I'd get some bone and all that. So, I had to have a big discussion with the patient and the family about taking her back again, explaining another time something went wrong. And so I wound up doing this, took out the plate, and I converted it to a nail. And I used this nail that allows you to inject some cement through the lag screw to fill up the area and basically fill up any defects that I had. And then I added this hook plate to the troch to try and counteract that force that wants to tip this thing into varus. And the fact that I'd gone through the troch, before and going through it again, I didn't know what if that was going to break off and become a problem as well for the patient. So this is what I did. And this is what it looked like at the end. And I was pretty happy at the end, although there's still a little bit of gap or bone loss on that medial neck. I think that was more from impaction of it falling into varus so many times. I make sure the version was correct. What's that?
How do you feel about the PMMA cement just under the cartilage in the hip? I mean, that's an exothermic reaction that's going to get so hot. What do you think the cartilage is going to do right above that?
I have no idea. But all I know is the x-ray looked good.
That's right. I always wondered why the companies are, suggesting to use PMMA cement. I mean, it would be nice to
That's not PMMA, that's calcium phosphate cement.
Okay.
It's calcium phosphate cement.
Okay, that's better then. That's not too hot.
And here she was at 2 weeks. She didn't fall apart. And she was at a year. I saw her and she healed and did very well and went back to her solitary life. And her son stopped calling me eventually. So, key points here. I don't know why this nail failed. I actually sent it to the company and had them examine it. And they said that it was damaged at the time of placing of the lag screw, that, basically the hole in the nail got reamed by the reamer and caused intrinsic damage. And that's what led to the fracture of the implant. Now, I'm sure we do that 97% of the times. That reamer hits the nail and causes some damage. I guess in some cases it'll get unlucky and it'll propagate a crack and fail early.
Well, I think that one thing, I think next time you see that happen, watch how it happens, because what'll happen is someone will be reaming and they'll hit the nail. Invariably, there's a millimeter that reamer is off and it's going to hit the nail. And I see sometimes they just sit there and keep spinning it without applying axial pressure towards the reamer. And it sits there for like 10 seconds. And they're like, why can't I get across? It's because you're not pushing. You got to push, push, push. So it'll just jump. If you got to, in my opinion, you just got to push it across. It's an arch. If you look at the opening of the lag screw hole, it's an arch. So if you imagine, if you ding the arch, and I've talked to engineers about this as well, if there's any nick in that arch, the arch will weaken significantly. You just got to push axially, and you won't spend as much time reaming it. I think 100% of the time do we hit it.
Yeah, you can hear it too. You can hear the reamer in the nail and carving it out.
Yeah, push.
Yeah. I wonder if also with the lag screw, because you never got any sliding of it, and so it was from the beginning. There was always that extra force on the medial side. And what I see being done a lot is, you put the set screw in, and then you back it off a quarter. So you check it to make sure that it doesn't turn, and then you back it off that quarter turn, and then people check it again. And that bothers me because the whole point is the set screw is supposed to sit in that groove and slide. And if you turn it and you jam it a little bit, then now your set screw is sitting on the nail again and not necessarily allowing it to slide. So I wonder if that might have happened, because I've seen people really, I yell at them, but really aggressively try to twist it after backing off a quarter turn. And that just doesn't make any sense to me based on the nail design and the point of why you're backing it off.
I have no idea.
Yeah, I don't know. I've had mine go the other way. The lag screws, I've had a few where the lag screws spit into the acetabulum, and I could not figure out what happened there either. So I think, as with everything else we've been talking about all day, there's a lot that we just don't understand and can't predict. And the post-op x-rays look great. And then you're very sad very soon after.
Not good for my wellness.
A couple of the audience were asking if revising this to a long nail the first time instead of revising it to the blade plate would have been a better choice.
Yeah, my concern initially was, that the screw had a trajectory of 125 degrees, and if I was going to put another nail in, was there some toggle when this thing failed, and is there going to be good purchase up there in the head? And to be honest, I really didn't think about use of this nail with the ability to squirt in the stuff at the time. But I think you could have revised it with a long nail, and this didn't fail because it was a short nail, I don't think.
Yeah, I think I would be concerned about putting something in exactly the same pathway as what you had before. But I think the use of this nail is probably a good idea because it still kind of fills that space around it that's invariably going to be there. Because over 7 weeks, that nail was sort of windshield wiper. The lag screw was windshield wipering in there. And so, I think that would be, I would be concerned about that. Like I said, initially, I would have done what you did. But yeah, I don't think it had anything to do with the length of the nail.
When you revise people, make sure you do a good job the first time. That's my advice. That's a tip. That's a tip and a trick.
That's a trick.
Okay, we have one more, I think, from Dr. Stevens. Nikki, are you able to control the screen there?
Yeah, maybe, yes.
I think you're the next slide. Yeah.
Okay. So this was a 35-year-old. She presented, this is a case from fellowship, with bilateral Meelan fractures. She's got an extensive past medical history, mostly for social issues. She's got PTSD, possible substance use disorder, depression, et cetera, et cetera, et cetera. We're going to talk primarily about her left ankle, which had a 5-centimeter open wound medially. She was otherwise neurovascularly intact. And these are her x-rays. So she was placed in an X-fix, and medial wound was washed and closed. And then eventually, this is her, these are kind of some cuts of her CAT scan. And then eventually she got this fixation. So her medial wound was really tenuous. So we decided not to go medially, and we just did this percutaneous 3-5 cortical screw on that side, and try to, limited touch technique, I think, of trying to use limited incisions and fix everything. So she leaves, and then she never comes back. And then at 2.5 months, here she is. So she's coming in. She hasn't really been able to put too much weight on this, but the weight that she has put, just by nature of how kinkly her leg is, did enough to kind of dissolve her fracture fixation, essentially. So you can see she's falling into varus. It's not looking too good. So we take her back to the operating room and put her in an X-Fix, take out all the hardware that we can reach, and she's left with this. We took cultures at the time, and she's growing back MRSA from her wounds. And here's kind of what we're at. So she's got significant bone loss. She's infected. She's not the greatest patient. And the question kind of is like, what are you going to do? What's the plan? So I don't know if anybody in the group wants to take a stab at what we're going to do now.
Fuse it.
Use. My question is, is this someone that you would even consider doing a fusion on primarily? I mean, knowing look at her body habitus, I would imagine in my hands, she's going to get infected no matter what, because that's what I do. I get infected.
Yeah. I think hindsight being 2020, I think a fusion might've been a good deal for her. She's got a hard time complying with weight bearing instructions. She's got a broken ankle on the other side that we're not even really talking about. And, basically every clinic visit with this patient when she comes in is like an hour long and results in a lot of tears and crying. So she was really anxious about amputation. She was really anxious about, really everything. But the concern at the time was everybody was kind of thinking fusion eventually, but, how do you fuse when you've got so much bone loss and you still really have an active infection going on? So we took her back again to the operating room and debrided all of the dead, devitalized bone. And by the time we were done, this is kind of what it looked like. So based on the picture on the right side, you can probably see kind of what the plan is right now. We've cleaned up and freshened the fracture edges, and we decided to put her in a frame and do a bone transport technique for eventual fusion was the plan. I think that this is a big thing for this patient. She's a difficult patient. You're going to see her all the time. She's going to hate her frame. But ultimately, we felt like she didn't have enough good bone that we could just do an acute fusion. But she told us in no uncertain terms that she wasn't going to keep this on for a long time. So I think that the plan was actually to lengthen her and then quickly transition her after the bone transport was done to a fusion type nail. So that we could get her out of the bone transport system quickly. So put her in a frame. You can put calcium sulfate beads in the big defect, which helps kind of sterilize the environment and has the added benefit of not needing to go back to the operating room again to remove a big spacer block. Here's her corticotomy. And then we started her transport. So here's what you can see. You can see the gap at this point. I think it was about 6 centimeters. I don't remember definitively, but that's kind of where we're at. So, throughout the bone transport, lots of tears, but she's doing her thing and she's on antibiotics and she's the bone transport going pretty well. You can see she's got a pretty good regenerate growing up proximally, which is good. And then after the bone transport was done, I think in about 8 weeks, we took her back to the operating room and did a upside down tibial nail to get a long enough length for the fusion for essentially what it is going to become kind of a TTC fusion for her. So it's a good technique because the nails only come so long. And we really wanted to get long length and cross to regenerate site. So we used a trivial nail to span both. And then she actually did okay. I think these are about 6 weeks post-op from her nail exchange. So she wound up doing okay. But I think these are kind of oftentimes really hard problems to fix, and especially in difficult patients, frames can work, but I think this is a nice technique to get the frame off quickly, is to transition to kind of a nail. And it also helps the consolidation of the bone transport and the fusion mass, because you're basically reaming, so you're generating reamings right into both sites, which is kind of nice. I don't know, questions, comments?
Did you do a pin side holiday after the frame removal and then conversion to the tibial nail? Because I put an upside down tibial nail once, and you got to do a lot of planning to make sure your screws are going in the right trajectory and orientation. So it's not like, it's not like you just take a nail and shove it up and hopefully get all the screws right, but it's a little finicky. But did you do a pin side holiday?
No, we kept the frame on. We took the frame off in the same place that we put the tibial nail in. I think there was a little bit concern, honestly, about the pin holiday, that she was gonna never come back again, and then her leg was gonna be all floppy. So I think we wanted to do it.
Yeah, when I transition from a circular frame to a nail, I don't generally do a pin holiday. The pins with those frames tend to be much less sort of soupy and toggly than what you get with just a uniplanar frame. And I've actually done a similar thing to this, but if you put the tibial nail in from the top, you just drive it down across the joint into the talus, and then you can lock it into the talus distally with your distal locks. So you don't necessarily have to go in from the bottom. You can do the same thing from the top. You just have to plan, obviously, your nail length appropriately.
Yeah, absolutely.
Question for those who do a lot of bone transport with regards to the regenerate and it consolidating. If we were to follow this serially with x-rays, is it similar to just any other type of like callus that's healing, like 4.5 months approximately to consolidate, or is it a longer time, shorter time?
It depends on how long it took you to get where you're going. And generally your consolidation period is twice whatever it took you to get to where you needed to go. So if it's a 3 centimeter defect, takes you 30 days, you're going to give it 60 to consolidate. And it's not actually callus. It's I'm completely blanking on the term, but it's the other type of bone formation. Sorry.
Okay.
Nikki, what did you guys do to prepare the joint surface distally for your fusion? When or if did you do anything or?
Yeah, so the only time we did prepare the joint surfaces during the original debridement, and then when we put the nail in, we made like a really small incision. We didn't do any like definitive preparation at that point, but I think we did put some bone graft in there distally. But a lot of it is it's taken care of by the reaming, so right. we didn't use a lot.
Did you use an antibody coated nail or just a standard?
I think for this one, we did just I think it's just a standard nail, but I think we talked about an antibiotic nail, but I think her inflammatory markers were normal at that point. And I think we decided that it was going to be okay, but definitely another consideration.
So no one else has any other comments? I think that's it for our lower extremity complications. I think we actually have a little bit of time for a break if you guys want to take that. Everyone agree?
I say we keep going.
Yes. Yeah, I think we should keep going. If Heather is here, I think she's on there, so we can probably keep going.
Sounds good to me. So we have with us Dr. Valier, who is a professor of orthopedic surgery and also is the Clyde Nash Professor of Orthopedic Education at Case Western in Cleveland. As you know, she's our OTA president, and even though she's probably burned out from last week, she still agreed to be with us. So we're very grateful. She has a prolific career as a clinician, as an educator, and as a researcher, particularly her work in the area of damage control orthopedics, which has really revolutionized how we treat the multiply injured patient. So we're honored and excited to have her here. I think, Ken, you wanted to say something also before?
Yeah, are you giving me control?
I'm giving you control.
I cannot share. Another participant has it. Who? Heather, you got the screen?
I don't know. Reflecting my limited technical capabilities.
Can I
no, there's nothing on there that says share.
Can they let me
Somebody took it.
share the screen or no?
Yeah.
And I think you're okay now.
I'm okay now. Okay, so Heather, great to have you here. I just want to say a few words about Heather. Meelan, thank you for that introduction. We all know, we may not know, but I know that Heather is not only a gifted surgeon, she is a tremendous educator. She is a scientist. She's the person who's helped clarify the concept of early appropriate care for the residents who are listening. She is an administrator running Metro Health Hospital there, the trauma service. She is a mentor to many up-and-coming orthopedic surgeons, a role model, and the immediate past president of the OTA. But even more so than that, she's a Badger and a Badger mom. So, Heather, this is for you. So there it is.
Oh, that was awesome.
F Michigan. Take it over.
Thank you so much for that really fun and most unusual introduction. I'm super excited to be here with you guys. And I'm glad I got to see a few of you last week at the meeting. It's been nice as we emerge from the pandemic to reestablish more physical in-person opportunities. So congrats on a really neat course, getting this all done today. I was really enthralled with the cases that were just shown. I was trying to refrain from giving you my 2 cents because you got a lot of better quality discussion going on there. And so thank you so much for the opportunity to talk with you a little bit this morning. This is a topic that I've become really passionate about over the last several years. And I think for all of us, as we're in practice, we realize that we try to perfect our skills as surgeons, as orthopedic surgeons. We spend a lot of years, a lot of time on it. And it's a wonderful and daunting challenge. And we continue to grow as surgeons. Each case we continue to learn. I think that was reflected amongst particularly that last section of case presentations. We answer questions, and whether we're looking at the clinical science, the basic science, but this aspect of recovery that I want to talk about today goes beyond just our traditional orthopedic skills. And I think in that realm, it can be sometimes off-putting to surgeons. I know I've felt that way before, like, gosh, I don't have time for this, or the system is really not set up to deal with this. So I can't go there right now. But you know what? I think we do need to go there. And I want to challenge you all as you're listening, and as I hope we can talk a little bit afterward or in the years to come, that there are ways that you can continue to grow beyond just the traditional orthopedic knowledge and skill set. And I think this is a way that we can make even more meaningful impact on many of our patients' lives. So having said that, I'm excited to be able to share with you a little bit today about the issues of recovery. So I am, for whatever reason, the slides aren't advancing. Okay, they're there. So disclosures are listed here. The one at the top is that our program is currently receiving funding from the state of Ohio. It's actually federal funding that comes to some states, not others. And this is specific to victims of crime, which pertains to many of our trauma patients and allows us to implement some of the recovery services that I'm going to speak about later on. And so our objectives are to look at some of the challenges to recovery as a whole. Some of these challenges include opioid dependence, which you guys I'm sure are well familiar with, mental illness, recidivism, topics that came up just even in those last case presentations. I'd like to talk a little bit beyond just those challenges, as we know they exist, but to speak to some ideas regarding interventions to enhance recovery and to improve patient education and engagement, and ultimately patient and provider satisfaction. So what do we know? Pre-existing mental illness is common. I mean, current literature suggests that it can be in up to almost half of our injured patients, depending on what center you work at. But I would argue it's probably even higher. And the pandemic has probably driven this up quite a bit more. Early data suggests that that has had a major impact on things as well. And that mental illness is going to predispose our patients to more pain and more catastrophizing. It's associated with poor social support, and ultimately it's going to reduce satisfaction of us as providers, but more importantly, patient satisfaction. Is going to prolong recovery. It's going to reduce the scope of recovery, result in more narcotic usage, more complications, worse outcomes, and then recidivism. We repeat the cycle. So not so good. And our trauma systems have become finely tuned, and there are variabilities, one community to the next, one state to the next. But I would argue that in the last 40 years, we've come a long way to develop pathways to improve pre-hospital care, hospital care, and even post-hospital rehabilitation. We've done quite well. And there are still ways to enhance this, but the area of recovery in terms of more of a multidisciplinary strategy to address mental illness, underlying substance abuse, and social challenges, we have not done very much. And so it's wide open. Do something a little yourself, or as a department, you can have a huge impact. When we think about the psychosocial consequences of trauma, who's really at risk? Well, this is, just a very, very simple retrospective study that Chris Flanagan, one of our recent grads who's doing his trauma fellowship right now, had put together. And we started looking at what was happening with our patients in terms of their opioid consumption, because this, of course, for the last several years has caught a lot of attention nationally, and rightfully so. Our population is slightly more male. Mean age in this case was 48 years. And these were all patients that were admitted with at least one operative orthopedic injury from the emergency department. About half of them were isolated injuries. And just in that group, almost 2/3 of them had a positive urine drug screen. This is not for items that were administered en route. About 20% of our patients were on opioids before this injury. So not so good. And that sets you up for more problems if you choose to ignore this and then go down the road and just treat that patient. I feel like we can't afford to do that. In our population, pre-injury substance use, be it tobacco, alcohol, or drugs, as are delineated in this bar graph, was associated with more narcotic consumption. And so if we look at the light blue bars, which denote those patients that ask for at least one narcotic refill after their surgery versus none in the white bars, the percentages on the y-axis here were much higher in all the groups. And so pre-injury substance use is a significant factor associated with more narcotic consumption. You say, well, yeah, I know that, I get that. Well, it helps us because it gives us a little bit of information as to what to look for. We identified that narcotic refills were also associated with patients of younger age, those who were intoxicated on presentation, and then the size of the discharge prescription. And that's an interesting one because we control that. Now, states have implemented a lot of prescribing laws. I know in Ohio, we have some for the last couple of years now. And our hospital and our orthopedic department have some new rules as well, which has created more standardization around this and has reduced our ability to refill narcotic prescriptions as frequently. And I think that that's a step in the right direction because it does not only reduce the amount of narcotics that are being dispensed, but it also pushes us to have more conversations with our patients about this issue. Interestingly, all of our work suggested that even any underlying demographic factors, the mechanism of injury, or patients who had multiple fractures and were treated surgically for multiple fractures versus maybe just one, there was no difference in their narcotic use. So it's really related to a lot of other things. And so I think that's an important takeaway. In terms of mental illness in the bigger scheme, beyond just the narcotic use, it's very common amongst our trauma patients. I mean, these are just some numbers here. This includes some of the work in our hospital, in our polytrauma patients, but a composite of work from other major trauma centers around the United States. And in the trauma population, worsening of pre-existing mental illness and new diagnoses of mental illness are exceedingly common, and they're often unaddressed. This is a polytrauma sample that we actually used from some of our EAC work, and we did some other studies with it, noting that this population is, again, heavily male, younger on average age. These were all patients that had one or more operative extremity injuries and were hospitalized for more than 3 days. Pre-existing mental illness was present in almost 40%, depression being the most common. None of it was related to injury severity. And orthopedic providers treating these patients were much less likely to identify and then to treat underlying mental illness. And so that's kind of sad. And I feel like, wow, it was actually worse than I thought. I figured it wouldn't be great. And this was disappointing because it was worse than I thought. Pre-existing mental illness was noted and treated in 69% of these polytrauma patients. But our orthopedic physicians, myself included, in this samples, this is residents and attendings, we only noted 10% of the pre-existing mental illness, knowing that that's probably less diagnosed than we knew. Meaning, patients aren't often going to disclose this, and so if we're not taking an accurate history, there's probably a fair amount of underdiagnosis going on top of that. So, as a department, we looked at that and thought, man, we got to really do better because we're not noting this, we're not connecting patients with providers, we're not even using the medications that they came into the hospital, we're not making sure they even stay on them. And that those things are really important. And those are relatively easy things to do now, especially with the electronic medical record. So paying attention to that and identifying that, and then trying to get patients connected with a mental health provider, whether it's rehab or clinical psychologists, psychiatrists, or maybe some other type of a support group or system, depending on their needs and how your hospital is configured. We know that mental illness is associated with complications. In our work, about 20% of the patients in this EAC sample had a complication, and those are early complications, meaning surgical site infections, pulmonary issues, thrombotic complications, and such. Not counting non-unions and things, it would actually probably be much more. 42% of these patients had pre-existing mental illness, again, depression being the most common. And all of that was associated with poor functional outcome scores and worse patient satisfaction. So you're like, well, yeah, sure, of course it is. Yeah, of course it is. And so this is just giving us some objective information as to the frequency of how often this occurs, what little we've done about it, and how much impact it's having on their ultimate function, both physically, mentally, and then their satisfaction scores. PTSD is a subset of this. We got interested in this in our group a few years back, recognizing that the American College of Surgeons says that all trauma centers should be doing some screening for PTSD. Now, this hasn't been very well enforced. And so I've heard from the American College of Surgeons that they're going to start paying a little bit more attention to this, in that they're saying that you should have screening now. Many places don't, or they don't routinely screen. We decided, well, we should be screening because we weren't very adherent to that recommendation. And so we started screening in our outpatient orthopedic trauma clinics and our general trauma clinics during the first post-hospital visit. And the first 452 that we screened, about a quarter of them were positive for PTSD off of this survey. Now, this survey is just a one-pager. It's very easy. It's written at about a 6th grade reading level. So there are patients who are literate. It is available in other languages. But even our personnel who were rooming the patients could help them to complete it. And so we had a very high completion rate, which was good. And it gave us this information about who's at risk. Younger people, again, tend to be at risk. And then certain mechanisms, pedestrians who were struck by motor vehicles. That's not too surprising. You know, you guys know from your practice, that's an area where you're going to see more PTSD. And then those who were victims of crime. And in urban Cleveland at the public hospital where I work, sadly, gunshot trauma is very common. It's gotten actually much worse the past couple of years. The people who are a victim of crime, usually ballistic assaults, sometimes other physical assaults, are very likely to screen positive for PTSD. So this really opened our eyes that we were not only not diagnosing it very often, we were also not helping these people into treatment. I'm going to show you some data in a very short period of time how we were able to change that. And ultimately, about half of these people now are plugged into formal counseling and other programs. We're still working on that, but we've made some progress in a short period of time. Our team noticed that a lot of the patients they were meeting, when I say our team, more information to come, includes counselors and other people who are clued in on these things, speculated that patients who thought they were going to die during their injury, you know how people will say that to you, sometimes I thought I was going to die, and this is what happened, almost always screen positive for PTSD. In fact, this is a really easy takeaway for you in your practice. Residents who are on today, this is very simple. We actually just got this published in JAOS. Patients who said, I thought I would die, and we've added it at the bottom of our PTSD questionnaire. When they did say this, they were 13 times more likely to develop PTSD. And so pretty much if you just do one extra question in clinic, or you pick that up even without asking it, that person probably needs help. And so if there's a way to get them plugged in with a counselor or with other mental health resources, I think it would be a really good move on your part. More to come. So just to summarize thus far, mental illness we know is associated with more complications, longer hospital stays, more readmissions, more pain, greater narcotic usage, more self-reported physical disability and mental disability, and less patient satisfaction. Not so hot. And it's also associated with recidivism. Now, we started about 12 years ago looking at recidivism in our trauma patients because you have these people that kind of keep coming back, and it's sad and it's frustrating. And I always feel bad, like, man, the guy came back again. This is what's going on. Well, again, not so good. This group of patients that we looked at for recidivism were all people who had been admitted with spinal, pelvic, acetabular, femur, or tibial fracture requiring surgeries. They all had some type of an orthopedic inpatient stay. And then we went back and looked at them for re-presentation to the emergency department and or readmission to the hospital. And we noticed that within less than 3 years, that was the mean time, almost 20% of them had represented with new injuries. So I feel like that's quite abysmal from a public health standpoint. And of these recidivists representing with the new injuries, almost a quarter of them were admitted to the hospital and requiring inpatient care. A small percentage of those here at that bullet point at the bottom, 8.2%, were recurrent recidivists, meaning that in that period of time, they had already come back with more than one injury. So some of this is very self-destructive behaviors. Other ones are just social circumstances. Sometimes there's people who are victims of crime or abuse. And so that involving your team of care managers, social workers can be helpful at rooting out some of these issues that, again, I think you probably see this and your first reaction is like, geez, that's not good. I don't have time for that. Like, who would I even call? How could I get help? And I totally understand that because it is overwhelming and your clinic is busy and you're an hour behind and then this happens. What do? It's easier to just take care of their tibia than to delve into all of this stuff. But I think if we all start to increase our expectations of ourselves and of our colleagues and of our hospital systems, we can slowly improve upon these statistics. So we know that substance abuse is more common amongst recidivists. If you look at alcohol, recreational drug use, even tobacco, and mental illness is also more likely. And amongst those, particularly in that repeat recidivist group, depression, bipolar disorder, and suicidal ideations were all more common. We've actually kind of been studying this on an ongoing basis. And so I don't have new data specific to patients during the whole COVID-19 pandemic, but it's without a real in-depth analysis, much worse, as you may well expect. So what can we do? Some basic intervention strategies, as I already alluded to, assessing baseline medications and social habits and mental illness is a start. We're all taking the history, getting to know the patient. Just make a note of these things and just address it with them and then say to your, whoever's on your team, or to the trauma team or the case manager following the patient, hey, this person has major mental health challenges. We really need to get them plugged in. So just to raise the issue and then try to engage those around you to help. Identify those patients at risk for chronic pain and prolonged opioid use, the ones that have some substance abuse history, the ones that have a mechanism suggestive of PTSD. Development and communicate a prescribing policy. Now, I said before that in Ohio, we have some laws, but before we did that, our department implemented a rule that we would not administer any more narcotic medication to our patients 6 weeks after the surgery. And so when you look at it, you go, well, there's always a few that need something a little more. Do they? They do, then there's probably something not quite right going on there. And so if you have a policy right now, we are limited in Ohio. We can only give a 1 week prescription of any narcotic medicine at a time. And then within 3 months, it's noted that those people should be transferred to some type of a pain management specialist or be completely off it. And so there's a statewide place where you have to log in all of your narcotic scripts and you have to check in there what they've received and sign off on it. So it does slow you down a little bit in terms of documentation. But even the 6 week rule that we had at our department was really helpful because you get the people that kind of are shopping around and come back and say, hey, we have a policy that we don't give it out, but let's take a deeper look. What's still causing your pain? Are there some other things that we could try? Can you get them connected with some type of a counselor? Do they have other underlying social recreational habits that need to be addressed? So it's just another point of conversation. If we think about the prescribing pattern associated with long-term narcotic use, this has been looked at in a lot of literature. I picked this study just because it's a very large one, and you look at who becomes long-term users. Well, there's a small number of them, and it's associated more often with longer-acting opioids, which I think have come under scrutiny a lot the past few years and are now prescribed less often or maybe not at all by many of us. And the other thing is that when there's multiple prescribers involved, that's a problem. And so again, you could do this, curtail the usage just by having a single prescriber policy within your department. Have policies where on nights and weekends, no other drugs are going to be given out or whatever it may take. But just a very basic change in practice with simple education of your team, I think can make a difference and improve care for our patients because we're not going to keep feeding into a habit that's causing them harm. This is an interesting study that was done by the guys at the University of Utah, and preoperative counseling, which didn't take all that long. When I say counseling, it sounds really complicated. Like we're going to bring someone in and we're going to do this big intervention. No, it was really simple. All they did was say, hey, if you were in the preoperative counseling group, we're going to try to help you to get off your narcotics. I want you to think about why you're taking it. Do you need it? Can you cut back? So it added maybe a half a minute to their whole conversation. So that was the counseling group versus just the control group where they went status quo. They found that within 6 weeks, the people who were still on narcotics were much less if they had had that little tiny bit of preoperative counseling. So it doesn't take much. These are just simple things that you can do, tricks you can impart into your own practice if you're not doing something like that already. Multimodal pain management. You've been hearing more about this the past few years. This is obviously a nice strategy because there's a lot of medications. I know when I went to medical school or when I was in surgical training, we didn't really talk about, or it was NSAIDs are taboo because they're going to delay fracture healing. I think the whole science around that has changed. And while there is some effect of NSAIDs and potentially Tylenol on the initial healing of the fracture, it's probably not as much as we think. And a lot of times these medications can be a useful adjunct, particularly in those first days and weeks postoperatively, by affecting the perception of pain by mediating its diminution at different steps along the pathway. So using different families of medications, gabapentinoids, NSAIDs come to mind. There are a variety of other ones that may be less familiar to you, but just kind of keeping this simple, as well as using more regional anesthesia and local blocks, particularly in your patients if they're not at risk for compartment syndrome after surgery. This is a nice way to go. It's going to help them to wake up and have their pain control much better. And that whole aspect of preemptive analgesia that has been shown to affect things is pretty easy to do. And your pain, your anesthesia partners like it, the nurses like it. Most of the patients go for it. Most of them aren't afraid. And then it helps them if you're doing an outpatient or an observation case to get them home while they're still more comfortable, I think is good. But counseling them about starting their oral medications while that block is still underway is very important, so they don't have it wear off and then suddenly be very frightened and have that amplified pain response, which is partially because of the acceleration of the pain drive, but also because of their own anxiety and not understanding. So there's an element of communication here, which I think we could all do better with. So if you think of strategies, I mentioned already about screening for pre-existing substance abuse and other mental illness, screening for PTSD, identifying and treating pre-existing mental illness, and then looking for new mental illness, ultimately engaging and educating patients. And I want to shift gears a little bit here and kind of get into some other ways, some other comprehensive forms of intervention that may be appealing to you in your practice. If we look at what's called the Trauma Survivors Network, I'm curious how many of you guys are familiar with this at all. I think that depending on where you've worked and maybe in your hospitals, it's a program that was developed about 10 years ago by the American Trauma Society and Johns Hopkins. And it involves a set of online resources. And you could look it up right now. If you put in Trauma Survivors Network, you'll come to a webpage that looks something like this. And there's various programs on there. There's some materials that can be downloaded in PDFs. You can have an educational handbook about injury and about recovery for your patients and families. And there's programs online like chat rooms and things that patients can engage in. Honestly, most of my patients aren't super sophisticated where they would go to this and just be like, I'm going to go in a chat room now with some strangers. I mean, I would have to really sit with them and encourage it. But the idea that this is there was predated by some information that kind of arose from what's known as a Leucht study. And so this is kind of important. And so some of the senior residents probably know a little bit about the Leucht study. If you don't, this is something that all orthopedic surgeons should be aware of. Back in the mid and late 90s, there was something called the Leucht study. And it was the Lower Extremity Assessment Project, LEAP. And the idea was that for patients with limb-threatening lower extremity trauma, specifically open fractures, dislocations, articular surface, and I'm not going to get into the nitty-gritty of the details, but there were 8 centers in the United States that prospectively looked at patients that presented with these injuries that could be treated primarily with amputation or with attempted limb salvage. And there were about 500 patients over a period of a few years in this study, several dozen of which ended up with amputation either as primary treatment or as a treatment of infectious or other complications. They wanted to know, is limb salvage feasible or better than just doing a primary amputation? It was thought that we could look at some patient and injury factors and really determine, like, if we knew someone's going to be better off, they were going to ultimately end up with an amputation, then we could just go there. And so, as you know, many of these scoring systems, objective measures of determining this have not panned out. And that was one of the findings of the LEAP study. Like, well, we can't really just look at the injury itself, the x-ray, and say, oh yeah, we should do an amputation. Now, sometimes it's completely a cut and there's not a salvage option. And that's not what I'm talking about. I'm talking about those ones where it's kind of either way. Interestingly, the whole LEAP thing, the predictors of disability weren't even so much the injury. There were these other things. And so guys that have been in practice for a while, you go, yeah, I know this. And I know this not because of LEAP. I know this from my experience. The risk factors for disability didn't matter whether your leg was salvaged or not. It mattered if they were having chronic pain, if they had depression, if they had anxiety. And then on the flip side of that, there were these protective factors. What does that mean? Well, social support. So who has family members, friends, people they can rely on to help them, to support them. Maybe it's, giving them a ride. Maybe it's helping them with food and with material needs. Maybe it's helping them mentally with their own coping, as well as self-efficacy. This idea that you can overcome, you have some resilience, you have some ability to heal. Those factors were protective, and patients who had those factors were much less likely to be disabled as determined by various functional outcomes measures, as well as physical performance measures like timed walking tests and things such as that. So it's interesting, after all that work on LEAP, what we found out is that none of the scoring systems to predict whether amputation or salvage would be the end game and or more successful, none of that came to fruition. But this was a key takeaway that ultimately led that same group of investigators and others through the Metric Research Consortium to start a study to look at ways that we may be able to improve social support systems and self-efficacy of our patients going forward. It led to a prospective study called Trauma Collaborative Care, where 12 centers, 6 control site and 6 intervention sites were given some resources to do this. And so we were one of the sites that got those resources back in 2013. And we called those resources trauma recovery services. So the research itself wasn't that complicated. It was really grant money that was used to allow us to hire a recovery coach. You go, what the heck is a recovery coach? What does that mean? Well, I kind of said that too, and I wasn't really sure. I interviewed like 13 people before I found the person that I thought was right for the job. And it really was just my own intuition. And fortunately, we were able to learn a little bit as we go. But the idea was that we would have a point person at our hospital who could provide education, who had some counseling skills for patients and families to help them to do some coping. We developed what was called a peer survivor mentorship program. So peer mentors are trauma patients from in the past, and they volunteer and they come back and they talk to patients and families, and they say, yeah, I remember when I couldn't walk for 3 months and I was in a wheelchair. It was really hard getting around the house. And those peer mentors have really so much credibility with any new patient coming in that we don't have, because we're not injured right now, and most of us haven't been in the past. And so they have a level of understanding and respect with our patients, irrespective of even things like age, race, type of injury. They all matter too, but they matter less than this sort of street credibility of being in that injured group. So peer mentors are an important phenomenon, and we implemented the peer program. I'll tell you a little bit more about it in a minute, but that's one aspect of what we call recovery services. We also have support groups, which kind of wax and wane. A lot of times initially patients or family members like have support groups where there's just a forum where they can come and talk. And some people really gravitate to that. Many don't, and many of them don't use it long term. We have personal coaching and counseling. And when patients have really full-on mental illness that needs higher level attention, we can access clinical psychologists and psychiatrists for management of those mental health needs and for medication when indicated. We have a PTSD screening program, which is pretty basic, and I mentioned that earlier. And then more recently, we've started things with our recovery coaches, even doing some medical staff debriefing. If we have a big trauma, say 5 patients came in simultaneously with gunshots and 2 of them died, and there's some physicians, people are pretty stressed out to go back and look at it, our coaches will meet with the group and help with the debrief that goes on. So those things have been nice adjuncts that have flown out of having this programming. We've also been doing some education in our community and for other hospitals in our community. And we have some resources that are specific to people who are victims of crime, who face other types of social challenges, as well as navigating the legal system. So some of the milestones of our programming over the last 7 years is that we've now, I think it's approaching 10,000 patients that we've had direct contact with, and about close to 6,000 peer visits to those survivors. Like this guy in this picture, he's a trauma survivor, and he's going to visit someone else. And it's interesting because the patients that get the visits really appreciate it on average. Some of them are kind of like, yeah, I don't know if it really, yeah, you can have somebody come by, that's okay. But most of them are really grateful that somebody came by. Like it does change their perspective. And what else we've noticed is that those peers that come in and do this, some of them have not been able to return to their prior work at all. Some of them cannot work physically or recreate in their same physical capacities. They find a sense of purpose and direction that's been really powerful. And that's one of the things we're going to start to write about a little bit too, to objectively measure that. In addition to that, we do the PTSD screening that I mentioned. And there's been a pretty big escalation in the services available. This just gives you an idea. This is a publication that we had put out, the Journal of Trauma and Acute Care, in last year, in terms of the number of trauma activations we saw over a 5-year period. And during that time, those 2 bullet points at the bottom, our recovery services were only being presented really to 7% of our patients when we first started, because we had so little resources available. We were completely spread thin. But now almost 2/3 of our admitted patients are receiving and using resources. We do have some patients that decline, any services or any type of education at all. It happens, and we try to continue to revisit that to try to improve their understanding and engagement. But this is where we are now, just to give you an idea. And the effectiveness of it at our hospital has been really profound, and it's changed and improved quite a bit over time. This data that I'm going to show you relates back to when we first started. We hypothesized that the patients who were exposed to the recovery services would feel more satisfied and feel more likely that they would recover. So you go, well, how do you measure that? This is actually information on patients that were before we had any services, so 139 of them, patients that never accessed or even heard about our services when we first started. So they had no contact. That was one other control group. And then an intervention group of over 200 people. And when we did this study, we went back and matched them for age, type of injury, type of mechanism, as well as gender. And we found that overall the satisfaction on a Likert scale of 1 to 5, 5 being highly satisfied and 1 being highly unsatisfied, the recovery services patients were on average highly satisfied. So that's good. But they also felt more confident about their recovery. So look at that last line down below, 3.7 versus 3.0, which was significant. And so they felt more likely that they would recover. So it's an idea that we're empowering them that they would recover, basically just by being exposed to any of the program elements. We also found that when we survey using Press-Ganey type questions, which many of you guys are familiar with, I don't know what surveys your hospitals are using right now, but it's obviously a common one, faulty as though it may be. Some of the questions here at the bottom I listed were ones that related to satisfaction with their care. And again, their overall rating of the care and their likelihood of recovery was what this paper focused on. And we found also that after multiple linear regression to root out some of the confounders I mentioned on the prior study, any resource utilization from the recovery services team was associated with higher ratings of care. This model accounted for these variations in demographics, substance abuse, pre-existing psychiatric illness, all of that stuff. And so this is a real phenomenon. Patients feel more engaged and more able to recover and overall more satisfied with their care. This caught the attention of our administration. And so I said, well, this is why I've been bugging you guys for the last 5 years, and we need more resources. And so if you're, as hospital administration, if you put resources in to improve patients' education, engagement, overall mental health, in addition to the physical health that we're already working on pretty hard, it's going to go a long way to improving your satisfaction scores. And that's something that a lot of the administrators like to brag about. So it's good. Other issues. Poor recall is something that is rampant amongst trauma patients, regardless of their background and mechanism of injury. I know this probably drives you crazy. You go and you round on them for the third day in a row, and they're like, "Who are you? What do it? Oh, I'm having surgery again. What do you mean I have to have another surgery?" And you know that you've spoken to them about this before, and as have other members of their team. And it's frustrating, and it's easy to kind of get upset with them, upset with yourself. Like, what can I do? They don't even remember what I'm talking about. These printed discharge education materials are confusing. Most of them are not written at a level that our patients would even understand if they read it. Probably they're not reading it. They're probably throwing it away or not even recognizing that it's there. And so this is something that we're working on quite a bit now. We actually have a new thing where it's like a teach back. And so we have 2 people from our recovery team who hit up all of the post-op patients, either post-op day 1 or 2, who have had some type of fixation or orthopedic surgery procedure for which they are admitted to the hospital. And they walk by and they introduce themselves and say, "Hey, I'm just here to help you with education. I understand that Dr. Smith repaired your leg yesterday and you have a rod in your thigh bone now. It's okay for you to walk on it. Did you know that? Okay, what's the name of their thigh bone?" This literally takes about 3 to 5 minutes. And the counselor asks them back, "Okay, well, can you tell me again, which bone did you break?" And make sure that the patient can answer those questions. And before we did this spring and this summer, we ran a control sample of about 300 patients, and about a quarter of them were actually able to answer those questions correctly during their first post-op visit. But since we started doing this, almost all of them know. And you might say, well, that's kind of silly. I mean, that you operate on their leg, they're getting their sutures out. They know that it's there. But beyond just identifying the bone that they broke, recognizing that they have a protected weight bearing recommendation or not, and how long is it going to take to heal, and the fact that they knew the answers to those things, they weren't just wondering what's going on, I think is going to go a long way to improving patient adherence to the recommendations we give them, as well as their recovery and their sense of comfort around what's going on with their legs. So this is just an ongoing project that we have that I think, again, is going to be something that's rather easy to do. It doesn't require a lot of time. It doesn't require a lot of resources, but can really improve patient satisfaction and engagement. Another thing that we started was just a simple post-discharge follow-up phone call, and this was published last year in JAS. Before we had any of these services in place, just a little over half of our patients actually even attended their first post-operative visit, which is pretty pathetic. It's really not very good. If they're not even coming back to clinic, who knows what's going on? And you think about these people when you're driving home and you go, whoa, what about that guy with that bad open tibia from 3 weeks ago? Yeah, why did he not come back? Where are they? We all have these patients. What we did was we started making sure that we had an active functional phone number for them and a backup one when possible. And then our team would call, and it's the day after they were discharged from the hospital, contact them and say, hey, you made it home okay? Is there anything going on that you're struggling with? Yeah, you have a follow-up appointment on November 2nd. Do you have transportation to get there? These are just some basic things, because transportation is a barrier, not just the distance, but oftentimes a vehicle and the time and that sort of thing. So we try to help with that. But we've been able to hugely improve just the attendance at our clinic visits. It's gone up. Now it's closer to like 80 to 90%, which again, there's still room for improvement there. I'm not getting around that. But this is something that we've made a lot of headway on with a really simple intervention. What we haven't measured that I suspect goes with this is that patients feel better. They feel like, wow, somebody cares that they're calling me on the phone and checking that I'm okay. So just that whole idea that we're concerned about their well-being, because we are. We also have an app. This is a really simple thing. You guys can load up this QR code. We presented on this at the OTA meeting last week, and then we presented on it last year as well as the development of the app and like who's using it. But we've had basically this information involves simple information specific to different injuries, and it also has some generic information about DVT prophylaxis and frequently asked questions, a little bit about nutrition, bone health, things like that. There's some simple exercises where we actually refer to some of the Academy's materials on range of motion recovery exercises for shoulder, hip, knee, ankle, whatever it is. All very basic and all written by physicians. So I wrote a fair amount of it. A couple of my partners wrote it, including some of the spine information, some of the hand and upper extremity information. It's really simple. But what we found is that most patients feel like the app has been helpful, and they have a dramatically better idea about, again, what type of fracture they have, what their weight bearing status is. So overall, their own health literacy has been shown to be significantly changed. And that was the most recent part that we presented last week. Again, it's really simple. And so we shared this with several of our fellows who are practicing in different parts of the country, and some of them are practicing in the UK. And they found kind of the same thing. And so we've done some multi-center work on this. But basically, the information on here, you could take it and you could tailor some of it to your own site. This is just very generic. It's not specific to my hospital. It just helps our patients have a really easy way of accessing accurate information. The OTA also has a patient education site. That site has a lot more detail on it. I feel like for patients that have very limited literacy, that might be overwhelming to have that much information. The text is much longer, the sentences are much longer. But for patients that are a little bit more sophisticated, I'll usually refer them to the OTA site because they like to have slightly more detail in their information. So running down to the end here, I'd mentioned about the peer mentorship program earlier. We've been studying this a little bit in terms of looking at our recidivism. I told you about the abysmal 20% recidivism that we had before any of these things were implemented. And so last year, we started taking a look at recidivism since that time. And we looked at almost 1,000 polytrauma patients with the same injury criteria as our original recidivism study. And what we found was that we are now down to 14%, which is significantly lower than the 19+% that we observed, just 10 years ago. But what we did notice is that 13% of our recovery services users become recidivists. Because the sample's so large, it's actually less likely that the patients who engage with the services will demonstrate recidivism. And again, that means representation to our emergency department with a new injury or illness, not related to their first trauma. But I thought that the bullet point here, fourth from the top, patients engaging in 2 or more peer visits had a lower rate of recidivism, significantly lower, was really profound. And it makes sense. Those people, there's probably some selection bias there because they're choosing to interact with that peer mentor versus the ones that don't. But when they do that, when they interact with the peer mentor team, they're much less likely to become a trauma recidivist. And so we feel like that's really huge too. I mean, we're helping that life, and we're also helping the burden of all the excessive healthcare on our hospital, which is a huge chunk of the county's budget. So I'm gonna wind down here, hoping to burn you all out, but I really appreciate the opportunity to talk about this because baseline mental illness is extremely frequent in our trauma patients. And I think for any of our orthopedic patients, irrespective of your subspecialty, recidivism is associated with mental illness and with substance abuse. And all of these things are associated with more perceived pain, more opioid usage, more perceived disability, and less patient satisfaction. So implementing some recovery services are really helpful. And it doesn't have to be an all or none phenomenon. Figure out which patients are at risk. We know that those people that had pre-existing substance abuse, including opioids or pre-existing mental illness of other types, are going to be at risk. We also know about some of the patients specifically at risk for PTSD based on mechanism, as are listed here. And then the ones that say, I thought I would die, they probably really need help. So think of maybe 1 or 2 things that you can do as an individual or maybe as a group in the coming weeks and months and add it to your repertoire. Try it. I encourage you that you will probably have better satisfaction getting through your clinic, your work week, and your patients are going to clearly have better satisfaction and more self-efficacy with a better recovery. I just want to acknowledge the DoD at Metric, which provided us with some initial funding back in 2013 for the first 2 years getting us started. We've also received grant funding for operations and for research from Northern Ohio Trauma System, from our own office patient experience from the state of Ohio, and then many individuals who have donated a lot of their time, their talent, and their money. Thank you so much for your attention. And then I ask, can you guys teach me? Tell me what you're doing, because I think that that's the main way is for us to, keep exchanging ideas on this stuff, and that's how we're going to get better.
That was great. That was really great, Heather. And this has clearly been a life's work for you. We just actually started with, in our geriatric trauma program, a dedicated social worker who is basically there to guide patients and their families through the process of the post-injury recovery and act as a liaison between us and the patient. And we're just starting that up, but we think it's a great idea. I have a question for you. How do you get the former patients to get involved in the program? Do you ask them, or do they kind of know about it and come to you and say, "Hey, I'd love. How do I help?" That kind of thing.
I'm glad you asked that. I should have said something when I was presenting. So thank you for raising that. Basically, when we first started out, I had noticed anecdotally one of the patients that I had that was going to be a new amputation, and had just booked him for that after saying, hey, your injury is really not salvageable. You're going to need an amputation, and I'm sorry, but we should try to do this sooner than later. Let's try in 2 days from now. I went back to go check on him, and he had connected in the hallway with a patient of one of my partners who was a former Ilizarov patient that had chronic osteomyelitis, that had gone through and had an amputation and was there too. And actually they talked, and he said, oh, that guy had an amputation and he's okay. He said it doesn't hurt more. It's just, and I was like, whoa, that was weird. Kind of random, unexpected acquaintance. And this patient told me, if you ever have a person in the hospital that is losing their leg too, I'd be glad to talk with them about it once I learn. And I thought, man, that's really simple. Why didn't I think of that? And patients naturally want to do this. And I think that's been shown in numerous settings. If you look at breast cancer survivors, if you look at in the military, at trauma patients. And so this model of peer mentorship and advice is very powerful. It was happening a little bit on its own. But after that incident, we formalized it and we started an amputee support group for patients with limb salvage and or amputation. And so one of our nurses from the clinic was just kind of doing it, and we found some time, and I would buy them cookies and beverages, and they would meet like every 2 months. So that was in the background. And then when the metric study came about and they said, hey, we're going to try to do this thing called peer mentorship, I was like, oh, we're sort of doing that, but it's not super organized. I didn't spend personally a lot of time on it, but I could think of patients who helped with the amputee group. And so we contacted a few of them to say, hey, would you like to be part of something a little more organized, where we would ask you to come in, say, once a week or a couple times a month, just to meet some patients for a couple hours? They were all really excited to be asked. And I think that's been something that we've noticed time and again. And so I kind of went through my brain, like, what patients do I have who had a reasonably substantial injury, who are socially level and capable of talking with others, who we could train them to come in and do it. And when I would ask them, they would almost always say yes. And the reason they would say no often was because of transportation or logistical issues. It wasn't just that they didn't want to do it. But now we ask our general trauma providers and all of our orthopedic providers like twice a year, hey, we're going to be starting a new training group for new incoming peer mentors, because we do a little training thing where they come to 2 sessions to learn about the program. And most of them have been through a trauma at our hospital, so they already know about the program now. So that's easier because they get it. And then they have to do like a little medical screening thing with our volunteer services where they show their vaccines are up to date, such as that. But then they go out with a trained and experienced peer for their first 2 days, and then we let them go. And one of our coaches supervises and sort of makes the peer assignments for the day, and she'll debrief with them and just make sure that nothing unusual happened in the rooms. Not a perfect thing. Sometimes there's personalities that don't get along or something that didn't turn out ideally, but we have a means of documenting that and managing that. And that's really not been the problem. I have patients who have come back and said, what really did it for me was when that guy came into my room and he told me about how he got an infection in his leg too, and how he had to go back to the OR. And it made me feel like, yeah, I wish it wouldn't have happened, but now that it happened, I'm going to be okay. And this is what I got to do. And those little stories now happen all the time. And a subset of those patients will say, can I be a peer too? Most of them want to do it right away and they're not even healed yet. And so we've put down some rules about letting them progress through their own recovery before we formally invite them back. But it's something that once you have a few in place, the patients recognize it, and some of them self-select and they want to come back. Peers do outgrow the program. Sometimes they get to different points in their life where they're moving away, or they're taking up new vocational opportunities and they cannot dedicate the time to the program, so they move on. But we haven't had anybody that's just left because they didn't like it. I mean, it's just, I can honestly say that. And I mean, I can't say that about other things, other groups that I work on, other teams that I'm on, even with other physicians, because we all have likes and dislikes when we move on. But for this, it's something that the patients and families appreciate, and something that the peers appreciate. One other thing that I didn't expect was that now a lot of nurses are really into this, and they'll call. We actually have a button in our Epic where any provider can contact the recovery services team. So 24 hours a day, there's somebody checking this. Like if there's a new consult request and they rate, is it emergent? Like you really want somebody to come right away. There's a lot of angst. Urgent in the next shift, or not urgent, then it would be in the next 24 hours. So it would be some kind of a contact by a coach and or a peer. Because our peers come in now 7 days a week. We'll have 1 or maybe up to 4 of them a day, because we have quite a lot since we've been doing this for a while. But then the nurses will sometimes recommend patients to be peers. And I feel like when a patient says, somebody told me that I'd be a good peer, it's like, wow, they've reached a new level of recovery. And that to them is a big accomplishment. And it's all these little things that you wouldn't think would make a huge difference, but they do. They make a huge difference for that individual. And then that individual pays it forward to countless others along the path. So it's something that it's a little bit of a logistical thing to get started, but once it does, it kind of feeds itself. And so we now have enough information, data, that I think most hospital administrators would look at this and say, you know, you don't need much of a budget to get this off the ground. And it's not a big liability problem. It just requires a little bit of organization and a little bit of documentation, but it's pretty easy. Sorry, it's kind of a long answer.
I think it was the answer we needed, though, because that's, you know, I mean, you've been through this and you have the understanding of it. And it's interesting you said about the amputation patients, because I've had that same experience with a couple of my amputees where they say, you know, I'd be really happy to talk to someone. And I've tried to set it up sort of, you know, in a much more informal way. And it never seems to work, and the patient cancels, or, you know, something happens. But, you know, I never really thought to formalize it like that.
Yeah. It's good and bad. The informal thing, very hit or miss.
Yes.
When it happens, that's wonderful, but super hit or miss.
My experience has been much more on the miss than the hit, unfortunately.
Yeah. Understandably. Well, the other thing I should say is that we've, you know, I'm fortunate to work with a team of really wonderful counselors. And one of the ways that we grew our program was we connected with some of the local community colleges who have people who are in their master's program and they need certain numbers of service hours or master's projects. And we've latched on. So we take interns and they help us, and they want to get these types of experiences dealing with patients and families. So it's really valuable. And so we've had both paid and unpaid internships for 6 months, a year, sometimes 2 years. And some of those people ultimately become employees with our system. So there's ways that you can tap into people in your community who are excited about having these experiences and really committed to contributing. And I've also found that most of the people that we've brought on have had little or no formal medical or trauma experience, for that matter. You know, the first coach I hired, her background was in schools and helping with school counseling. And she had also done some work for the state of Ohio with Child and Family Services, dealing with issues of abuse and neglect. And so she knew about system issues and some of the legal issues around it, but she had no experience specific to trauma in a you know, orthopedic trauma or general trauma standpoint. And so it's interesting because I think that it was actually valuable for us to bring in people from the outside. Many of the people who applied for the job were nurses who were trauma nurses and looking for a different change of pace. And I think that could work, but we found it helpful to grow from the outside. And our team is also available just to do consultation. We're right now consulting with 5 other hospitals in the United States and helping them to develop some programming. And 2 of those groups seem to have a lot of buy-in, where one of them, the COO and very higher level people in their health system, were actually on some of our calls as a group. And I'm often not on those calls. I usually come on as, say, want to be the physician champion, because it's nice if you can have a couple of champions who are providing trauma care, pairing with administration, counseling, patient experience officers, or whatever the recipe may be in terms of having a little bit of funding. But you don't need a ton of money to get this going. The economic return, which is something we're trying to measure right now and we'll have for you soon, is huge. Because you look at, the patients aren't going to be readmitted to the hospital if they're actually going to follow for their appointments. You're going to have lower complication rates, better satisfaction. I mean, it pays for itself quickly. And so we're working to try to look at ways to allow other programs to get things started. Anyway. Thank you for all this opportunity. I mean, you guys have a really neat program that you set up for today. I was so honored, and I still am, just to be able to be a part of it. To see some of you guys last week was really fun, but to interact like this is even better. And so thank you for inviting me.
Thanks for being here, Heather.
Thanks for a great talk.
Yeah.
And thanks for your service as OTA president last year.
You're welcome. It's such a neat opportunity. You guys all contribute. I think it's nice that we can all work with a group of really committed people. I think that's been the greatest honor for me. Hope you guys have a good rest of your weekend.
You as well.
Thanks again, Heather.
You too. Thank you.
Thanks.
All right, everyone. Well, thanks everyone and all our attendees for joining the 4th annual Howard Rosen Memorial Tri-State Trauma Symposium. We really appreciate everyone's attendance. We hope you all took a little bit of something away from this. To round this up, some housekeeping items. Remember to claim your CME credits to the NYU CME app. There'll be a link available on the app for you to go and do that. If you have any questions, you can always email me or Dr. Patel on the back end, and we can always reach out to the attendings for you, or you can email the attendings directly. They're all easily accessible through their NYU email address. Thank you again, everyone, for joining, and we look forward to another riveting talk next year.